Good morning, everyone. Good morning. I'm great, thank you. Wonderful to see folks in person as well. So welcome to everyone to the University of Ottawa Heart Institute Women's Heart Health Education Day for Healthcare Professionals. My name is Bonnie Quinlan, and I'm the Director of Prevention and Rehabilitation. And I will be co-moderating this amazing day today with my colleague, Sandra Wong, who is our Regional Clinical Nurse Educator. So welcome, everyone. I'm very pleased to say that we have almost 300 participants registered from across Canada and beyond for this unique hybrid learning event, including representation from Saskatoon, Newfoundland, British Columbia, Glasgow, Scotland, and Melbourne, Australia. This is amazing. Wow. This educational opportunity today, focusing on the unique health aspects and needs of women, is a pilot project, part of a larger initiative by the Canadian Women's Heart Health Alliance, seeking to educate healthcare providers across Canada on women's heart health. I would like to start the day with our land acknowledgement. We pay respect to the Algonquin people, who are traditional guardians of this land. We acknowledge their long-standing relationship with this territory, which remains unceded. We pay respect to all Indigenous people in this region from all nations across Canada who call Ottawa home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. Before we begin the day with our opening speakers, I would like to run through just a few details of the day. There will be 2 to 5 minutes for questions at the end of every session. If we don't have time to get to your question, please post it in the chat and just indicate who the question is for, and we will follow up with a response as quickly as we can. I hope everyone has had a chance to review the agenda for the day, which includes our speakers as well as times for breaks and lunch. So those of you who are in person, please ensure that you do have a chance to pick up some breakfast this morning and coffee over to the side of the auditorium. A very special thanks today to our event sponsors. So Amgen, Dexcom, Bios Medical, Novo Nordisk, and the Heart Institute Foundation. So we really appreciate their generosity in making this event happen. You'll find the sponsors actually have set up tables outside the auditorium. So if you'd like a little bit more information and like to browse, they have some great things for you to look at. Thank you to everyone as well for completing the pre-event knowledge quiz. We will be repeating this quiz towards the end of the day, and it also is going to include an overall evaluation of the day. We really appreciate your feedback on this because it will help us to improve future events. When you complete the quiz, your name is actually put into a draw for great prizes. Sandra and I will be drawing prizes and names throughout the day. So the prizes that we're giving out is actually merchandise from the Canadian Women's Heart Health Alliance. And I'm sure for those of you in person, you've noticed that they have a table outside the auditorium if you'd like to purchase additional items. Sandra as well, I believe, is putting the link to their online merchandise store as well. So really, really lovely things if you'd like to have a look. So welcome again. It's going to be a fantastic day. I'm very excited and thank everyone for attending in person and right across Canada and beyond. So I'm now going to turn it over to Sandra to introduce our opening speakers.
Thanks so much, Bonnie. It is my pleasure to welcome Bonnie Bose and Kara Murfitt. Bonnie Bose is the Vice President and Chief Nursing Officer of Quality, Risk, and Health Information, the Division of Prevention and Rehabilitation, Women's Heart Health, Clinic, the Nursing Clinical Educators, as well as the Canadian Alliance for Women's Heart Health. Her ongoing expert leadership and support is one of the foremost reasons for this event and all the changes made within the Institute to support women's heart health. Kara is the nurse educator for our cardiac surgery and cardiology units at the Heart Institute. Kara's role as a nurse educator is instrumental in the development of this pilot project and the rollout of staff education in women's heart health. Bonnie and Kara will share about the gaps in education opportunities in women's heart health. Welcome.
Thanks, Sandra, and good morning, everybody. We have a great number of participants today, so we should say thank you for everybody who's here in person and also the people who are online. I think there's over 300 who are supposed to be here today, and the interest in this topic is encouraging, which proves that healthcare providers understand that improving our knowledge in this topic will improve cardiac care for women. We should thank the presenters. We're very lucky at the Heart Institute and in Canada. We have a lot of experts among us, and they've put together a really great day. I'm sure we'll learn an awful lot. I know I learn something every time I hear these people speak. You've probably heard this before. There's a problem. So that's why we need to solve it. So the problem is women's heart health is under-researched, underdiagnosed, undertreated, and women are under-supported during the recovery from a cardiac event. In most cases, screening for heart disease omits female-related risk factors. Women have atypical symptoms and can be dismissed or misdiagnosed. Research on heart disease historically, and even today in most cases, neglects to analyze results by gender. And most of us healthcare providers who are practicing today obtained an education in cardiac care that didn't include any reference to gender differences. So it's no wonder there's any gaps in their knowledge. This is why improving women's heart health is a strategic priority for the University of Ottawa Heart Institute, with a goal of bridging all these historic gaps. We're committed to working across the fundamental pillars of research, clinical services, education, and awareness to further advancements in this domain. As a central part of our patient care strategy, we'll continue to promote cardiac wellness in general and support our unique Canadian Women's Heart Health Centre to further their great work. And you can see on our strategic wheel, it's right there, further support women's heart health. So it's a main priority for our board and our senior management at the Heart Institute. Understanding of this important problem starts with education. Education will lead to advocacy, policy, and practice change. And talking about education is a good segue to let Kara talk, who's one of our educators here at the Heart Institute.
Cardiovascular disease is the #1 killer of women over the age of 35 worldwide, and yet there remains a lack of education surrounding women's cardiovascular health. A recent literature review conducted by the University of Ottawa Heart Institute's Women's Heart Health Alliance found that there were very few educational initiatives on the topic of women's heart health, and even fewer geared towards nurses and allied healthcare professionals. Physicians were primarily the targeted audience. Acknowledging the lack of educational initiatives for nurses and allied health professionals, despite the significant amount of time they spend with patients, teaching them about their disease, watching for signs and symptoms of a cardiovascular event, was the impetus for organizing this Women's Heart Health Education Day. We knew we needed to bridge this gap so that we can ensure we provide high quality care to women with heart disease. And so, as Bonnie said, it's our goal to provide accessible, ongoing learning and educational opportunities to our staff and bring forth knowledge and understanding of women's heart health to those who will be caring for these patients. Some of the educational initiatives that we have in development include e-learning modules, incorporating information on women's heart health into our nursing orientation, and future educational sessions similar to today's event. So again, we would like to welcome you to this Women's Heart Health Education Day. We have several speakers and topics that you will undoubtedly find interesting and hopefully bring forth some of the information you gather here today back to your colleagues, because the dissemination of knowledge is key to awareness on such a profound topic. So welcome and enjoy.
So I'm going to open it up for 2 questions for Bonnie and Kara in the audience and also online as well. So to get us started, Bonnie and Kara, what do you think will be some of the main challenges to incorporate specialized education on women's heart health within healthcare institutions, and how do you think they will be best overcome?
That's a great question, Bonnie. I think curriculums in universities are one thing. We need to start with the young ones, and if we can advocate to get that in those places now, which is something that I know the Canadian Centre for Women's Heart Health is integral in trying to advocate for, at least our future will be bright. Getting the information out to our current group of healthcare providers is a little harder. Once we've learned something, it's hard to unlearn it. This is starting to get traction. The fact that there's 300 people at this meeting today tells me that there's a thirst and a need for this kind of information. I think it needs to be grassroots. There's a few big projects going on that are looking at doing more of a hub and spoke model and regional approach where experts can provide materials and things to smaller sites or other sites that can help disseminate that information. I think all those things are important. It starts with us, and I think the more we can beat the drum and provide these educational opportunities, the better. It's been slow growing. But I think we're starting to get a little bit of traction, and the future's bright looking forward.
And Sandra, has any questions online?
Thanks, Bonnie. Note so far we are good online.
Thank you. This is a small token of our appreciation, ladies. Thank you. Thank you so much. Okay, so we're going to continue with our next speaker, who is a woman with lived experience, and her name is Tammy. And you know what? This is so important to actually hear from a patient what this is all about. And it makes it so much more meaningful to us as healthcare providers, because this is why we do what we do, right? So to introduce Tammy, she's 44 years old and she's got 5 kids, so 3 kids and 2 stepkids. She's currently a manager in the federal government, and she is here to share her journey of getting a cardiac diagnosis. So welcome, Tammy.
Hey everyone, sorry, apologies for this. Our patient Tammy isn't here quite yet, so we'll actually present Dr. Coutinho. So I will introduce Dr. Coutinho. Dr. Coutinho is a clinician scientist, Chief of the Division of Cardiac Prevention and Rehabilitation, and Chair of the Canadian Women's Heart Health Centre at the Heart Institute. A strong advocate for women's heart health, she joins us online today to educate us about the facts of how heart disease impacts women. So welcome, Dr. Coutinho.
Hello, everyone. I hope you can see and hear me well. I am just going to share my screen.
Dr. Coutinho, can
Yes?
you just at the top say take control, and you'll be able to control the presentation through Teams right now.
Yeah, my top says you are a presenter. You can share content and facilitate the meeting. It doesn't ask me to take control. It seems to imply I already have control. Yeah, I like that. I'm trying to share my screen. I don't know if the screen that you see right now is mine or yours. It doesn't want to take it forced me to be stuck in this screen. So let me try opening this one now. Apologies, everyone. I am all the way in Rio today because I came here to speak at a Women's Heart Health Conference, and I had 4 talks to give on this topic. So I had to present remotely as I'm flying back to Ottawa later today. I think I successfully shared my screen. Can you please confirm whether you can see my slides passing through right now?
Yeah, we can see it great.
Okay, wonderful. Thank you very much, and thank you for your patience. So first of all, welcome to everyone. Good morning. I'd like to congratulate our team, a wonderful team in prevention, rehabilitation, and the Women's Heart Health Center for putting together this day that has been apparently very popular. I'm always very excited to hear when more and more people want to learn about women's cardiovascular health. So thank you for your presence. Thank you for the invite. Thank you for allowing me to present all the way from Brazil. And I was asked to talk today about some facts about women's heart health. So I'm just going to highlight some introductory topics for you, and hopefully you have the chance to think about these things and then deepen your knowledge as the rest of the day goes by. And I have no disclosures. So let's start with the first fact, which is the magnitude of the problem. How big of a problem are we talking about? Well, I always start with this slide because I think it's very powerful and thought-provoking, because this has been shown in research again and again. If you go out in the street and you ask, 100 women, what do they think is the biggest threat to her life, the biggest threat to her health? It's anywhere between 60 to 80% of women, according to research, will respond and say that breast cancer is a woman's greatest health threat. This is a myth, however. The fact is that heart disease kills 5 times as many women throughout the world than breast cancer, and it kills twice as many women than all cancers combined. Like I mentioned earlier, I'm here in Brazil for our Women's Heart Health Conference, and I just learned yesterday that in Brazil, cardiovascular disease kills 10 times more women than breast cancer, which is even a greater number. But unfortunately, and this is also data from research, from our own research, only a small minority of Canadian women actually identify heart disease as the greatest health threat. Why is this important? Because the majority of heart diseases can be prevented. So if a woman is not even aware that she is under risk, she is less likely to undertake the behaviors, the preventative strategies and medications that we know can help prevent heart disease, right? If she doesn't even perceive that this is a risk for her. So that's a big problem. And the reality is that cardiovascular diseases will be responsible for 1 out of 3 every female death in the world. The other big component of this problem is that we have certainly the poor awareness at the level of the population, but we also have poor awareness at the level of the scientific community, because the far majority of clinical cardiovascular research has focused on men, either because women were not included in research, especially in the earlier days, or if they are included still to this day, they are hardly ever the minority or even an equivalent number of participants. They're usually the minority, so statistical power to make sex-specific inferences about the research becomes lower. So it has been reported, and this is from the Heart Stroke report called Misunderstood, it has been reported that 2/3 of heart disease clinical research has actually focused on men. So research in women certainly still lags behind. So poor awareness in the community, poor awareness in science, and here this slide is to show you that there's also poor awareness and knowledge at the level of the healthcare providers, which is something that we're trying to improve with today's symposium. So this is also research from our group. We surveyed Canadian physicians, particularly family medicine, cardiology, and OBGYNs. And the gist of the results of this paper is that physicians typically demonstrated poor awareness about the prevalence and the approaches to identify and treat heart disease in women. And physicians, where they were asked to rate themselves, how high do they rate their own effectiveness and capacity to support female patients to prevent or manage heart disease, and physicians rated themselves very poorly. So because they're not educated about some of these specific aspects, and therefore they don't feel as prepared to deal with the specific and unique aspects of cardiovascular health in women. So that's a big problem. So that was the problem number one, is this overall poor awareness at so many levels, from community to science to healthcare practitioners. Let's move on now to the second fact. I mentioned earlier that cardiovascular diseases are highly preventable, which is true. So when we think about cardiovascular risk factors, it is important for us to note that when it comes to men and women, risk factors are not created equal. And I'll show you examples. Let's start now with the conventional risk factors. These are risk factors that everybody knows about, everybody, at least in this audience, because you're all in health. These are risk factors that we know about, but it's important to understand that conventional risk factors typically affect women more strongly than men and are more likely to contribute to cardiovascular disease in women than men. So I'll show you examples. Let's start with hypertension. Hypertension is the #1 cause for death and disability worldwide. But as you can see in the slide, hypertension is more likely to contribute to a heart attack, heart failure, stroke, or target organ damage in a woman as it is to contribute to these diseases in the men. So perhaps without surprise, hypertension is also more likely to cause death in a woman as compared to a man. So hypertension is more dangerous for women than men. And there are also more hypertensive women walking around in this planet than we have hypertensive men. The other very popular, well-established cardiovascular risk factor is diabetes. Diabetes increases the risk of heart disease in both men and women, but the magnitude of this increase is significantly higher in women, as you can see here, as compared to men. The other aspect of diabetes is when we think of younger women who are still menstruating and still having, during their reproductive years, so to speak, those women are known to be relatively protected against development of atherosclerotic forms of cardiovascular disease. Well, if that young woman is diabetic, the natural protection that she has from the age is eliminated in the presence of diabetes. So that's something important to consider. Smoking, a very important risk factor, is the #1 cause of preventable death and hospitalization in the world. Smoking increases the risk of myocardial infarction in young women 60% more than it does in young men. Importantly, quitting is also more difficult for women. Women have been reported to have more difficulty quitting, have more failures at quit attempts, and have more chances of relapsing after quitting as compared to men. Physical inactivity is really probably the cardiovascular epidemic of the 21st century, perhaps even further magnified as a result of the pandemic. And physical inactivity has been reported to be more common in women than men. And obesity increases the risk for cardiovascular disease in both sexes. However, once again, the magnitude of this increase is also higher in women than in men. So those were conventional risk factors. Now, women also experience a number of female-specific risk factors that men will never experience in their lifetime, which further compounds the cardiovascular risk. Here are some examples. Polycystic ovarian syndrome, or PCOS, increases the risk of heart disease by a little bit, and this is mostly mediated by the metabolic effects of insulin resistance that can occur with PCOS. I don't think it's a surprise to anyone that a woman's risk for cardiovascular disease increases substantially after menopause, but for those women that reach early menopause before the age of 40, they have a 95% increase in the risk of myocardial infarction compared to age and sex match individuals that went through menopause at a regular age around age 50. Perhaps the most studied, the most robust female-specific risk factor is hypertensive disorders of pregnancy, which is abbreviated here, HDP. This includes gestational hypertension, preeclampsia, and eclampsia. And in summarize here are results from meta-analyses with adjustment for confounders that very robustly send us this very strong message that these diseases significantly and independently increase a woman's future risk for a number of different cardiovascular diseases. As you can see here, if a woman has had preeclampsia, for example, her risk of chronic hypertension and heart failure is quadrupled. The risk for stroke is 80% higher. The risk for atrial arrhythmias is about 50% higher. And there's more than doubling of the risk of coronary heart disease and cardiovascular death. This slide, I find it very telling, and I think it's an eye-opener for many people. This is an observational study where women had babies and then they were followed for 40 years into the future. In this slide here, you have survival on the y-axis, and in gray, you have women that had normotensive pregnancies. In black, you had women that had preeclampsia, but after 34 weeks of gestation. And in the dashed line, you have women that had early preeclampsia before or by 34 weeks of gestation. As you can see here, having preeclampsia does negatively affect survival. However, the biggest impact on survival we're seeing among those that had early preeclampsia. These curves separate very early, which means that some of these women are dying at the time of having their babies, but they also continue to separate over time to the point that if you calculate a hazard ratio for early preeclampsia and predicting future cardiovascular mortality, the hazard ratio is nearly 10. Think about this for a moment. I challenge you to identify any conventional risk factor, hypertension, diabetes, smoking, hyperlipidemia, whatever it is. None of them are going to increase the risk of cardiovascular mortality by tenfold. This is a very, very powerful risk factor that we hardly ever consider. The authors of this study also calculated a woman's probability of being alive at the age of 31 years old, surviving after the age of 30. If they had no preeclampsia, most of them were alive. If they had late preeclampsia, most of them were alive. However, if they had early preeclampsia by 34 weeks gestation, the woman's chance of being alive to turn 31, to have a 31st birthday, was only 86%. These are it's an enormous impact in the health and the lives of very young women. So remember this. The reality is that the pregnancy history, which takes 2 minutes, costs no money, has no risk, no radiation, taking a pregnancy history is a golden opportunity for us to enhance our cardiovascular risk assessment of a woman. We just talked about hypertensive disorders of pregnancy, but there are other factors as shown here. Gestational diabetes about doubles a woman's future risk for cardiovascular disease, which is partially mediated by development of diabetes mellitus later in life. Other factors such as placental abruption, premature delivery, and stillbirth all increase a woman's future risk for cardiovascular disease and or cardiovascular mortality. So again, it costs you nothing. It takes you 2 minutes. And you can get smarter by asking these very simple questions about the woman's pregnancy and delivery, and you start to understand a little bit more about her cardiovascular risk. So we spoke about conventional risk factors, we spoke about female-specific risk factors. Now I wanted to highlight some female-predominant risk factors. And I wanted to specifically highlight the inflammatory rheumatologic disorders. Classically, these are rheumatoid arthritis, lupus, and psoriatic arthritis. These conditions collectively increase a person's risk for cardiovascular disease by about 50%. But if you think who is affected by these conditions, and they are mostly women. So that's what we call female predominant risk factors. Here's some data for rheumatoid arthritis. This is an observational study where the authors had about 600 adults with rheumatoid arthritis and then age and sex matched controls without RA. And they found that the patients that had rheumatoid arthritis had about 3 times the risk of myocardial infarction, nearly 6 times increase in the risk for unrecognized myocardial infarction, and about doubling of the risk of sudden cardiac death, with a decreased chance of having presented with more stable, predictable forms of heart disease, such as angina, or requiring elective revascularization. So the patients with rheumatoid arthritis presented more acutely and more severely. And if you look at who has rheumatoid arthritis, the female to male ratio is 5:2. So again, a female predominant condition. Lupus. 1 out of 10 people with lupus will develop clinically manifest coronary artery disease in their lifetime. And if you look at a population of young women between ages of 35 and 44, many of our lupus patients are in the age group, that woman's risk of myocardial infarction is 50 times higher than age-matched control women that do not have lupus. So that's a very, very significant increase. And once again, lupus is predominantly female. Female to male ratio is 9:1. Most of our patients with lupus are women. So the European Society of Cardiology has made this recommendation. So for us to better estimate cardiovascular risk in our patients that have inflammatory rheumatologic conditions, we should calculate that risk with whatever calculator we typically use. If you use the Framingham risk score, the Reynolds, if you use the ACC score, or if you use the Q-risk lifetime, you use a calculator of choice for that patient. Then you get your result and you multiply that result by a factor of 1.5, and that will give you a better estimate of risk. And this is why in this graphic here, the black bars are observed risk, like real events, and the white bars are predicted risk, predicted by the calculators. And as you can see, as the deciles of risk increase, there was a significant discrepancy where observed risk was substantially higher than the risk you could predict with a calculator. And that's how they came up with this factor of 1.5 for us to apply to our risk calculations to have a more appropriate risk estimation for that patient. And that goes for men and women. But again, most of them will be women. So that was the second fact about cardiovascular risk factors. So now let's move on to the third fact, which is about the presentation of ischemic heart disease. And I always like to think about the ischemic heart disease that I see today on the wards, that I see today in the women's health clinic. It's not the same heart disease that I learned in books from medical school and from many of you in nursing school, physiotherapy school, and any of the professional schools that you went to. I can guarantee that what you learn in your books in school is not identical to what we see today in real life. Once again, quoting the Heart and Stroke Misunderstood report, because the classic presentation of angina, the classic presentation of a myocardial infarction that we all learned in the books has been described from studies from over 50 years ago that only included men. All of these descriptions are very classic for men, but we are now learning that women may be different than what's written in the books. And this translates even to the population, because women are expecting to have the classic symptoms when they have a heart attack, and sometimes they don't. So resulting from that, early heart attack signs can be missed in up to 78% of women. So what do our textbook says? Regardless of the school we went to, I can guarantee that you learned that a classic angina and a classic heart attack presents with a retrosternal heaviness or tightness that may radiate to the jaw or to the left arm. And if it's a stable angina, it is usually brought on by exertion and usually relieved by rest or nitroglycerin. That is correct, and many women will present this way. But this is the easy part. The real life, however, is that some women may present with different patterns. They may have a chest pain, but they may use different words to describe how the chest pain feels, like burning, sharp, dull. Indigestion is the one I hear the most. Women love to use the word indigestion. I do not know why. They choose to use that word to express what they're feeling, even though deep inside they know that indigestion feels differently. But that's the best word they can come up with to express to you as a provider what they're feeling, the word indigestion. So that can be very confusing to everyone. They may have just epigastric pain or just feeling the neck, jaw, or arms, which is the minority, but it can happen. Or they can have just shortness of breath, nausea, and exhaustion without any pain at all. And that's really the minority, but can also happen. in women more so than men, pain can be triggered by emotional stress or anxiety, or sometimes without rhyme or reason. It may wake her up in the middle of the night, which is actually very classic for vasospastic angina, but it's definitely not what's written in our books. And some women may have chest pain associated with the menstrual cycle, like 2 to 3 days before the menses or on the day of the menses when hormone levels significantly drop, or as she enters perimenopause. So again, this is all more complicated than what's in the books, isn't it? Now, this idea of typical and atypical angina and the fact that women have atypical symptoms at the time of a heart attack, this idea has truly percolated through our community and our science and health community. So we have all been told at some point that, oh, women with angina, women with heart attacks, they have atypical symptoms. But there is now a significant push to not use these terms anymore, because when we use the word atypical, we are truly marginalizing a woman's experience, a woman's health experience. And simply because people didn't bother to study the classic presentations of angina in a woman before, it doesn't mean that they're not typical. It just means that people didn't bother studying them when they wrote the books. So the most recent chest pain guidelines that were published a year ago actually completely eliminate the wording typical and atypical that we all learned. And they ask us to grade chest pain on a scale from cardiac chest pain to likely cardiac chest pain to non-cardiac chest pain, rather, instead of the typical and atypical definitions. The other idea that I have seen percolating through healthcare providers is this idea that at the time of a heart attack, women don't have chest pain. Women have other symptoms, but no chest pain. There have been many studies that have debunked this notion. I'm showing you just one of them here. They looked at men and women at the time of a myocardial infarction. And as you can see on the very first row here, the proportion of men and women that present with chest pain at the time of an MI is nearly identical. It's almost a 90% for men and women and not statistically significant. So women are as likely as men to have chest pain at the time of an MI. What is, however, different between men and women, which you can see here on the bottom, is the fact that women are more likely than men to present with a whole bunch of other symptoms, 3, 4, or more additional symptoms. So an example for illustration here is that maybe a man presenting with a heart attack may come with chest pain and shortness of breath. A woman coming in with a heart attack may come with chest pain, shortness of breath, dizziness, sweating, and fatigue. So the syndrome of angina, the syndrome of myocardial infarction in a woman is more florid, more complex. So it's harder even for the woman to understand that all of these things she's feeling is a heart attack. Because if it was just chest pain, it would be easier, right? And it's also harder for the provider to come up or to narrow down the differential diagnosis to a heart attack because they have all of these other things that they have to evaluate as part of the differential diagnosis. But this is the true difference between men and women. This concept of typical and atypical angina, I find it very interesting. This study, it was presented at the ESC a few years back. I have not yet seen it published. It was called the Anice study. And what they did is they took patients that were referred for coronary angiograms, and they recorded the conversation between the patient and the doctor. They analyzed that conversation through natural language processing, and they put it through an artificial intelligence framework. And the computer then was able, through artificial intelligence, to analyze those conversations. And the computer reported is that 90% of both men and women reported chest pain at the time of their presentation to the coronary angiography suite. Once again, compatible with previous studies that we knew that about 90% of them have chest pain. However, the computer identified 9 clusters of symptoms that people were reporting, and these clusters were not different between men and women. So what I learned from the MS study is that if you let a computer listen to the patient, the computer will tell you that men and women are telling you the same things. But if you let a human listen to the patient, the human interprets the same conversation as men having typical symptoms and women having atypical symptoms very often. So this shows us the role of bias in healthcare, and we all have them. Doesn't matter how good we think we are. You have them, I have them. We all have biases, but it's important for us to know that we have biases, know where and how our biases are, so we can actually keep these biases in check and always ask ourselves, am I having a biased view of this encounter? Because we're going to bring these biases already to every healthcare encounter. And we can show here that if you remove the bias and just give it to a computer, men and women are the same. The other important myth that I wanted to dispel is the myth of the ischemic trigger, because a textbook tells us that true angina is brought on by exertion and relieved by rest or nitroglycerin. Again, many women will have this type of angina, no question. However, what we see in real life in our clinic, in the wards, in the emergency room, is that women can have indeed angina, true angina, that is brought on by emotional stress or anxiety. This is more common in women than men. And very often when this happens, the woman thinks it's all in her head. The physician, the nurses sometimes also think, oh, this is all a product of her anxiety. So she's feeling this chest tightness because she's anxious. And of course, anxiety, panic attacks can cause chest tightness. It's known. But many of these women have true ischemic triggers that are based on their mental stressors. And I'll show you a study that proves this very elegantly. In this study of 306 patients that had a recent myocardial infarction a month before, they found that, and half of them were women, by the way, they found that at baseline, at the time of their MI, women had less severe coronary stenosis than men, and they were less likely than men to have multivessel disease. However, the risk for revascularization was the same. So everybody had a heart attack a month ago, everybody got revascularized, but women had less severe epicardial disease from the get-go. Then they brought these people back a month later and they did a mental stress test. So that includes telling the patients to prepare very briefly a 5-minute speech about a certain topic, then get up and give that speech. So it's enough to cause a little bit of distress. And I think you agree with me that this is not even close to the stresses of real life that these women have to go through. But nonetheless, it provokes a little bit of distress. And then they put them on a stress test camera, a nuclear stress test, and they document myocardial perfusion to see if there is any perfusion abnormalities. And what they found is that women were 3 times more likely than men to experience documented ischemia on a nuclear stress test in response to the mental stress. Documented ischemia. It is not in her head, it's in her heart. And this was 3 times more likely in women than in men. The other component of the ischemic heart disease being different than what we read in books is that not all heart attacks are created equal. We know that today. What we learn in school is that heart attacks are usually caused by very severe or even complete blockages to one or more of the epicardial coronary arteries by cholesterol plaque. So as you can see in this arrow here, anyone will be able to identify this very severe stenosis. This patient can get a stent from here to here. And if there's multiple blockages, they can get a bypass. So we know how to recognize this and we know how to treat this, right? But what the books don't tell us, well, they didn't tell us, but we now know, is that heart attacks, chest pain can also occur in people that have apparently normal or only mildly abnormal coronary arteries. This is certainly a bit more common in women than in men. So this brings us new terms that we use all the time. MINOCA, which is myocardial infarction with non-obstructive coronary arteries. INOCA, which is ischemia with non-obstructive coronary arteries. And ANOCA, which is angina with non-obstructive coronary arteries. We see that all the time in a women's heart health clinic. The usual characteristics of a MINOCA patient is that a MINOCA patient tends to be a little bit younger than a regular atherosclerotic MI. They are more likely to be women than a regular atherosclerotic MI and less likely to have hyperlipidemia as compared to an atherosclerotic MI. MINOCA is not rare. It's been reported to be present in 6 to 14% of all myocardial infarctions. So if you just think of the sheer volumes of heart attacks that we see every year here at the Heart Institute, I've done this calculation. Every year we are bound to see anywhere between 100 and 300 MINOCAs, just based on the volumes of heart attacks that we get. So it is not rare. So keep your eye out for it and you find it. There have been a couple of mechanisms that have been proposed in MINOCA. One is a plaque mechanism, which I'm showing you here. In this study from New York, they took women with MINOCA, so they had a heart attack but had open arteries. They found that 30% of them had completely normal angiograms, not even one plaque to speak about. The other 70% had some burden of plaque, but mild, non-obstructive. Interestingly, what I'm showing you here in this figure is the angiogram of 3 of these women with MINOCA. The arrows are pointing to the segment of the arteries that are being interrogated here with an intravascular ultrasound. And if you just look at the coronary angiogram at the arrows, you will see, these arteries look pretty healthy. You don't see blockages there, right? Then when they did intravascular ultrasound, I'll guide you through it. The hole in the middle is the actual catheter inside the vessel. And the circle here is the lumen, and then you can see the plaques here crescentically. So if you just focus on the right, it's a little bit easier because it's been contoured for us. So in this first woman, the artery looks very healthy on the angiogram, but here you see a crescentic plaque that is probably about 30, 40% obstructive, but that plaque is ruptured. See? The middle one is also a very mild, small plaque, maybe just 10% obstructive. The angiogram is invisible to this, or blind to this, I should say. This plaque is also ruptured, as you can see here. The bottom one is, once again, a plaque that is crescentic and maybe just 20% obstructive, seen here on the left. And there's a big chunk taken out of this plaque. See, this is a plaque erosion. So one of the proposed mechanisms of MINOCA is plaque disruption. And unless you have intracoronary imaging, you will never be able to document that. So people just have the heart attacks, they have the coronary angiogram, say, okay, Miss So-and-so, coronaries are good, this was not a heart attack, move on. And in fact, they had a heart attack and they had a plaque event. The other mechanism of MINOCA, and also a mechanism of INOCA and ANOCA, is microvascular dysfunction, and I also put a parenthesis here to also say vasospasm. So vasospasm, I think it's easier to conceptualize that an artery with spasm, but the microvascular dysfunction is a bit harder to conceptualize. I always joke with my trainees and with my team that believing in microvascular dysfunction is an exercise in faith, because you have to believe what you don't see. Right? Because when you do the angiogram, as you can see here, you only see the nice, big, plump epicardial coronary arteries. You don't see what is shown here, which is this incredible network of microvessels. This is a special angiogram in a dog. That's how we can see this. That was done with special techniques. We don't see this in the angiogram. And the reality is that these very tiny hair-like microvessels are responsible for 80% of the blood flow regulation to the myocardium. So it's very naive of us to think that just because there's not a blockage in the large arteries, that everything must be okay, when 80% of the blood flow is being regulated by the arteries that we don't see. Here's a very good and practical example for you. Imagine you're trying to get home. You're trying to get home, you take the Queensway, so you have a highway, but then you have to take a side road to get to your actual street and to your house. Think of the highway, the Queensway, as your epicardial coronaries, the ones that you can see in your angiogram, and think of the microvasculature as the side roads. So if you have a traffic jam, if you're in this blue car here, it's going to take forever for you to get home if you ever get there, right? So this is a blockage in the epicardial coronary artery. So when this is happening, and those helicopters that are reporting up above to the radio stations are reporting that the Queensway has severe traffic obstructions, everybody knows this. This is what we see in the angiogram. We see the blockage. However, you could have a completely open highway, but then when you take your turn to go to your house and you take your side road, then you're blocked. And I don't know if you can see this, but this is actually a herd of cows in the middle of the road. So you take a side road and you just cannot get home. But yet the report from the radio tells you the highways were open, yet you cannot get home. That's because that's the microvascular disease. The helicopter doesn't report on these little side roads, right? So we don't see the microvessel. So think about this as a very simple analogy to what's happening in these people's hearts. Microvascular dysfunction has prognostic implications. This is data here from the WISE study, the Women Ischemia Syndrome Evaluation Study, where they took 224 women with ischemia, and 81% of them had minimal or no epicardial coronary artery disease whatsoever. And then they followed them for 10 years into the future. And you can see here that even though these women's arteries were open, over a 10-year follow-up, the number of events was not low. And if you even look at the number of events among the subset of women that had no coronary blockages whatsoever, not even a single plaque to report, they still had events at 10 years. So this is not a perfectly benign condition. What they also found is because we can study microvascular function with catheters with special physiology and Doppler wires in the coronaries, which is complicated but can be done. And we can estimate microvascular dysfunction that way. And what they found is that the women that had documentation of microvascular dysfunction on those special caths had higher rates of heart attack and death. And here are the Kaplan-Meier curves, where on the y-axis you have, sorry, my mouse disappeared. Here we go. You have cardiovascular event-free survival in all women, and then on the right, in women that had completely normal arteries. And as you can see, if there was microvascular dysfunction shown in red, there was lower probability of event-free survival. So this is also not diagnostic, but also prognostic. In the topic of not all heart attacks being created equal, I just couldn't give this talk without at least briefly mentioned that spontaneous coronary artery dissection is also a mechanism for heart attacks that is not the usual atherosclerotic mechanism that we all learned in school. Now, I have a 45-minute talk on SCAD alone. So today I'm just going to give you a sprinkle of information on SCAD because that is a very complex topic, but I just couldn't not talk about it because that is also a mechanism of myocardial infarction that is very common in women. And spontaneous coronary artery dissection, or SCAD, just simply means that there's a spontaneous separation of the artery wall. So basically one of the three layers separates from the other two, and there's a bleeding into the wall of the coronary that then compresses, this hematoma eventually compresses the true lumen and impedes blood flow. And this is not caused by trauma. It is not caused by a catheter. It's not iatrogenic. It's completely spontaneous. SCAD is typically a condition of an underlying predisposition, most commonly a fibromuscular dysplasia they didn't know they had, with a trigger. Triggers can be a peripartum period. If a woman is going to have SCAD in the peripartum period, usually occurs in the first 4 to 5 weeks postpartum, perhaps directly related to the sudden hormonal level drop that happens in that time. For women, the most common trigger of SCAD is an emotional stress trigger. And for men, the very few men that have it typically have a physical trigger, a very heavy type of physical exertion. The typical SCAD patient is a woman. 90% plus of SCAD patients are women. And the average age is actually between 42 and 52, but most recently reported even to be about 53 years old. We used to think of SCAD as a disease of pregnant women. Now we know that the average prototypical SCAD patient is a woman in their early to mid 50s. Although I have seen women in their 20s all the way to their 70s, and this has also been reported. About a quarter to a fifth of these cases occur in the peripartum period. And the classic presentation that you should have all your antlers up is a young to middle-aged, relatively healthy woman without the typical risk factors with sudden onset of classic chest pain and myocardial infarction. So if you see this person, you have to really have a SCAD in your differential diagnosis. And again, SCAD is a different talk, but I just wanted to insert that topic there for you so you know that not all heart attacks are the atherosclerotic plaque heart attacks that we all came to learn. And my last fact is the fact that coronary artery disease is typically undertreated in women, and that leads to adverse outcomes. So here in this graphic on the y-axis, you have a number of quality indicators that must be achieved for the proper treatment of a person with myocardial infarction. There's several of the many quality indicators. And on the x-axis, it's a negative scale because this is how less likely a woman is compared to a man to achieve some of these quality indicators. And if you can see here, we're talking about anticoagulant, timely reperfusion, being prescribed a statin, being prescribed the antiplatelet therapy, all the way here on the bottom to receiving coronary angiography for diagnostic purposes within 72 hours of an NSTEMI. And as you can see, women were less likely to achieve these important quality indicators across the board and significantly more likely to even be sent to the cath lab for diagnosis despite having an NSTEMI. So women are diagnosed and treated less aggressively at the time of an MI. And perhaps as a direct result of that, 30-day mortality in women with MI is worse than it is in men. 30-day survival, I should say. Now, secondary prevention is very important. We know that if we have good secondary prevention after a first event, you can prevent subsequent events by about 50%. So it's a powerful intervention. And there are very simple things shown here. This is not an esoteric approach. We're here talking about aspirin, a second antiplatelet agent, a beta blocker, and a statin. Very simple things, right? But if you look at these very simple secondary prevention measures, across the board, women are less likely than men to receive and be prescribed these very simple medications for secondary prevention. So they're being treated and prevented to a lower degree as compared to their male counterparts. We also know that cardiac rehabilitation is an important component of a patient's secondary prevention and journey back to mental and physical health. There are many benefits of cardiac rehabilitation, and these benefits are equally enjoyed by men and women. However, despite this, women are a lot less likely than men to participate in cardiac rehabilitation. In this meta-analysis here by our colleagues in Toronto, they, as you can see, all of these articles were summarized. If you're familiar with a forest plot, here's the line of unity. Anything to the left of the line of unity favors men being referred to rehab, and everything to the right of the line of unity favors women being referred to rehab. And almost a blind person can see that everything is to the left. So when they summarize the data, as you can see, women were on average 32% less likely to even be referred to cardiac rehabilitation as compared to men. So these are problems that we need to be aware of. And we're very proud of our team that they continue to work on this, and we've been able to increase our referrals and participation of women in cardiac rehabilitation very much through automatization of processes, the addition of a liaison, and to really put an emphasis to it. So I can say that our numbers are much better than reported, but this is what you're going to find out there, a significantly lower referral and participation for women. When it comes to hard outcomes, perhaps as a result of all of these things that I outlined for you, women are going to have worse outcomes. So here's the data for rehospitalization after an MI at 12 months. In the gray lines, you have women older and younger than 55, and in black lines, you have men older and younger than 55. And as you can see, regardless of age, women were more likely than men to be rehospitalized at 1 year after myocardial infarction, perhaps because they're not receiving as much secondary prevention, perhaps because they're not being referred to cardiac rehabilitation, and they're just not having their needs met. So they are more likely to be rehospitalized. And unfortunately, women are still more likely to die at 30 days after myocardial infarction. This graphic represents the temporal trends over decades of 30-day mortality for men and women. In blue, you have Black women. In orange, you have white women. In green, you have white men. black men, and in red you have white men. And regardless of race, still at the time of the last evaluation of this data, women were still more likely to die at 30 days after an MI as compared to men. So these are some facts that I wanted to share with you today, and I'll summarize it here for you to digest and explore in the coming talks. Remember that cardiovascular diseases are the #1 killers of women worldwide. Remember that conventional risk factors that we all know about, they affect women more severely. And to compound that, women are also exposed to some sex-specific or sex-predominant risk factors for cardiovascular disease. I can say that in 2022, a heart attack is not exactly what I learned in medical school. I'm not that old, so it's not like I've been around for 50 years. So it is different today than when I learned it, especially in women. And we have new evidence that heart attack and angina symptoms may not be that different between men and women. It's how we interpret it as humans with bias. I also want you to remember that mental stress can indeed trigger true ischemia, and that is present in men and women, but much more common in women. Remember that heart attacks and angina can occur even when the epicardial coronary arteries are completely open, as can be seen in the setting of plaque erosion, microvascular dysfunction, vasospasm, or SCAD. Remember that if you see a young to middle-aged woman with chest pain or frank heart attack, you have to consider SCAD in your differential. And women are less likely to reach the quality indicators and secondary prevention and cardiac rehabilitation after a myocardial infarction, and perhaps as a result of this, have worse outcomes than men. All of these things are very doom and gloom, but there are lots of wonderful, smart, engaged people working on this. We know things will get better. And education is the first step to making this get better. So I commend you for being here today and learning about this. And I really I hope that you would take this information and into your practices and help us change these very ominous statistics that we still see in women today. So I'd like to thank you very much. And I'll finish here with an invitation for you. If you like today, if you love learning about women's cardiovascular health issues, I recommend that you join us for the 4th Canadian Women's Heart Health Summit, which will be taking place in Vancouver next April. It's a great opportunity to travel in the spring. And the registration and the call for abstracts are going to open on November 1st. So I hope to see you there. With that, I would thank you very much for your attention. I'll try to unshare my screen and I'll be happy to take any questions. Thank you so much.
Thank you very much, Dr. Coutinho. That was amazing, as always. So I'm going to start off with a question for you. What would you say is the most important action that healthcare providers can take to improve women's heart health? If you have more than one, that's okay too.
Oh my gosh. Okay. So can I say 2? I'm going to say 2. Because 1 is just impossible. So one, for healthcare providers alone, so in our role as you know, preventers and managers of health, I think to make our female patients aware or help them be aware of their risk and their risk factors and empower them to control those risk factors. Because at the end of the day, yes, I'm a cardiologist, but I don't want to see these patients. I want them to prevent these diseases, and maybe I can see the patients that could never have presented, right? So prevention is powerful and is still significantly underutilized in women. So I think being a healthcare provider and really emphasizing prevention is very important. And I think the second point that I think as healthcare providers we can do is educate ourselves and our colleagues about some of these female-specific presentations I spoke about, because you would not believe that still today, women are coming to our own emergency department with chest pain and are sitting there for 3 hours, even waiting for an ECG with a frank heart attack. You know, unfortunately, we still hear that even in the best of centers. So I think it is our job as providers to continue educating ourselves and our colleagues to help eliminate some of these disparities in presentation and diagnosis.
Thank you very much. We'll take other questions for Dr. Coutinho as well. Sandra, I believe you have some online there.
Yes, that's right, Dr. Coutinho. There's a question from Lydia McDonald. She asks, how do we prevent plaque disruption?
So nobody knows how to prevent plaque disruption because plaque disruption wasn't even known until fairly recently. I would make an educated guess that the same way we prevent plaque disruption is the same way that we prevent heart attacks to begin with. So we know the power of there are 7 things that everybody can do to decrease the risk for atherosclerotic events. And I would think that the same would apply for any plaque event, even if it's a plaque disruption. So what are these things? Eat a healthy diet, meet your exercise goals. And the recommendation is a minimum of 150 minutes of moderate to vigorous exercise per week for everyone. Maintain a healthy weight. Avoid or treat hypertension to goals. Avoid diabetes or treat to goals. Avoid hyperlipidemia or treat to goals. And don't smoke. Okay? 7 things. We know that if a person, man or woman, engages in these 7 things before the age of 50, her or his risk of atherosclerotic disease, heart attack and stroke, for the rest of their life is only 5%. So I always like to quote this number so people can understand how powerful these 7 preventive strategies are. And I would then transpose this to this concept of the plaque disruption, because at the end of the day, it's an unstable inflamed plaque, and all of these 7 things apply to all kinds of unstable inflamed plaque. So I would continue to promote those 7 things. And for anyone in the audience who's older than 50, because I just gave you a quote for below 50, there's still significant benefits in engaging in these habits to continue significantly decreasing one's risk. It's never too late, and it's really, really powerful. So I would just use this exact same 7 for plaque disruption, although this is my expert opinion because there's no science on this.
That's great. Thank you, Dr. Coutinho. Those are some really practical tips for preventing plaque disruption. There's another question from Rishma Lada. She asks, are there studies done to explore causes or reasons of why women are less likely to be referred to cardiac rehab? So it's right along your.
So there are 3 layers of this. So we have the referral layer, then we have the participation layer, and then we have the engagement layer, right? Because for cardiac rehab to occur, a person needs to be referred, then they need to answer the phone call after they get referred and agree to come to an intake, and then they have to come to the sessions. So on the referral piece alone, this is very often an issue with bias, and also the reality is the reasons for low participation in cardiac rehabilitation are very similar for men and women. Men and women, if you ask, why is it that you didn't participate in cardiac rehab? Men and women would tell you that because my doctor didn't tell me to. And I say doctor because that's what we refer, but I think this goes for any healthcare provider. We are so good at the time of discharge, our patients, we come in with our discharge summary, our AVS, and we say, okay, you're supposed to be on aspirin and Plavix, you're supposed to take your statin, don't forget to take a beta blocker, use your nitro spray if you have chest pain. We give all of these advices that they take to heart and they have it in their paper, but we don't always tell them, and when you get that call from cardiac rehabilitation, be sure to come and participate because it's going to help you get healthier and it's going to help you prevent future events. We don't systematically do this to the same effect that we recommend the medications to them at the time of discharge. And that's the number 1 reason people don't participate, men and women. And perhaps this is even further magnified in women. Then in women, there are still additional layers of complicated things that have historically been reported as preventing women from participating in cardiac rehabilitation, which very much have to do with social factors. Sometimes they don't even perceive that they need it. Take a SCAD patient, they're usually young and healthy and they already run anyways. Why would I come to rehab? But then there are transportation barriers. They don't have a ways to come to the track. And nowadays with virtual delivery, hopefully this is going to be mitigated. Sometimes they just don't have the time. They are the central piece of their household and they have to take care of everybody else and the dog before they take care of themselves. So it goes lower on their priority list. There is also this perception by some women, and it's been reported, I'm not just coming up with this, that it's been reported that some women perceive cardiac rehab as a boys' club and they don't see themselves fitting fitting in. So to address this, some female-specific programs have been proposed. So it's a very complex issue, but I think the one message that I wanted to leave with you, because I think it's fair to say that most people in this audience today are healthcare providers at some level, is when you see your patients that have had a heart event, have had a procedure, tell them all of your advice for maintenance of health and prevention, and also tell them, and it's important that you participate in cardiac rehabilitation to get you back on your feet, to improve your physical and mental health, and to prevent future events. And so, I think if we say that to the patient, they will take that information just as nicely as they take the information about taking their dual antiplatelet therapy. So that may be a message that everybody can use as early as tomorrow.
I think we have another question as well.
Thank you, Dr. Coutinho. There's a few questions. I think one of them from Emily asks a good question. She says she works as an RN in outpatient mental health. Many of our patients have lots of risk factors. Am I positioned to do brief screening? Do you have any interventions or screening questions that you'd suggest, like top 3, that would be helpful in assessing risk factors?
So some risk factors can be assessed with questions, but some risk factors can only be assessed, for example, with a blood pressure monitor or a blood test, right? I think in the mental health population, probably the number one thing that you can address is probably smoking. Rates of smoking are probably even greater in the population that you care for. And smoking is the number one preventable cause of death in the world in hospitalization. So I think addressing smoking can be very much on par with the practice of mental health providers. So that would be my first advice. Other risk factors very often don't come out in a simple questionnaire, with the exception of family history, right? So family history is also something that you can simply ask for. And to count as family history doesn't mean that anyone in the family had a heart attack or stroke. We want to know who had premature disease. So for men, did they have any first-degree family members that had a heart attack or a stroke before the age of 60? And any female first-degree family member that had a heart attack or stroke before the age of 65? That is what we consider a positive family history for premature atherosclerosis that we should also consider, and we're going to treat that individual differently. If their grandma had a heart attack at 75, it's unfortunate, but it doesn't count as a positive family history. So that's something else that you can also obtain with a questionnaire. Everything else, I think you're going to have to send them for blood tests to check the cholesterol, the blood sugar, or actually measure the blood pressure.
And we have one more quick question from the audience. Very popular session, Dr. Coutinho.
That's great. Sorry, I'm not sure if I'm not hearing the question.
Sorry, Nazli, can you help turn the mic on maybe? Is that, thanks, perfect. Sorry, we just need to turn the mic on here.
No problem.
Hello, can you hear me now?
I can.
Okay, it's Sylvie working in cardiac imaging. I'm a nurse here who's been at it for 35 years. And always in the Heart Institute. So I'm learning a lot more today. And like I said, I don't know why I get all nervous about talking and sharing. And I'll have a female patient in front of me and she'll have a hard time expressing herself. And I'm telling her to advocate for herself and to feel like she needs to be heard. There are a lot of patients that we see in cardiac imaging who have been referred by yourself, who are SCAD patients and who do follow up in rehab. I know of some who followed up and have been very grateful for the program. So that's one positive. The other thing is that thanks again for sharing. We see patients that you refer for PET, microvascular, and we're all kind of going, well, what's that all about? You know, why are we doing these tests on patients who we know have had coronary angiograms with normal coronaries not that long ago, and she's referring them. It's like, well, what are we going to change here? So again, it's not without doing research and without referral and without advocating that we're going to see changes for women in heart disease. And again, these are young women who are athletic, who don't necessarily have all the risk factors. So I'm grateful that I'm working in this area and finding out a lot more, even though I'm pretty old at this. And like you said, old school, atypical symptoms. We're still asking patients about atypical chest pain and not necessarily. So I am through this trying to advocate to my female patients that are sitting in front of me coming in for a CTA saying, my patient says my husband, well, him too. My doctor says I have anxiety, and why am I here? Like, well, we have to look at everything, and not necessarily anxiety, or I get chest pain when I'm anxious. Well, we need to look into that. So just a quick feedback from myself that I'm grateful that I have this job, and I'm going to forever, how long I'm here, advocate for my women patients who are, you know, not necessarily being supported.
Thank you very much for this very wonderful, thank you for this wonderful commentary. And I wanted to just address for you, just so you know, because you're working there and you're seeing all of my referrals for PET, and you probably think I'm crazy. The reason I do this, these women that have unexplained chest pain, that have normal coronary arteries on cath or CT, theoretically, PET myocardial flow reserve is reported to be the best way to look at microvascular dysfunction, and that's why I send them. However, I will tell you that in my experience, the myocardial flow reserves are almost always normal, and this is why I'm working with Dr. Beanlands and Dr. DeKemp and Anna Hita and others on some research projects to try to understand what may be a better cutoff of myocardial flow reserve, or maybe a different parameter from the PET that we can look at that may give us a little bit better answers as to the microvascular function. So that's why I'm sending you all these patients, even though you may not understand, but there's always a method to the madness. So thank you for putting up with me.
Thank you so much again, Dr. Coutinho, for another amazing, informative presentation. We'll give you a round of applause.
Thank you very much. And I'm going to go to the airport and get on a plane to Ottawa. So I'll see you all tomorrow.
We wish you safe travels home. Thank you.
Thank you so much. Bye-bye.
I'd like to introduce our next speaker, which is a woman with lived experience, Rochelle. So Rochelle is a retired nurse, and she is here to share experience of having a spontaneous coronary artery disease, or SCAD. So c'est ma plaisir d'introduire notre prochaine lauréature, Rochelle. Bienvenue, Rochelle.
Bonjour à tous. J'ai eu une dissection spontanée d'une artère coronaire en avril 2021. Tout a commencé durant la soirée lorsque je me préparais à prendre un bain. En brossant mes dents, j'ai senti une douleur soudaine et intense à la partie supérieure de mon thorax. La douleur s'est présentée sous forme de bande d'une épaule à l'autre. À ce moment, j'ai pensé que la douleur disparaîtrait aussi vite qu'elle était apparue. J'ai quand même pris un bain rapidement. La douleur persistait, je me suis sentie très faible et mes mains sont devenues blanches. J'ai alors réalisé que la situation devenait sérieuse. J'ai appelé mon époux et je lui ai demandé d'appeler 911, lui disant que je croyais être en train de faire une crise cardiaque. Je me suis allongée sur mon lit et quand les paramédics sont arrivés, ils m'ont donné 2 aspirines à croquer, ils ont vérifié ma tension artérielle et m'ont fait un ECG. Ils m'ont ensuite transportée à l'hôpital général. À cause de la pandémie, mon époux n'a pu m'accompagner. Je sentais le besoin d'être vue par un médecin, mais je pensais qu'il me renverrait probablement à la maison. La douleur était toujours présente, mais je ne pouvais croire que c'était vraiment une crise cardiaque. À la salle d'urgence, l'infirmière m'a admise et le médecin m'a vue très rapidement après mon arrivée. On m'a fait des prélèvements de sang, une radiographie pulmonaire et un ECG. L'infirmière m'a dit qu'il répéterait la prise de sang 4 heures plus tard. Et 4 heures plus tard, la troponine était très élevée, ce qui confirmait la crise cardiaque. Le cardiologue m'a prescrit des médicaments et m'a dit que j'aurais une angiographie à l'Institut de cardiologie dans quelques jours. À l'angiographie, on pourrait voir s'il y a un blocage des artères coronaires ou une faiblesse du muscle cardiaque causée par l'infarctus. À l'angiographie, à l'Institut de cardiologie, le cardiologue est venu m'expliquer le résultat. Il m'a dit que mon muscle cardiaque était intact et les coronaires étaient normales pour mon âge. J'étais surprise et soulagée. Le lendemain, j'avais mon congé de l'hôpital avant mon départ, le cardiologue avait des détails supplémentaires au sujet de mon angiographie. J'avais une dissection spontanée d'une artère coronaire. La dissection se situait dans une branche de l'artère circonflexe et elle était bloquée à 80%. Malgré tout, j'étais chanceuse à cause de la localisation et elle cicatriserait en 3 à 6 mois. L'infirmière m'a donné de l'information sur les maladies cardiaques, la dissection spontanée de l'artère coronaire et la médication que je devrais prendre pendant 1 an. À la maison, je me sentais faible et fatiguée pendant les premières semaines. Un physiothérapeute de l'Institut de cardiologie m'appelait régulièrement et me guidait avec les exercices recommandés. Une diététicienne me guidait aussi afin de réduire le sel, le sucre et le cholestérol. L'infirmière de la clinique de la santé cardiaque des femmes m'a aussi beaucoup aidée. Lorsque j'étais inquiète au sujet de douleurs thoraciques ou des effets secondaires des médicaments, elle a toujours été patiente et m'a donné de bons conseils, car dans une telle situation, l'on se sent vulnérable et parfois anxieuse. En août 2021, un IRM a confirmé que j'avais la dysplasie fibromusculaire. C'est une anomalie de la paroi de certaines artères pouvant entraîner des rétrécissements, des dilatations ou une déchirure comme la dissection. Présentement, je prends des médicaments antihypertenseurs, des bêta-bloqueurs et des anticoagulants. Je me sens très bien. J'ai eu des douleurs thoraciques seulement pendant 2 ou 3 mois suivant ma dissection et la nitro en aérosol a soulagé la douleur. J'ai eu quelques consultations avec une cardiologue de la clinique de la santé cardiaque des femmes. Ça m'a aidé beaucoup à comprendre la maladie et le résultat des tests. Car si on ne comprend pas, on pense toujours au pire. Ma mère est décédée à l'âge de 38 ans d'une hémorragie cérébrale et c'est possible qu'elle souffrait de la dysplasie fibromusculaire. Je suis une infirmière à la retraite et naturellement, j'ai beaucoup de respect pour les infirmières et la profession médicale. Je suis reconnaissante pour les bons soins que j'ai reçus pendant mon hospitalisation et ma période de réhabilitation. Alors, je remercie chacun et chacune pour votre travail extraordinaire, spécialement durant cette pandémie. Merci. Do you have any question? Happy to answer.
Merci beaucoup, Rachel. J'ai une question pour vous. Selon vous, qu'est-ce qui était le plus utile pour votre récupération après le SCAD?
I think it's the exercise and the medication, and just follow step by step with what the doctor, the physiotherapist was telling me to do, like start slowly, and if you're tired, just stop and rest, and next day add a few minutes more. So, and the diet naturally, I guess. Even I was trying to eat well before, but I made an extra effort to eat even better after. That good, please.
Thank you so much. Are there any questions online? Nope. Bonnie, you can take it away.
Okay, so our next speaker is Nazli Parast. She is the clinic nurse for our Women's Heart Health Clinic and Hypertension Clinic here at the Heart Institute. So Nazli will share with us the nursing role in the Women's Heart Health Clinic and the care provided to patients. So welcome, Nazli. Hi, everyone. Just waiting for my presentation to load. Perfect. Hi, everyone. My presentation is about nursing implications for clinical practice. Just to give you an overview, I will be talking about a survey that we had done at the Heart Institute with the staff to just give you an idea of how we got here. And then I will talk about how our clinic is run and what is my role in our clinic at the Women's Heart Health Clinic. So just want to start to review the survey that we had done in May at the Heart Institute, having a staff to just give us their knowledge or opinion about the women's heart health. We had the survey done and it was answered by 248 participants. The survey had 10 questions. Most of the participants were actually nurses who answered the questions. We asked them about if they have heard about MINOCA, and I mean, I guess most of you, and most of you answered no. So I will go over these information quickly. Their acronyms, I believe Dr. Coutinho already addressed most of the acronyms. I will come back and give you a little bit more information at the end as well. We asked people what do they think of INOCA stands for. Majority of people actually answered that correctly. We asked when compared with men, women tend to have symptoms of ischemia more often when, and most people answered when they're performing activity, but the correct answer was during rest and sleeping. But quite a bit of people actually got it right. We asked what factors put women at higher risk for cardiovascular disease. Majority of people answered correctly. It was all the above, but there was still some need for improving the knowledge because there was still some participants did not answer it correctly. We asked which of the followings are true, and the correct answer was that cardiovascular disease is the leading cause of death among women. Again, we had majority of the participants answered correctly, but there was still a knowledge gap that we recognized there. The next question, again, was about which of the following is true, and majority of people actually got that correctly. Depression is twice as common among women as it is among men. We asked what are some of the classical risk factor triggers for development of a SCAD. Most people answered correctly, it was all the above, but there were still a big portion of people did not select all the answers, which included all the options. We asked if the staff participants received the previous education regarding women's heart health.
Most individuals said no. And then we asked if they're interested in women's heart health education, and most people said yes. So there we are. We are providing you with education based on your needs. To give you an overview, as you know, women are less likely to recognize the signs of heart disease and to seek help early. To add to that, a woman with lived experience realized that women's cardiac health is understudied and that some professionals may not recognize a woman's cardiac symptoms. As Dr. Coutinho mentioned earlier, women and men share similar risk factors for heart disease, such as diabetes, smoking, high cholesterol, physical inactivity, stress, anxiety, and hypertension. However, women face unique range of risk factors, such as menopause, particularly when menopause occurs at a younger age, pregnancy-related complications, giving birth to underweight baby, preterm delivery, having irregular menstruation cycle, potentially being on certain birth control medications, having polycystic ovarian syndrome, having history of breast or gynecological cancer treatment. A woman may experience a distinctive set of symptoms when they're having heart attack. So neck, jaw, shoulder, upper back, or abdominal discomfort, shortness of breath, pain in one or both arms, nausea, vomiting, sweating, lightheadedness, dizziness, unusual fatigue, or indigestion, as Dr. Coutinho mentioned. So as nurses, we have a unique role in making a difference in our patients' lives by hearing them and advocating for them. It's very important that we ask them questions to allow them to answer those questions, to help them to make connections, having them paying attention to their responses and listening to them, and making connections between the information they're providing to us, and also documenting them, because that's what is needed for collaboration. So you need to communicate with the physician, with the staff at the clinic, with other healthcare providers that are in the circle of care with the patients, and as well as with the patient. And the next and most important thing is advocating. So I guess earlier we mentioned that advocacy is a huge part of understanding women's heart health, recognizing it, and helping them to advocate for themselves, teaching them to advocate for themselves, and then raising awareness. So my nursing role in the clinic, the Women's Heart Health Clinic, I usually ask series of questions from my patients at every visit, especially the first visit, to collect as much information as possible for the healthcare providers I'm working with. So I asked them about the distinctive set of symptoms that they have. And then I asked them about pregnancy history, gestational hypertension, if they had gestational hypertension, gestational diabetes, preeclampsia, low baby birth weight, premature birth, hormonal therapy intake, history of gynecological surgery. I also asked them female-specific risk factors, such as polycystic ovarian, if they had polycystic ovarian syndrome, if they already reached their menopause or they're during their menopause, if they've had early menopause, about their menstruation cycle, if they're taking birth control medications, if they had history of gynecological cancer or treatment. And I also asked them about the family history. So there's quite a bit of information. It takes a long time to get all those information to make sure that I am fully understanding my patient. Our clinic consists of 3 physicians, Dr. Coutinho, Dr. Paquin, Dr. Gruba, and I am the nurse for the clinic. In our clinic, we see patients with SCAD, MINOCA, INOCA, ANOCA, and also for evaluation of cardiovascular risk in women with hypertensive disorder of pregnancy or gestational diabetes. With help from my manager, Bonnie Quinlan, and the clinic physicians, we developed template and policy to help structure the nursing role at the Women's Heart Health Clinic. We developed templates to make sure we're following, we're all looking at the same thing, we're all meeting each other's needs and getting as much information as possible from the patients. We are sending letters to the patients prior to their visits, providing them with guidance and videos and providing them educations. We have a policy in place, so for the nurse to follow to make it more structured. We also developed an education session for patients. There are a series of education sessions. They're going to be repeated during the year. Once a month, there will be a presenter providing that education. It's half an hour presentation, half an hour Q&A. All patients are welcome. It's actually posted on our patient calendar at the Heart Institute website. So to encourage people to participate, whether they've been referred or not, they can, at the beginning of their referral, whether they've been seen or not, we are encouraging them to attend the session. We also developed a Women's Heart Health Guide. I was hoping to have it so I can hand it in to you guys, but unfortunately I don't have it on hand, but it's in the last line of completion. So the patients voiced that they need a Women's Heart Health Guide. We developed one. We had it assessed by the patients in our clinic, and we had it reviewed by nurses, physiotherapists, dietitians, cardiologists, and the psychologist. So everybody brought their expertise into that guide, and it's in the last step through communications, and it should be coming out shortly. So we can certainly provide that to you later. It will be in our website. We have an interactive voice response technology, and which is an automated phone call to patients. It's done pre-initial visit every 6 months for 2 years. The goal is to improve patient care, patient knowledge, and clinical outcome, to improve the patient experience at every clinic visit, to assess the impact of Women's Heart Health Clinic on patients' quality of life over the duration of their clinic participation, and also to increase patient satisfaction. We have, there are some Women's Heart Health resources, supports available for the patients in our clinic. Of course, the cardiac rehab program that offers a lot of support to our patients. The Women at Heart, which is a peer support program, that's a great support to patients, which you will hear more about it this afternoon at one of the talks. And then the Cardio Prevent postpartum program is a heart health program that helps people with risk factors lower their chances of developing cardiovascular disease. Again, you will hear more about it this afternoon. That's it. Well, if you have any questions, please let me know.
Just to get a question started off for you, for your corporate staff survey that you did, do you have any plans to repeat that survey after some education is done?
Yes, actually, so that initial survey was done in May, and we're hoping to provide education along the way, which today is one of them. And we also provided nursing education during the nursing week. And we're hoping to have that survey redone again by January to just assess to see if there has been a knowledge improvement.
Thank you. Are there any questions online?
There are no questions online. Thank you.
Yes,
Oh, sorry, buddy.
Sure.
Nazli, thanks a lot for the presentation and all the work you've done in the Women's Heart Health Clinic to make it a really comprehensive program. I know you mentioned the guide is coming out and some education sessions. I know from looking at the list of participants, there's a lot of people that aren't from the Heart Institute. Are they able to download that once it's done off the website and use it for their own patients?
Yes, certainly. So all the information will be online. So thank you for the question. So we have the education sessions are actually already posted online in the patient's calendar at the Heart Institute, and the booklet will definitely be online for anybody who would like to download it. We also might actually be able to attach it to the link that Sandra put in. So if it comes early. So, but certainly we will keep you guys updated.
That's awesome. So please do make sure that your patients get access to Nazli's amazing class and also the new booklet when it comes out. Okay, so our last speaker before break is Tammy. So welcome, Tammy. She ran into some unfortunate traffic problems earlier, but we're so glad that she made it here safe and sound. So Tammy is 44 years old with 5 kids, 3 plus 2 stepkids. She's currently a manager in the federal government, and she's here to share her journey of getting a cardiac diagnosis. Welcome, Tammy.
Thanks, everyone. And again, sorry for the traffic. I think after 2 years of working from home, you forget how bad the traffic on the bridges. So thanks for rearranging the schedule a little bit. I'm going old school, so sorry, there's no slides. So first, I just want to thank Nazli and Bonnie and the team for organizing this really important event and asking me to talk here today. When Nazli asked me if I wanted to kind of share my patient story, I didn't hesitate because I've received such great care here at the Institute, and I think it's so important to give back and to spread the word out about women's heart health. So about my story, it's funny how when you go through some kind of life-changing event, there's like a clear line of like the before and after. So I kind of see the before and after my diagnosis that was last year. But there's also an in-between in my case that I really like to focus on because that's where I think we can learn and improve on. So my heart story started 6 years ago when I was 38. At the time, I was married with 3 kids, aged 5, 7, and 9. And I was in the middle of my career in federal government, so kind of like your typical middle-aged woman, you know, dealing with tons of things, juggling all these balls in the air. And I remember kind of having these chest pains that would sort of come and go for weeks. And they were like little like jolts of lightning that would just kind of come on all of a sudden. And luckily they didn't last long. It would just be like a split second because they were really painful. But I also had chest tightness and breathlessness. And the breathlessness came like when I was exercising, obviously, but also just like out of nowhere, like when I was talking or walking. So it was definitely, you know, I was getting a little bit worried because this wasn't normal. So I brought it up with my family doctor at one of my, you know, regular checkups. And at the time, I was active, you know, I was running around with the kids, I was exercising and stuff. And skinnier. COVID years haven't been that kind, but you know, I didn't smoke. I, you know, rarely drank. I didn't have a history of blood pressure, cholesterol, all that stuff. I was like a fit 30-year-old woman. And so my doctor asked me a few questions. You know, he didn't really perform any tests. He kind of listened to me with his stethoscope, and he pretty much said, "Oh, your chest pains are muscular. You're suffering from anxiety, and yeah, I'm going to prescribe you some pills," which I never took, luckily, because I didn't feel like that was really what was representing what I had. So I have to admit the whole experience kind of made me feel like I was being dismissed for making too much out of nothing. But these symptoms kind of persisted, and at one point, my breathlessness and generally not feeling well, I got worse. So one day I ended up just coming to the hospital, and you know, they did an ECG and a blood test. Everything was fine, so they sent me home. Fast forward to maybe 6 months later, I was biking up a small hill close to home, and then my chest pains got really bad. So I thought, oh, you know what? The hospital's right there. I'm just going to bike over. So I biked over. And so I'm like, maybe they'll find something this time because I'm actively, you know, in pain. So they did an ECG, and ECG is still normal, but this is where things kind of got interesting because they did a blood test. and my troponins came out slightly elevated. So they weren't extremely high. They were like at 50, but still weird for my profile. And it was funny because I remember the doctor, it was like 2 a.m. I was in the, been waiting forever at the hospital, and I could just hear like blah, 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 myocardial infarction. I hope I said it right. And then she kind of left. She said, I'll be back. And at first I was like, I think that's not a good word. I didn't know what it meant. So I Googled it really fast while she was gone. I'm like, oh, wow, that's serious. She's like telling me I might have had like a heart attack. So I was like, whoa, I'm 39. Like this isn't, supposed to happen. I have no history. I'm healthy and all that. So this triggered a whole bunch of tests. I got an angiogram done, CT scan, you name it. And everything came back normal. So after about 5 days in the hospital, they'd said, everything's good. You can go home. Maybe you had myocarditis. We're not sure, but it's, it's a short-term thing. We'll treat you first. I forget the medication they gave me, but you'll be fine. And the doctor, I'm like, so what next? And the doctor was like, just go live your life. That's actually what he said. So I'm like, okay. So that's what I did. I returned to my normal life, and I still sometimes felt off, but I got better, and I got back to my routine of, working out, taking care of the kids and all that. And I told myself maybe I was just exaggerating, or it was myocarditis. I'm fine now. Get a grip. So fast forward to another year later, I was just kind of sitting down at a conference like we are today. I'd been having some chest pains and a bit of breathlessness, for the last few weeks. And then all of a sudden, I just kind of felt this like, whoa, I don't feel good. And I'm like, I have to go to the hospital. I just kind of knew it. So what do? I drive myself over to the hospital. I was close again, very close. Same thing as before, normal ECG, slightly elevated troponins. So that sparked a whole bunch of other tests. And again, after 5 days in the hospital, they can't find anything. So they send me home. When I asked, before I was sent home, I asked the cardiologist, I'm like, so what's my diagnosis? He's like, myocarditis again. I'm like, what is that? Like, is that normal? A year later, I get myocarditis again. So I wasn't really convinced, and I don't think he was either, but I felt like he didn't really have the time for me. So I went home. Another year later, like you can see a pattern starting. I'd been living my life as the doctor had prescribed. And, I was generally good, but sometimes like chest pains and breathlessness would kind of come back, but, they would kind of go. So sometimes, especially when I was like in a stressful situation, whether physical or mental, I would get them back. But again, they would kind of ease. So, I didn't kind of think anything of it. I would work out and stuff. And I remember one time going biking in Gatineau Park, and I went by myself, and I had a really strenuous bike ride, and I had some chest pains, like, ooh, that's kind of weird. I shouldn't be biking by myself, So that kind of scared me a little bit, but I kept on saying, the doctor said I'm fine. It's not my heart. So whatever, I'll chill about it. So at one point, my chest pains and my breathlessness were building up for about a week. And I knew the drill. So I went back to the hospital again, and same thing. ECG normal, troponins elevated, but this time I had like very low hemoglobins. So it was like a new factor. So that triggered a whole bunch of other, doctors and all that tests, and everything was perfectly fine. I'm like perfect bill of health. And so after 5 days again, the doctor sent me home, and he said, it's probably your hemoglobins that cause your elevated troponins. I'm like, okay, that's fine. I can deal with that diagnosis. And so, so I went back home. So things were again normal. So that started, like I said, 6 years ago. So things were pretty normal. And then one day I went through a really stressful situation in my life. And I remember the breathlessness kind of came back a few days later. And I had totally forgotten about all the other episodes. Well, not forgotten, but I didn't have a lot of chest pains at that point. And I remember one day, like talking to my partner, I'm like, oh, I'm feeling breathless. That's funny. And then I'm like, uh-oh, I remember what that means. And sure enough, that day I got this really bad heart pain. And I'm like, oh, I called him up because he wasn't at my house. I'm like, I have to go to the hospital right away. And so he came to pick me up, and he's like, you know what, Tammy? She's like, this is where like my story changes. She's like, let's go to the Civic, because I'd been going to the hospital on the health side. That's very close to my house these past 3 years. He's like, seriously, like if you can take the 20-minute drive, I'll bring you there. I really want to bring you to the Civic. So I'm like, okay, just whatever, drive fast. And honestly, it was like the longest drive I think in my life, because at that point I really wasn't feeling well. I felt like this the world was closing in on me and I was going to pass out, and I was, I was probably panicking. I was getting really scared, but I'm so happy I came to the Civic. So of course, the first, few minutes is the same drill and triage. Normal ECG. I kept on telling them I always have a normal ECG, and elevator troponins. Some other tests followed, and at this point, I've probably had every test imaginable. I'm like, I'm pretty certain that I'm healthy and all that. But this time I tried to push back a little. So a doctor would come in with students, like I think they were residents and stuff. So they would ask a lot of questions, and I kind of pushed back. I was emphasizing that I've been through a lot of stress lately. Could this be a factor? This is my 4th time in 4 years being hospitalized. Like this can't be normal, So luckily my cardiologist at this point was Dr. Coutinho. Up until then, I have to say I'd been followed by, middle-aged male doctors, in their 50s who, I have to say, kind of made me feel like I didn't know anything about medicine, which I don't. I never said I did. But I was so happy to have Dr. Coutinho on my side, and luckily she kind of pushed. She's like, you know what? Something's weird here. Let's do another angiogram. So a doctor did an angiogram on me, and it was normal. So while I was still on the table, he's like, your angiogram's fine. Why are you here? And I'm like, well, I don't know. I keep on getting these chest pains, especially when I'm stressed and stuff. So he's like, you know what? I can do another test for you. She's like, since you're here and I've got this thing in your heart, he's like, I'll do another test. I'm like, okay. He's like, you won't feel good for a few minutes. I'm like, I already don't feel good. You've been in here for 15 minutes. So it's okay, but this time it's different. I'm inserting something metal, I don't know, in your heart. I don't know. He's like, you really can't move. I'm like, okay. So yeah, and then he inserts some drug in me to, I don't know, make something, my heart go wild, and I really wasn't feeling well. So he was next to me. He's like, okay, you're good. He's counting down, a minute left. You're doing good. And I'm like, oh my God, it's like so like not good. It's like 30 seconds left. So finally he gives an antidote or something. I felt good after. But he's like, yeah, I saw something. So it explains all your, what you've been feeling. Oh, great. But I'm still a bit buzzed from, the angiogram. I'm like, okay. So then I go to my room. I'm like, what did he see? He doesn't tell me. Luckily, there's my chart. I think that's amazing. I mean, I am from on the Quebec side. My chart's awesome. I found out before the doctor came in to tell me what I had. So basically, yeah. So I find out what it is finally. Does anyone want to take a guess? Well, close. So yes, so I was actually diagnosed with MVD, microvascular coronary artery disease. So Dr. Coutinho was talking about that, and MINOCAs, reoccurring MINOCAs. So as Dr. Coutinho explained, I'd basically been having like mini heart attacks all these years, which was like, wow, like that's crazy. I'm here. I'm happy I'm still here. So that was a big shock, and obviously it's hard to take, right? When you're 43 and you're told, oh, you have heart disease. It sucks, I admit. But above, all of that, and that I was scared with the diagnosis, I think I was so relieved. Like honestly, I think I like cried tears of joy and relief, because finally someone had listened to me. And after all these years, like I wasn't overreacting. It wasn't anxiety, as people like to say, oh, you're a 30, middle-aged woman, you have all these stresses, you're suffering from anxiety, here are pills. I'm so glad that I had finally like listened to myself, and someone had listened to me, and I kind of felt vindicated. Obviously after that, I kept waking up being like, oh my God, I have heart disease, like holy moly, how can this be? So, but the most frustrating out of all of this, if you can believe, is that I had asked the doctors from the beginning about MVD, because luckily my mom had done some Google research, and so it goes to show you that moms are always right. She's like, ask them about MVD. So I asked my doctors about MVD, and they dismissed me every time. They're like, no, it's not possible. You don't have any of the factors. You're young, blah blah blah. You don't fit the profile. So that was really frustrating after 4 years of going through this, kind of being diagnosed with the thing that I had kind of asked them to look at from the beginning. it could have avoided. I mean, luckily I'm here. Luckily the MRIs and all that, it didn't indicate any permanent damage to my heart, but it could have easily been. And I mean, I have 3 small kids, so it was a very difficult thing to realize. So since my diagnosis, I've learned a lot. For instance, I've learned that it's really important to listen to my own body and my intuition and to be my own advocate. I know someone was talking about that before. It's so hard. I don't know why in our society for women to just advocate. I think we're just so scared to be like, hey, sorry, I know I'm not knowledgeable about, cardiology, but maybe it could be this or whatnot. And also I think the feedback I was getting from my doctors at the time was just really negative. I mean, when I was in the hospital, the doctor would literally give me 2 minutes of his time. And I mean, at that point, my troponin levels were going up and down. He's like, yeah, you're fine. You can go home. I'm like, what? This is crazy, but whatever. So yeah, like I don't have a PhD in medicine, obviously, but I'm 44 years old. And I think that gives me maybe a bachelor's or a master's degree in like the knowledge of my own body. I know when something's up. I know, when something's not right. I've also learned that, women experience heart disease differently, as was mentioned previously. And even though, heart disease is the leading cause of death for women, less than 40% of participants in research studies are women. So we need to kind of change those statistics. I've also learned that MVD isn't very well studied. If I'd had my symptoms 15 years ago, I might not be here right now. I might not have been diagnosed. So, I think what astonished me the most when I started reading up on facts about cardiology and women is that, learning 1 in 3 women are affected by cardiovascular disease. And, these statistics blew my mind because all my life, I've heard about breast cancer awareness and the need to get a pap test to screen for cervical cancer. I mean, those are drilled into you from a very early age, but I've never heard about heart disease being the leading cause of death for women over 35. And so personally, I'm trying to get that message out to all my friends. And, as soon as someone's going through stress and they're not feeling, I'm like, have you thought of your heart? Just like always mention that to your doctor, because I think women, especially women in like their midlife, we're not forgotten about, but, people kind of, they don't dismiss us, but, someone that they're in their 70s that's not feeling well, they're going to think, okay, heart disease or, anything else. But a woman in her 30s or 40s, they'll be like, oh, you're fine. It's just stress. It's anxiety. It's normal. You have a family, you have career, you might have aging parents you're taking care of. So I think it's important for people to realize that we need to push more because it's occurring more often. So, clearly there's still a long way to go in terms of awareness for women's heart health. But I count myself really lucky that I decided to come here that day last year, and that there's this Heart Institute in Ottawa that's doing great research and work with top-notch, cardiologists and staff. I think the staff from every line has been amazing, from the person who wheeled me to my tests and he would give me like a heated blanket to the nurses, to the support groups. It's been amazing. And as far as recovering from heart disease, it's been really well. Like I've been really well taken care of. And I'd like to thank in particular the Women's Heart Health Center, who are doing such great work in increasing knowledge and awareness for women's heart health. So thank you so much.
Thank you so much, Tammy. Such a great, just great sharing from you about your experience. Just going to start our Q&A question off with looking back at your journey. What advice would you give to healthcare professionals encountering patients with cardiac symptoms? You alluded to it a little bit, listening to their patients' symptoms and taking them seriously. Would you have other advice for healthcare professionals?
Yeah, I think the first would be think outside the box. Learn more about MVD because there wasn't a lot of knowledge, and just listen to your patients. Don't just chalk it off to like anxiety or someone who's exaggerating or whatnot. I'm sure there are instances where people exaggerate. There's nothing, but I've heard so many stories since I've been through this with all my peer support groups that women are often told, oh, it's anxiety. They're just, I find it's insane the amount of times that they're told they're just dismissed. And when you look at the stats, I don't understand how that's possible. Like when the stats are clearly saying that women are dying from heart disease, why aren't we listening to them? So that's what I would say.
Thank you so much, Tammy. There is a question online from Ariane Campbell. Her question, she says, thank you for sharing your story. What did your treatment consist of for MVD and how are you doing now?
Thanks. So I think it's more about managing managing my stress levels. So what I did is I kind of took part in all of the support groups that are offered, whether it's managing stress, women at heart, health, wellness and all that. And it's a little bit of a hit and miss because I think maybe for MBD it's different for everyone, right? You have different triggers. For me, it's mainly like emotional stress that can happen, but not like big stress. It could just be little things like, oh, I've had a busy day at work, I'm flustered, there's so I have to kind of like really meditate and relax, and that really helps me. Obviously I've been diagnosed, I've been prescribed medication by my doctor, but we're still kind of working out how that works, because the thing with me is I don't have high blood pressure, so normally they would prescribe like a beta blocker, but my blood pressure is really low. So she's like, if I go any lower you're going to die from low blood pressure. So it's been a little bit difficult on that end for me, but it's more managing my symptoms for now and slowly getting back to exercising. That's been really hard because it's been a year, and I used to like to bike, and I have to be careful with that. So my partner bought me an electric bike, and which is good. At first I was like, come on, I'm too old, I'm too young for an electric bike, but I'm like, oh, my heart's old. so I guess I do need one. So yeah, I'd say that.
That's great. Thank you so much, Tammy. There's just some comments online, just again about how inspiring your story is. A comment from Jane, she says, I also wonder if any associated anxiety should be viewed not so much of a diagnosis, but a symptom of potential trouble. Who wouldn't be anxious worrying about a potential undiagnosed heart problem? So I think you alluded to it in your story there, just that, yeah, there was a bit of anxiety on your part because you didn't really know what was causing all of this, all of the symptoms, right? So yeah, so great point, Jane. Bonnie, are there any in-person questions? Turn it over.
I don't think so, Sandra. So we'll just have a big round of applause again. Thank you so much. Okay, everybody, it is time for a short biological break. So we at 10:30, if you can, for our next speaker. Sandra and I are actually going to be drawing the first 3 prizes, just maybe at 10:28. We'll draw the 3 first names for the great prizes. So thank you, and I'll see you soon. Next speaker, Dr. Amélie Paquin. Dr. Paquin is a fellow in the Women's Cardiovascular Health, Clinical Research and Advanced Echocardiography at the Heart Institute. She will share the important issues of cardiovascular disease and pregnancy. Welcome, Dr. Paquin.
Thank you very much. So very happy to be here today to be talking to you about cardiac diseases and pregnancy. So as mentioned, I'm a fellow in the Women's Heart Health Clinic. I also participate in the cardio-obstetric clinic with Dr. Abiba Garuba. So I've separated my talk to answer 3 main questions. The first one is, why is it important to talk about cardiac diseases and pregnancy? What are the different cardiac diseases, or what are the different aspects of cardio obstetrics, and how can we manage these conditions and improve outcomes? So first of all, why should we talk about cardiac disease and pregnancy? Well, mainly because cardiovascular conditions remain one of the primary causes for maternal death. If you see on this graph here that shows the causes of pregnancy-related death in the United States between 1987 and 2013, we can see that cardiovascular conditions remain predominant, but not only do they remain predominant, but as opposed to other causes, they are on the rise. Why is that? There's an increasing number of pregnant women with cardiac disease and or cardiac disease risk, which can explain why more of them can have significant complications from their pregnancy. There is now a better life expectancy, a better treatment of women with congenital heart disease, meaning that more of these women can now carry a pregnancy, increased diagnosis of inherited cardiac diseases as well. There's also a better treatment now of valvular heart disease and other acquired cardiovascular conditions, thus allowing these women who beforehand could not undergo pregnancy, but they are now more and more becoming pregnant. And I think one of the main reasons too is that nowadays more and more women have their first pregnancy at an older age, which means that they are at higher cardiovascular risk or that they could have other chronic conditions that could affect their cardiac risk during pregnancy, such as hypertension and obesity. So just to show you a few numbers from Canada, there's this registry that was done, the CARBREAK-2 study, which we can be very proud of. It's a study that's been used worldwide. And in this registry, they looked at about 2,000 pregnancies in women with known cardiac disease between 1994 and 2014. And they noted that cardiovascular complications occurred in about 16% of these cases. And the most frequent complications were arrhythmia and heart failure. And serious cardiovascular complications occurred in 3.6%, and death occurred in 0.4% of these cases. Here is the list of the serious cardiac events that were reported in this registry. So you can see that the main causes were the need for a cardiovascular intervention, congestive heart failure, arrhythmia, myocardial infarction, also a few cases of death, cardiac arrest, stroke, thrombosis of the valves, endocarditis, and aortic dissection. But what's most striking about this graphic is not only the number of cardiac events during pregnancy, but is that 49% of these events were deemed to have been preventable as per the authors. So there's definitely something we can do to improve these outcomes. So why should we talk about cardiac disease and pregnancy? Well, there's a need for enhanced training and awareness of the primary care professionals to detect underlying cardiac diseases. Also a need for better specialized training of cardiologists, internists, a need also for better access to specialized cardiobstetric care and cardiobstetric clinics, as well as enhanced patient awareness of what their cardiovascular risk could be during pregnancy, what are the treatments, and what is the follow-up that is recommended. So now the what question, what are some of the aspects or some of the diseases that we see in the cardiobstetric clinic? Well, one of the main reasons of consultation for the cardiobstetric clinic are valvular heart diseases. That includes bicuspid aortic valve, rheumatic valve disease, mitral valve prolapse, previous valve replacement, or mechanical valve. And especially in that case, there's a discussion to be had regarding the anticoagulation during pregnancy. We also see patients with acquired or genetic cardiomyopathy, one of the main ones being previous or de novo peripartum cardiomyopathy, which is a type of heart failure that can occur during pregnancy or in the early weeks after delivery. This condition requires follow-up, may require treatment, is also a cause of maternal death, and can recur during following pregnancies. Aortopathies is also another indication to seek cardiobstetric care. So we know that women who have dilated aorta and an aneurysm of the aorta, they are at risk of progressing faster. So they are at risk of having their aorta enlarged faster during pregnancy, but they're also at higher risk of dissection. So they are at higher risk of dissection at a smaller size, so much that these patients require a closer follow-up during pregnancy, and they also have a lower threshold for aorta replacement if pregnancy is considered. Pulmonary hypertension is another reason to seek cardiobstetric care. women can also suffer from arrhythmia before their pregnancy or during their pregnancy, and they may need some adjustment with safe medication, safe for the fetus and safe for the mother as well. They may suffer from coronary artery disease. We've been talking a lot about spontaneous coronary artery disease, spontaneous coronary artery dissection this morning. We know that women who are pregnant or in their early postpartum period are at higher risk of having a SCAD, but they can also have atherosclerotic myocardial infarction. And I've put this here last, congenital heart disease. So another reason another indications for patients to be seen in the cardio-obstetric clinic. I've put it last just because in the cardio-obstetric clinic specifically, we see simple congenital heart disease, meaning a small ventricular septal defect or atrial septal defect, previous small repairs. But whenever the congenital heart disease is more complex, usually these conditions will require follow-up by a congenital heart disease specialist even during pregnancy. So why are these cardiac lesions at risk of complications during pregnancy? Well, pregnancy is a stress test on the body. During pregnancy, the plasma volume and the cardiac output increases by about 40 to 50%. So knowing your heart is a pump, so it has to pump 1.5 times the amount of blood and of fluid that it usually does. So it works a lot harder during pregnancy. And 75% of this increase occurs by the end of the first trimester, so very early on during pregnancy. It usually happens by an increase in the stroke volume. So every time the heart pumps, the amount of volume that's going out of the heart during the first half of the pregnancy. And then during the second half, it's increased by a gradual increase in the heart rate. So the heart has to beat faster as well to allow for all this blood volume to circulate. To accommodate for this, the atria and the ventricles of the heart would also dilate in a normal fashion. However, you can imagine that in a woman who's had heart disease before, this ability to dilate, to accelerate the heart rate, and to generate a higher volume of blood with each contraction, this adaptation can be suboptimal in women who already have a heart condition. There's also a decrease in the pulmonary systemic resistance, a hypercoagulable state, which can be of importance, especially in women with mechanical heart valves. And there's also a change in the drug pharmacokinetics, so that can affect the efficiency of the drugs. So increased activity of the liver enzymes, increased glomerular filtration rate in the kidneys, increased plasma volume, protein binding changes, and decreased serum albumin levels. And finally, the delivery itself also can cause a significant cardiovascular stress by the pain that it can cause, the anxiety, but also if there are complications with the delivery, hemorrhage, the anesthesia as well can cause fluctuation in the blood pressure, which can affect the heart condition, infections, etc. So there are certain tools that have been developed to identify among all women with cardiovascular conditions pre-pregnancy, who are the ones at higher risk of developing complications and who are the ones that we should be following more closely. These features include women who've had a prior cardiac event or arrhythmia, a baseline functional class NYHA 3 to 4, so not being able to do a lot of physical activity or cyanosis, a mechanical valve, ventricular dysfunction, high-risk left-sided valve disease like aortic stenosis or mitral stenosis, pulmonary hypertension, coronary artery disease, high-risk aortopathy like Marfan syndrome, the absence of prior cardiac intervention, and late pregnancy assessment. So a woman who hasn't seen a cardio obstetric specialist before 20 weeks of gestation is considered at higher risk of complications. And as you can see on the graphic, the score, as it increases, it's associated with a higher risk of pregnancy-related cardiovascular complications, with the higher risk seen in the group with at least 4 points, reaching about 40% risk of cardiovascular complications. Certain other features have also been identified in this study, but were not included in the score. This include rare understudied cardiac conditions, other maternal comorbidities like advanced maternal age, hypertension, medications like anticoagulation, other cardiac test results, fertility therapy, patient compliance, and patient access to care and quality of care. Another tools that we often use is the Modified World Health Organization classification, which is divided into 4 or 5 if you count the middle class here, 2 to 3. And on the scale of 1 to 4, you can find the lesions, specific cardiac lesions at lower risk of cardiovascular complications, and the cardiac lesions at highest risk of cardiovascular complications, which would actually represent contraindication for the woman to have a pregnancy. These include pulmonary arterial hypertension, severe mitral stenosis, for instance, and certain collagen disease like vascular Ehlers-Danlos loss. For each of these classes is a risk associated, and you can see in the highest class, number 4, the risk of cardiac event is 40 to 100%, so very, very high. This classification also provides recommendations for counseling in everyone, and provides recommendation regarding the care during pregnancy, whether it can be at a local hospital or should be done in a center who specialize for pregnancy and cardiac disease. Minimal amount of follow-up visits during pregnancy, and the location of delivery that should be favored, being okay for a local hospital versus requiring expert center for pregnancy and cardiac disease. Another important aspect of the what is cardiac disease in pregnancy is the medication. Unfortunately, a lot of the medication that we use in cardiology has not been studied in pregnant women or is known to be contraindicated and potentially toxic for the fetus. This includes the ACE inhibitors or antagonist receptor blockers, which we very often use in heart failure or after a heart attack. And these medications are contraindicated during pregnancy, and therefore patients with heart failure need their medication to be changed so that it's not toxic for the fetus. And you can imagine that if we changed all of the medication of these women, that can also trigger the decompensation in itself, adding on top the stress of the pregnancy. So just to summarize what I've been through, so we said pregnancy is a stress test for the body. Physiologic changes of pregnancy require adaptation of the cardiovascular system, and certain cardiovascular lesions and their consequences on the cardiovascular system put the patient at risk of deterioration and complications during pregnancy. And there is several frequently used medication in cardiology that are contraindicated during pregnancy and breastfeeding, which requires adjustment and surveillance. So now the how. So how do we manage these women, and what can we do to improve their outcomes? Well, all of the scientific guidelines agree that cardio-obstetric care is important, and there are various recommendations that have been published by each society, including the European Society of Cardiology, the American Heart Association, the American College of Obstetricians and Gynecologists, as well as very recently, the Canadian Cardiology Society recently published in December 2021 its first clinical practice update on the management of cardiovascular disease in the pregnant patient. What the CCS recommends in terms of a structure for a cardio-obstetrics program is putting the patient at the center of care, around which evolves different specialists that collaborate to plan the pregnancy and delivery of the patient. This includes obstetricians, cardio-obstetric experts, maternal fetal medicine, nursing, anesthesiology, and certain other specialties that may be required, such as cardiac surgery, for instance, genetics, psychology, social work, and pharmacy. The CCS also recommends a preconception visit when possible. This preconception visit allows for a better definition of the risk, better evaluation of the risk of the patient using cardiac imaging. So evaluating beforehand what is the severity of heart failure, what is the severity of valvular disease, and also doing some stress testing to evaluate functional capacity, which is a very important prognostic marker. As we mentioned before, making these medication adjustments before the pregnancy, ideally, so that we can know that the patient can remain stable on this regimen. Also evaluating for possible risk reduction. Is there anything that we can modify in the patient's lifestyle habits, for instance, that could help lower this cardiac risk, being smoking cessation, improving exercise and diet beforehand, as well as in the case of severe valvular disease on the left side, so severe aortic stenosis, severe mitral stenosis, we could potentially do an intervention before the pregnancy to lower the risk of complication. We may involve also genetic counseling on the risk of transmitting congenital heart disease to the fetus. And all of this allows for the patient to make a better informed decision regarding the risk of pregnancy for herself, but also for the fetus. So here's a quick summary of our checklist that we use at the cardio-obstetric clinic. So first of all, the first step that we do when we meet with the patient is a risk assessment using the CARPRIC-2 risk score that I've shown you before in the modified WHO class. So we look at what are the cardiac lesions that the patient have, what are their severity, has there been previous repairs, interventions, surgeries, what are the cardiovascular complications, has the patient already suffered from heart failure, arrhythmia, what's the patient's functional capacity, lifestyle habits, and social support and resources. We evaluate the medication as mentioned before, and it's important also to plan for lactation, as certain medication can also be transmitted via breastfeeding. We provide recommendation on the site and type of pregnancy care, whether it being local, shared care with a cardio-obstetric specialist, or should the patient receive exclusive care and delivery in a tertiary care center. And we also plan for future investigations and follow-up. For example, a woman with aortopathy, we will plan for the follow-up imaging studies of the aorta size, or follow-up echo in a patient with valvular heart disease. We will also provide recommendations regarding fetal echocardiogram. We know that women with congenital heart disease may transmit congenital heart disease, and it can be a different type, but the risk is still increased for the fetus. We also will provide the patient and their treating physicians with a labor and delivery plan. So in this, we include, are there any contraindications to vaginal delivery? Is there a need for induction or expedited versus assisted delivery? Does the patient require cardiac monitoring during labor and delivery? Are there any contraindications to epidural in the context of anticoagulation, for example? What's the management of anticoagulation to be done during pregnancy? So, you know, if a woman is on anticoagulation, it increases her risk of hemorrhage with delivery. So there are certain management plans that we can provide. Does the patient require air filters in their IV lines in the context of cyanotic heart disease? And does the patient require additional measures to prevent venous stasis? We also discussed with the patient issues with lactation. I've mentioned medication and breastfeeding. There's also certain medications that can lower the ability to breastfeed. So it's important to discuss that with the patient. And lastly, we plan for future pregnancies as well. So this discussion can happen all at the same time as the one visit in the cardio-obstetric clinic, or it can happen after the visit, after the delivery. But what we discuss there is what is the risk of recurrence. So if a patient develop heart failure or develop postpartum cardiomyopathy, what's the risk of it happening again with another pregnancy? Are there contraindications to future pregnancy? And then if so, does the patient have adequate contraception to avoid pregnancy? And also the question of contraception, does the patient have safe contraception with regards to their underlying cardiovascular disease? And lastly, we can evaluate for future cardiovascular risk and risk factor management. So just to overview this very briefly, because cardio-obstetric clinic is a great opportunity, a great window to have this discussion with women very early on about how they can prevent their future risk of having a heart attack or having a stroke. We know that women who suffer from hypertensive disorders of pregnancy, that includes preeclampsia, eclampsia, gestational hypertension, we know that these disorders are associated with a higher risk of cardiovascular disease later on in life, but are also associated with a higher risk of having these complications at an earlier age than would be expected for a woman. These complications include development of hypertension, stroke, arrhythmia, coronary heart disease, heart failure, all-cause death, and cardiovascular death. So, it's very important that we try to target these women and lower their risk as much as possible, because there are modifiable cardiovascular risk factors upon which we can act, and ideally try to lower this cardiovascular risk as much as possible in the future. And actually, in women with hypertensive disorders of pregnancy, it is now recommended to perform annual screening of the lipid and glucose profiles, as well as measurement of blood pressure, so that these conditions can be treated earlier on. So what are the benefits of cardio-obstetric care? So the CARPRIC 2 study that I've been presenting to you, they compared women that were included in their registry between 1994 and 2000 to women who were involved in their trial between 2001 and 2014. And 2001, 2014 was when they installed cardio-obstetric care, and they were able to demonstrate a reduced incidence of pulmonary edema during pregnancy. Women were more likely to be on appropriate cardiac medications, and they were more likely to undergo assessment before 20 weeks of gestation. So if you'd like to know more about the cardiovascular management of women during pregnancy, I invite you to read the Canadian Cardiovascular Society Clinical Practice Update. It's open access, so accessible to everyone online. And they also provide very good algorithms for management of acute cardiovascular complications like dissection, arrhythmia, heart attack during pregnancy. And you can also find a list of the current cardio-obstetric programs across Canada in the supplemental material of this practice update. So to conclude, we've discussed about why is cardiac disease in pregnancy so important. It remains one of the major causes of maternal death, and about 50% of major cardiac events can be prevented. We've discussed what are the cardiac diseases that affect pregnant women. There's a wide list, and there are specific conditions and their severity that can be associated with different risk burden. And medication may need to be modified, but may also lead to decompensation. And we've discussed about the how can we manage these conditions and improve outcomes with the use of cardio-obstetric programs, multidisciplinary approach, and also increasing training and enhance awareness among healthcare professionals and in the general population as well. Before I finish, just a quick ad for our cardio-obstetric program at TOH. You can refer patients to this clinic using the form that is here and that you can find on the website of the Ottawa Hospital in Clinics and Services Cardiology Clinics. The form can be faxed or sent by email, and referrals without the form are accepted, but complete clinical information is requested in the referral letter. And it's a clinic that we do in collaboration with the Maternal Fetal Medicine Group. So I'd like to thank you all for your attention, and to a special thanks to Dr. Abiba Garuba for sharing her expertise with me in my training. Thank you.
Thank you so much, Dr. Paquin. If anyone has any questions online, I would just a friendly reminder just to enter them in the Q&A chat. It can be found in the top right of your screen corner, and you can just enter in your questions there. Just because of our large group, we're unfortunately not able to enable microphone or video at this time. Maybe just to start us off, Dr. Paquin, one of my questions is for women with pre-existing cardiac condition, what are some preventative actions we can do to reduce their cardiovascular risks, particularly from a healthcare professional perspective?
I would say what's good prevention for everyone is also good prevention for a woman who's planning on a pregnancy. So being active, at least 30 minutes of aerobic activities every day, eating well, Mediterranean diet, having lots of fruits and vegetables in their diet. All of that is good for women with cardiovascular disease or not prior to their pregnancy. As well, what I would suggest is that to be aware and then to advocate for themselves. If they are known for a certain cardiac condition, inquire their family doctor should they see a cardio-obstetric physician before or during their pregnancy. Most of the patients, we see them during their pregnancy, and it's okay. Not everyone needs a preconception visit. It depends on the severity of the lesions. But I think to have this discussion with their family doctor could certainly be helpful. And then after that, it's on a one-to-one basis, depending on what their conditions are.
Thank you so much, Dr. Paquin.
Thank you.
Okay,
Hey,
so
go ahead, Sandra.
yes. Yeah, so I'm going to introduce our next speaker. Our next speaker is Dr. Lisa Mielniczuk. Dr. Mielniczuk is a professor of medicine at the University of Ottawa, the director of the Advanced Heart Disease Program at the Heart Institute, as well as vice president of the Patient Safety and Clinical Care for Department of Medicine. Dr. Mielniczuk is here today to talk to us about the impact of the female sex on the trends, management, and outcomes of heart failure. Welcome, Dr. Mielniczuk.
Thank you very much, and thanks for the invitation to be here today and speak about something near and dear to my heart also. Over the next 20 minutes or 25 minutes, there's three sort of main teaching points I'd like to go over with you. The first is to really have a bird's eye view of temporal trends of heart failure landscape as it relates to prevalence and incidence for women and men. But more importantly, to talk a little bit, take a deeper dive into the different phenotypes of heart failure, how they're very different for women and men, and some of the milestones that have been achieved, but also some of the gaps that we still need to close. And then also finally, we'll talk a little bit about the management of heart failure and how it may be different or what we might consider differently as it relates to sex. As a sort of introduction into the concept, though, I think everybody in the audience knows heart failure is a substantial issue and an important health priority, not just for patients, but also for the healthcare system. It's estimated that more than 600,000 patients in Canada have heart failure, and that number continues to rise. It also places a significant burden on our healthcare system. Most of the cost related to heart failure is related to hospitalization and the costs incurred in hospitalization. So we try to do everything we can to keep patients out of hospital. We know that that places a financial strain on our system, but it also places a significant strain on our patients. We know that readmissions for heart failure are high, and we also know that your prognosis is determined by your hospital status, and that there's a marked decrease in survival with every admission you have in hospital. This is particularly relevant for our female patients who have a higher probability of being admitted and readmitted to hospital for their heart failure. If we look at heart failure as it relates to age and sex, we very quickly see two very different phenotypes. And we'll talk today about HFpEF and HFrEF. For those not familiar with that term, HFrEF has to do with heart failure with reduced ejection fraction below 40%, and HFpEF is ejection fraction above 50%, so normal, quote unquote, heart failure with preserved ejection fraction. And you can see that right away there's striking differences. Women are more likely to get HFpEF than HFrEF, and there's clearly an age association there. The older we are, the more likely we are to get HFpEF, and the prevalence of this disease goes up substantially in our older female patient population. But if you look at it a different way and just take a snapshot of ejection fraction over a cohort from sort of 20 to 80%, you can see certainly the very marked distinguishment in spikes of prevalence of heart failure for women versus men. And we're going to talk a lot about this, and there's lots of reasons for that. And we're starting to understand a little more about why that might be the case. But not only are there differences in phenotypes of heart failure between the sexes and differences as it relates to age, but we also see differences in relationship to mortality risk. Now, we know that there is in the US, we don't have the same data in Canada, but there are age-adjusted mortality differences based on geography. But in many places in the United States, and we see this in certain places in Canada as well, the age-adjusted mortality risk for women exceeds that for men for a diagnosis of heart failure. So why is this? What is it about this about sex differences that affects so much of heart failure presentation, diagnosis, and management? There's lots of reasons for this, and we could spend a whole day talking about the complex interplay of some of these important concepts. But it is important to know that there are very significant differences in social determinants of health between women and men. Risk factors, lifestyle factors are different between women and men, and that affects healthcare seeking behavior. It affects our ability to use primary prevention for heart failure, and also affects the risk or the phenotype of heart failure that will be developed. We know there are important differences in cardiac and vascular physiology and structure, and this also affects the differences in presentation of heart failure. And we also know that there are important risk factors. There are cardiovascular risk factors, there are obstetric risk factors, and there are also non-cardiovascular risk factors that are very different between women and men. And all of this affects the presentation and prognosis of heart failure in our patients. So if I had to have one slide to summarize this all, I think there are key things that we're going to talk about. You've already talked about coronary artery disease today, and you probably are all well aware that there are differences in how women and men present with coronary disease, right? Men are more likely to present with classic chest pain and epicardial obstruction. Women are more likely to present with vague symptoms. They're more likely to present later in the presentation of an ACS, and they're more likely to have things like SCAD or non-obstructive disease as their ACS presentation. ACS is the biggest driver of ischemic heart failure and cardiomyopathy. Men are more likely to get HFrEF. Women are more likely to have non-ischemic heart failure, and we'll talk about two important causes of non-ischemic heart failure in women today. And women are more likely to get HFpEF by a 5-to-1 ratio. This is a disease that predominantly affects women, and there's lots of reasons for that, and so we're going to spend some time in that as well. So I'd like to start with the phenotype of reduced ejection fraction heart failure. And as I've already said, this is a disease which we see in men double the rate that we see in women. However, when we do see it in women, women often present with more symptoms, lower quality of life, more advanced risk factor burden. And in fact, despite that, there is a bit of a paradox because women tend to do better than men with their non-ischemic heart failure with reduced ejection fraction. There are two types or two phenotypes that we see in women much greater than men as it relates to heart failure with reduced ejection fraction. And the first one, of course, is exclusive to women, and that's the concept of peripartum cardiomyopathy. This was first described way back in the 1800s, but really got a sort of a systematic definition in the early 1970s. And this is heart failure with reduced ejection fraction that tends to present in the last month of pregnancy or in the first 5 months postpartum. It's often a diagnosis of exclusion and really has to do with risk factors. We'll talk about that in a minute. Now, how common is this disease? I get a referral for this, probably 2 or 3 referrals a year, I would say. The incidence varies anywhere from 1 in 100 in some African countries to 1 in 3,000. But it's probably about 1 in 1,100 to 1 in 1,200 live births. Now, there is a suggestion that the incidence of peripartum cardiomyopathy is increasing over time. And a lot of that may have to do with increasing prevalence of the risk factors which predispose to peripartum cardiomyopathy. And these include older age, African American race, hypertension, anemia, autoimmune disease, preeclampsia. And you can see from this cohort study that if you have all 7 of those risk factors, the odds of peripartum cardiomyopathy is just off the chart relative to women who don't. And I'll call your attention to some of these really relevant risk factors: autoimmune disease, hypertension, preeclampsia. You'll see as we talk today that these risk factors are really important drivers of heart failure, of even different types of heart failure and vascular risk for our female patients. And so understanding that link is an important health priority. Now, how do these women present? They mostly present after pregnancy, early postpartum. They can present fairly significantly with advanced symptoms of heart failure, and the diagnosis is often one of exclusion because these women can mimic a new diagnosis of a previously unknown or unmasked heart failure. It can be related to pregnancy and heart failure or undiagnosed valvular heart disease or congenital heart disease. But essentially, they present with HFrEF and heart failure, and they can be quite sick. Now, as we've gone over time, we've learned something really interesting, and that's the relationship between prolactin and the presentation of peripartum cardiomyopathy. And you can see in the red line, those are the marked increases of prolactin, and in the vertical blue line is the most common presentation or risk of presentation to peripartum cardiomyopathy. And in fact, the link between prolactin and peripartum cardiomyopathy has been unmasked even further over time. And it's one main driver, not the only driver, but a main driver of peripartum cardiomyopathy, particularly in genetically susceptible individuals. Prolactin induces oxidative stress. It creates a substantial increase in microRNA, creates endothelial dysfunction, systemic inflammation, all of which causes cardiomyocyte injury. Now, as it relates to the management of these patients, it is important that you remember the contraindicated HFrEF therapies in pregnancy and in lactation. And unfortunately, most of our foundational therapy in HFrEF has to be adjusted or stopped in pregnancy because of the teratogenic risk. You might see this acronym BOARD for management of peripartum cardiomyopathy, and that brings in the concept of bromocriptine. Bromocriptine actually causes a block of prolactin secretion. Given the relationship between prolactin and peripartum cardiomyopathy, it's not surprising that clinical trials have suggested that giving bromocriptine to these patients can improve outcomes, and there's data to suggest that. Heart failure therapies, diuretics, anticoagulation are all part of the standard care. Now, the good news story is most of these patients get better. In fact, large registries have shown that about 6 months, more than 80% of patients with peripartum cardiomyopathy will have normalization of their heart function. And that's really great news. Also, not surprisingly, if your EF doesn't recover, your prognosis is much greater. And one of the most important questions our female patients ask us is, can I get pregnant again? And this is very relevant for some patients. Now, this is an older study, but it's a landmark study that looked at patients who had a diagnosis of peripartum cardiomyopathy and went on to have a subsequent pregnancy. And group 1 are patients whose LV function improved, normalized, and in group 2 are patients who had persistent LV dysfunction. And you can see on the table that unfortunately, if you got pregnant again with persistent LV dysfunction, your risk of further reduction in decline in EF, your risk of heart failure and even death was substantially greater. Now, older study, not done in our current contemporary era of heart failure therapies, but still the recommendation for our patients is that if you have systolic heart failure after pregnancy that doesn't get better, pregnancy should be avoided. So let's talk about another sex-specific phenotype in heart failure with reduced ejection fraction. And I think, again, many of you have looked after these patients in hospital or you've been familiar with them, and that's the concept of Takotsubo syndrome. Takotsubo gets its name from this sort of octopus trap that was used in Japan many, many years ago. And you can see that the shape of this urn, if you will, looks not dissimilar to the shape of what we see in patients who have Takotsubo cardiomyopathy, which is this apical ballooning and this hypercontractile basal function. Now, this is also a disease that affects women more than men. In fact, the prevalence is about a ratio of 9:1 for women to men. Now, if you've looked after these patients, you know that one of the common associations of Takotsubo syndrome is this concept of a trigger. And it's important to know that these triggers don't necessarily have to be emotional. In fact, oftentimes they can be physical. So acute physical stress such as surgery or acute injury, acute bleeding, all of these things are thought to trigger the onset in, again, susceptible individuals for Takotsubo. The emotional triggers are there on your left. You can read them. This is not an exhaustive list, right? You can imagine that anything that causes sudden emotional or physical stress to the body can cause this catecholamine surge of release, which we believe is the driving force of this Takotsubo syndrome. Now, the diagnosis is also a diagnosis of exclusion. These patients often present like acute coronary syndrome. They present with mild enzyme rises, chest pain, acute shortness of breath. And because it is so substantially associated with women more than men, in a female patient, you have to have a high index of suspicion for Takotsubo in patients who present like this, particularly if their impairment in LV function does not follow a coronary artery, a sort of typical CAD distribution. Now, the emotional trigger is a good predictor of Takotsubo, but in fact, about 35% of patients have no, recallable or memorable emotional trigger to suggest the event. So the absence of one certainly does not exclude the diagnosis. And these patients can have coronary disease. They can have risk factors for CAD. So urgent angiography is relevant for almost every single patient. In general, Takotsubo patients do well, just like our peripartum cardiomyopathies. However, almost 25% of them can present with cardiogenic shock. Because their base is hypercontractile, you can get a transient LV outflow tract obstruction. You can get significant mitral regurgitation, arrhythmias, and just like peripartum cardiomyopathy, it is associated with systemic thromboembolism. And so when we think about this, we tailor our management to these different phenomena. Now, I've already mentioned this is a syndrome we believe is caused by catecholamic cardiotoxicity. It's also been associated with estrogen withdrawal, with abnormalities in microvascular function, endothelial dysfunction, and so the risk factors such as older age, hypertension, known diabetes, or other known vascular disease certainly is a predisposition for this syndrome. And the catecholamine surge is felt to be results in further microvascular dysfunction and then myocardial ischemia and injury. And in fact, this is so important that if you look at patients with acute myocardial infarction and compare them to Takotsubo patients, the plasma catecholamine levels, so the levels of epinephrine and norepinephrine, are much higher in patients with Takotsubo cardiomyopathy, just sort of really driving home that important phenotype. And even brain SPECT angiograms have shown uptake of these catecholamines in the hippocampus, in the prefrontal cortex, and in the brainstem of patients who present acutely with Takotsubo cardiomyopathy. So this really truly is a brain heart disease. Now, as I said, most of these patients get better. In fact, I see most of these patients, their EF starts to recover almost prior to discharge. It really is quite impressive. However, some of the patients can have very advanced disease, cardiogenic shock, and require supportive devices or advanced therapy. If you've had Takotsubo cardiomyopathy once, you are at risk of getting it again, particularly that postmenopausal female phenotype, also been associated with an increased risk of anxiety or mental health disorders. This patient has a much higher risk of recurrence. How do I manage these patients? I manage them just like HFrEF patients. If they're leaving the hospital with impaired ejection fraction, I treat them as such. And for most of these patients, they get better, and then you can very slowly tailor down the medical therapy as appropriate. So as we talk or think or summarize about HFrEF in women, again, important things to remember. HFrEF is a more prevalent disease for men than women. As it relates to causes of HFrEF, there are unique causes to think about in HFrEF women. That's peripartum cardiomyopathy and Takotsubo. The clinical encounter will help to dictate that. If we look at other causes of non-ischemic cardiomyopathy or toxic causes of cardiomyopathy, in fact, actually, alcohol is more likely to cause HFrEF in men than women. But chemotherapy is more likely to cause HFrEF in women than men, particularly as it relates to breast cancer treatment. We know our female patients with HFrEF are going to present to you with more comorbidities in a more advanced degree of unwellness and health. However, they will have a better prognosis, and that's very important to know. And I'd like to shift now to talk about the other phenotype in heart failure, and that's the HFpEF phenotype. And again, I think all of us are very familiar with this very challenging patient population. And as you've already seen, this substantial increase in incidence of disease in our female patients, particularly as we reach beyond the 7th decade of life. Now, HFpEF is a diagnosis that is made on the constellation of normal ejection fraction, so EF over 50%, with signs and symptoms of heart failure and abnormal features on echocardiogram. HFpEF is a real tough diagnosis to make, particularly in our female patients, because it is often associated with this complex interplay of comorbidities. Now, these comorbidities not only confuse the diagnosis, not only affect prognosis, but also are very related to the treatment pathophysiology. Hypertension, diabetes, obesity, sleep apnea, atrial fibrillation, CKD, 30 to 40% of HFpEF patients will have at least one, if not 3 or 4 of these comorbid diseases. So these are sick, elderly patients with comorbid disease. Obesity is interesting. In men, obesity is more likely to result in HFrEF. In women, obesity is more likely to result in HFpEF. So why are women at such a great risk of HFpEF? It is absolutely because of these comorbidities. You may not know this, but with diabetes presents a substantial 5 or 6-fold greater risk of heart failure for women than men. Obesity, as I've already mentioned, has a marked increase in systemic inflammation, changing LV mass, changing metabolism, all predisposing to HFpEF. We've talked about systemic inflammation and autoimmune diseases, an important driver of HFpEF in our female patients. This concept of systemic inflammation being very important to the pathophysiology of heart failure. And then there's hypertension, vascular abnormalities, vascular stiffness that Dr. Coutinho and her team have been working on is another important driver of the HFpEF phenotype. And so what you get is this complex interplay of traditional risk factors such as diabetes, smoking, obesity, hypertension, inactivity, combined with non-traditional risk factors particularly at risk for women, such as pregnancy-associated hypertension, gestational diabetes, preeclampsia, autoimmune diseases, combined with changes in and just anatomic differences in the heart between women and men. And you have the perfect storm which sets up abnormalities in myocardial structure, abnormalities in cardiac metabolism, and abnormalities in vascular dysfunction. And this, of course, has the end result of HFpEF for our female patients. Now, if we shift to talk a little bit about management, I apologize, the slide is small. It's come from the most contemporary 2022 guidelines for heart failure management. You can see that it very nicely talks about prevention of heart failure, which is really, really important. And it also talks about treatment of heart failure based on your phenotype, HFpEF or HFrEF. What it doesn't talk about are differences between the sexes. And why is that important? In fact, it actually might be important because we know that men and women are very different as it comes to response to therapeutics. We know that there are differences in the pharmacokinetics or drug metabolism. Women metabolize drugs differently than men because of differences in hormonal balances, estrogen, progesterone, birth control pills. All of those can affect drug metabolism. We also know that women and men are different in body sizes, and so there's differences in drug distribution throughout the body. There's also differences in drug absorption between women and men, and studies have shown very nicely with standard HFrEF therapies that there's differences in the pharmacodynamic profiles between women and men. So if I told you there might be differences in how we treat women and men with heart failure, you might not be surprised based on these important physiologic studies. But then there's another problem. Another problem is that as we look at clinical trials in heart failure, we see that women are still underrepresented in many clinical trials. Now, these are trials of HFrEF, and I've already told you that HFrEF is a disease that affects men 2 to 1 compared to women. So some of this is expected, but you can see very low percentages, particularly historically, in our standard clinical trials in which evidence-based therapy recommendations are made. But there is data out there, accumulating data out there that suggests that women and men may respond differently to heart failure therapies. There was a really nice recently done registry called Biostat, which actually showed really nicely, in contrast to men, women can actually get a benefit of the heart failure therapies at less than the recommended dose. So women who are on 50 to 60% of the target doses of HFrEF have the same clinical benefit as women who are at higher doses. And that's really important because adverse events related to side effects and medication use in women, particularly elderly women, is not a small problem. We also know that there are differences in response to things like resynchronization. Women are more likely to respond to resynchronization when they have less wide Q restoration. But if you look at the current contemporary HFrEF therapies, you can see that across the 4 foundational therapies, if you do sex-related stratification, I'm happy to say that the benefit is there for women, and it is of a magnitude that is similar to men. So that's also very reassuring. If we look at trials for HFpEF, you can see that the proportion of patients enrolled in some contemporary HFpEF patient trials is better than our HFrEF patients, but you're still looking at 40 to 50% of women enrolled with HFpEF. Now that doesn't make any sense because I've already told you that women outnumber men by a 5-to-1 ratio in regards to HFpEF. So we're not doing as well as we think we should be doing. But in general, across these clinical trials, the benefit, or for HFpEF trials, lack of benefit seems to be similar for women and men. With one interesting observation. As you know, sacubitril/valsartan is a foundational therapy in HFrEF management, and that was from the Paradigm trial. A few years later, there was the Paragon trial, which looked at sacubitril/valsartan in patients with HFpEF, and that trial was negative by its primary endpoint. But interestingly, what these investigators did is they looked at the treatment response as it related to ejection fraction in women and men. And to walk you through this, because I think it's important, you can see the primary composite, which is a composite of CV death or heart failure hospitalization, is very different for women and men. For men, once you cross that red line, that implies there's no benefit of the drug. And you can see that that threshold for men is about 60% ejection fraction. However, for women, that gets pulled out to 70%. And so when you talk about mid-range ejection fraction or HFpEF with EFs of 50 to 55%, there's a suggestion, in fact, that for women, sacubitril/valsartan will not only prevent the primary outcome of CV death and heart failure hospitalization, but largely total and first hospitalization, up potentially to an ejection fraction of 65%. We don't see this in men. And it may be that the trial was negative because there were so many men in the trial. Now, interestingly, the investigators took this to the FDA in the United States, and the United States has approved sacubitril/valsartan for HFpEF patients, particularly for women, based on this very interesting data. So in summary, if I had to summarize the key points today, it's very clear there are differences in men and women as it relates to risk factor profiles predisposing to heart failure. And as a result, we see in our female patients what we call a predominantly endothelial inflammation, microvascular dysfunction, whereas in men, we see more macrovascular disease, myocyte necrosis, and the result of that is that women are more likely to get HFpEF, men are more likely to get HFrEF, women are more likely to have diseases of systemic inflammation like Takotsubo cardiomyopathy, hormonal diseases like peripartum cardiomyopathy. And so we've come a long way in our understanding of sex differences in heart failure, but we still have a long way to go, right? We're still seeing underrepresentation in clinical trials. We still don't have a good understanding of pharmacology as it relates to therapeutic impact in our female patients. And we still need to refine all of those risks and how they directly impact on pathophysiology as it relates to heart failure incidence and prevalence. And as a result, there are still important ramifications of these critical unknowns, right? Women are more likely to present later in their stage of illness than men. Women are still less likely to be offered appropriate primary prevention strategies for heart failure, and women are still less likely to be referred for heart failure, and they're still less likely to be treated as optimally as men for HFrEF. And before I conclude, I want to make one discussion on gender. We've talked a lot about sex today. Remember, gender is a societal construct about sense of self and identity. About 5% of our population identify as being gay, bisexual, or transgender. And this is an area where we have no information as it relates to heart failure management. But we do know that this important patient population has a substantially increased burden of risk factors that can predispose them to heart failure. We also know that this patient population has been not served well by the medical community and are much less likely to have equitable access to care. So as we talk about sex, we have to remember sex and gender as we go forward in understanding heart failure. So how do we close the gap? We close the gap with the recommendations that we've been made. Better understanding of risk factors, better attention to treatment for heart failure for our female patients, and better policy initiatives that will help ensure that our female patients are well represented in clinical trials and well supported in research as it relates to heart failure and female patients. So in summary, thank you for your time. Really enjoy this meeting. Happy to take questions if there is, and look forward to the rest of the day. I was just wondering as well if you think that the landscape healthcare providers are knowledge gaps with heart failure that evolving. Yeah, I think that, thank you, Bonnie, for that. And a comment on gender, absolutely. I mean, I still think sex and gender are used interchangeably too much. You know, and we understand that this patient population to be actually very different. And until we understand how, why, and how best to serve the patient population, we're missing, I think, a lot of opportunity. As it relates to your question, I do think there's been great advances in the field. I think, pillars like the Canadian Women's Heart Health Alliance is a great example of just raising awareness. And the data does suggest that if you look temporally over time, our management of heart failure for women has gotten better. It still lags behind in men. But what also has improved is some of the things I touched about on the understanding of the vascular inflammatory associations or predispositions to heart failure, particularly HFpEF. There's a lot of interest in this, and we understand this comorbid constellation much better than we did 5 years ago. We understand how it's driving HFpEF, and as I've said, this is largely a disease of women, of elderly women. So it's nice to see that has evolved. So I think we've come a long way. I still think there's still inroads to make, though.
Hi, Dr. Mielniczuk. Thanks for a great presentation. So as you know, in cardiac rehab, we see anyone and everyone that's referred. And I'm glad that you mentioned Takotsubo today, because we do see this as a diagnosis of exclusion. Sometimes it is actually confirmed, sometimes it's not. And so I'm wondering, what is our role in someone who has come in and they've been worked up, they have been diagnosed with Takotsubo, fully recovered, normal EF, they're reluctant to be compliant with medications. They may or may not get referred to the heart function clinic. So how are we supposed to intervene with these patients? What is the messaging we're supposed to get to them?
Yeah, and it's tough to give a clear message because we don't have a lot of data on how to manage these patients long-term out of the acute setting. So thanks for raising the question, because there's not a lot of good data to advise us. Because the rule for these patients is that their EF does recover completely. So where do we go with heart failure therapies in patients whose EF has recovered? That's a whole nother question. There has been some trials looking at this. And in fact, one trial in particular suggested that if you withdraw heart failure therapies, if your EF has recovered, but many of the patients in this study still had some abnormalities with remodeling, they actually had an increased risk of deterioration over time. So many of us are somewhat reluctant to withdraw heart failure therapies if you still have some abnormalities in heart function. And that could include some abnormalities with left ventricular volumes, dilatation, or sort of low normal ejection fraction. That's not typically the Takotsubo patient. Mostly Takotsubos, they normalize their EF. So their EFs and their volumes are completely normal. And so there's no there is no evidence to say when the therapies should be withdrawn. I have my own personal practice where I'm a little bit more conservative with withdrawing therapies. Oftentimes, these patients have risk factors for benefit of treatment of ACE inhibitor anyway, so I might continue to treat the ACE inhibitor for hypertension, vascular protection. I'm less aggressive about stopping the beta blocker because there is some evidence in Takotsubo's, particular Takotsubo's with a history of depression, that the beta blocker reducing that adrenergic tone may actually have some benefit theoretical in preventing heart failure or preventing recurrence of Takotsubo. So I think, you know, if you're seeing these folks in rehab and they're on these therapies, I would encourage them to stay on the therapies because we're just in a bit of an unknown area with respect to the timing of the withdrawal of therapies, particularly if this patient in rehab has any LV remodeling abnormalities that are still existent. Then the data is actually, you know, there is data to support that they should be that they should stay on those therapies.
Thanks so much, Dr. Mielniczuk. There's a few questions in our online Q&A. The first one is also in relation to Takotsubo and cardiac rehab. The question is coming from Lauren, and her question is, what would you still endorse referral to cardiac rehab for those with Takotsubo or postpartum cardiomyopathy if their LV function has improved?
So that's a great question, and I'm a bit of a believer because I would wholeheartedly say the answer is yes if the patients are interested, and so we you know, when we think of the spectrum of heart failure, we have this opportunity for prevention of heart failure and treatment of heart failure. And your Takotsubo patient who has recovered, or your peripartum cardiomyopathy of patient who has recovered, is clearly at risk for heart failure, right? They've already developed clinical heart failure. And so this is the point where if they've been lucky enough to have a full recovery, we move them back to stage B heart failure, which is the prevention of heart failure. And many of the risk factors which predispose them to the Takotsubo or predispose them to the peripartum cardiomyopathy are also risk factors which will predispose them to HFrEF or HFpEF down the road. And so I think, you know, moving them through a program that can address those risk factors, that can provide them with the support that they need to reduce that sort of burden of risk factors would be very beneficial. So I would see a role for a patient like that. I would say that that patient, even though fortunately they've recovered their heart failure, are still at a high risk. And so there is value and opportunity and good data to support that we can prevent heart failure by mitigating some of those risk factors.
That's great. Thank you, Dr. Mielniczuk. We just have another question from Guianne. You mentioned earlier about inflammation. Her question asks, as inflammation is a key contributor to many cardiac conditions affecting women, how should it be assessed?
That's a great question, and it's a question that is part of the, I think, priority area in terms of research. There are many ways to assess inflammation, and all this is just in the research stage, right? So there are many ways to assess inflammation. You can assess it by biomarkers. There's advanced cardiac imaging you can do that looks at imaging markers of inflammation, and all of this work is being done at the Heart Institute. There are however, from a clinical day-to-day perspective, how do we assess inflammation? Probably one of the most important markers of inflammation is a good history. The association between connective tissue disease, autoimmune disease, and heart failure risk is quite substantial. So, you know, for our clinicians, sort of understanding, you know, does the patient have signs or symptoms of an undiagnosed connective tissue disease or a poorly treated connective tissue disease? Because we do believe that adequate treatment of that is important to prevent heart failure. Random levels of inflammation, of inflammatory markers in the absence of a known diagnosis of connective tissue disease may be less helpful in heart failure. There may be some evidence for that in certainly vascular risk and coronary artery disease. However, in heart failure risk, we haven't yet shown that you know, if your inflammatory markers are high and you give something to reduce the inflammatory markers, your heart failure risk goes down. I don't think that's the case. So I think for now, it's still a matter of treating the chronic inflammatory disease aggressively that predisposes to heart failure.
Thank you, Dr. Mielniczuk. We just have a few questions about estrogen deficiency, kind of connected to heart failure, and you know, and then also sort of hormone replacement therapy. So just kind of the question is hormone replacement therapy beneficial for, like, for example, menopausal women who have those decreased estrogen levels?
Yeah, so that has to be taken in balance with the risks of HRT as well, right? So the thromboembolic risks of HRT need to be factored in. There is no randomized trial that suggests that women who receive HRT are less likely to develop heart failure or HFpEF than women who don't receive HRT, although there is interest, and there have been some animal studies that have looked at estrogen replacement as a way to treat HFpEF and other vascular disease, pulmonary hypertension also. So it's not for prime time at this time. I would not recommend HRT just to prevent heart failure symptoms. And remember, and again, HRT does have to be balanced against the risks. So that's a great question. It's one of those unanswered research questions that needs a little more work.
Hey, wow, this has been quite an amazing morning, and it's going to continue. So our last speaker before lunch is Freya Kelly. So Freya is an advanced practice nurse for the Heart Institute's Cardiac Supportive and Palliative Care Program and the Amyloid Clinic. Freya will share with us about cardiotoxicity and a pilot program for breast cancer patients in cardiac rehabilitation. Welcome, Freya.
Great. So thank you guys very much for having me. I'm very honored to be invited here today to give you guys a little bit of a talk about something I'm actually very passionate about. So I have my learning objectives here for you. My hopes for you today is that we'll leave with a bit of a background on cardio-oncology. I'll touch on the pilot project that we're working on here at the Heart Institute, including the objectives and some very preliminary results, and then where I think the next steps in this area should be. So given the new interest in this field and that I am speaking at the Women's Heart Health Education Day, I thought it would be worthwhile to go into a little bit more detail than I usually would on the background of cardiotoxicity. Although I'm presenting as a nurse and I know I'm presenting to a bunch of healthcare providers, I'm looking out, there's a lot of females in the room. So I'm hoping, and I know there's been a lot about advocacy today. So what I'm hoping for today is that you'll leave with a little bit more knowledge for yourselves to advocate should you need to. We know that 1 in 8 Canadian women will develop breast cancer during their lifetime. We also know that cardiovascular disease is the leading cause of death in patients with breast cancer over the age of 50. I therefore hope to leave you with some important knowledge that you can share with your friends, family, and other healthcare providers. I also thought I would highlight here that October is in fact Breast Cancer Awareness Month, and CIBC had their annual Run for the Cure. And then I've also just added this slide. I just came back from the Global Cardio-Oncology Summit, and there's a lot of really great studies and information that's being shared around the world. So, and thanks to new treatments that are coming out year over year for all cancers, but breast cancer in particular, the number of cancer survivors has steadily increased since the 1970s. The 5-year survival rate in the United States, for example, has increased from 75% in the 1970s to 91% in the 2010s. However, especially among breast cancer survivors aged 50 and more, deaths due to cardiovascular disease account for 35% of non-cancer related deaths. The increase in cardiovascular disease among breast cancer survivors is due to the cardiotoxic effects of breast cancer treatment, including in particular anthracycline chemotherapy and therapy such as Herceptin or trastuzumab. So this image is from Mehta and colleagues from 2018, and it shows the risk factors for both cardiovascular disease and breast cancer. It also really highlights the overlap of those risk factors, including age, patient's diet, their family history, whether they intake any alcohol, if they're obese, any hormone replacement, whether they participate in physical activity or not, and whether they smoke or not. Early research focused primarily on the consequences of treatment for breast cancer as a cause for cardiovascular outcomes. As a result, for example, doses of anthracycline chemotherapy decreased. Routine screening for a patient's ejection fraction became standard of care for those on trastuzumab, which is a biological therapy that can lead to reversible congestive heart failure. As well, oncologists became more mindful that tamoxifen, which is an adjuvant therapy for breast cancer, can increase the risk for venous thrombosis. Nonetheless, there's been a recent assessment of the above risk factors, which has really taken the front seat. Given that increased cardiovascular risk appears to manifest itself approximately 5 to 7 years after initial diagnosis of cancer, breast cancer in particular, a potential window of opportunity really exists for possible preventive intervention strategies, which is ideally offered through a cardiovascular rehab program. So this is just another schematic that shows, although I recognize it's not very well, sort of all the modifiable and non-modifiable risk factors that we take into account when someone is diagnosed and treated for breast cancer, which can eventually lead to cardiovascular disease. So one suggestion to help prevent cardiovascular disease and premature death from the literature is secondary prevention, in particular the management of pre-existing cardiovascular risk factors, as well as monitoring for cardiotoxicity during the survivorship period after breast cancer treatment has really been completed. So we therefore were able to leverage our pre-existing cardiac rehab program to assist with the specific patient population. So I'm just going to spend the next few slides talking about our pilot project here. So alongside the colleagues at the Ottawa Hospital Cardio-Oncology Referral Clinic and our management team here at the Heart Institute, it was decided that our pilot project would be aimed at a specific subgroup of patients seen by the CORC, notably breast cancer patients treated with anthracycline alone, as well as breast cancer patients treated with both anthracycline and trastuzumab, who also had a decrease in their left ventricular ejection fraction. So this was estimated to be about an additional 40 new patients referred to our cardiac rehab program. So the objectives for this project included identifying and recruiting key stakeholders, developing a pathway for this specific population, developing an auditing tool, examining ongoing barriers and facilitators, education for both our staff and our patients. And I just wanted to highlight here that we were the successful recipients of the RNAO Fellowship, which allowed us to hire a nurse coordinator to really oversee this whole project. So as I said, our first objective was to identify the various key stakeholders, and this was really instrumental in allowing this project to take off. So I've just highlighted a few of the names here who really made this idea a reality. The next objective was setting up a pathway for these patients. So here we have the cardio-oncology cardiovascular rehab process diagram. And this was determined following a systematic literature search that was conducted to determine existing clinical guidelines in cardio-oncology rehab for patients undergoing both anthracycline and Herceptin therapy. So following the systematic search, guidelines were selected and adapted using this RNAO toolkit, which I personally really like. This pathway has been really instrumental, first to ensure those fall within our pre-specified parameters, as well as to clarify for the staff sort of what's different and the same from their usual standard of care. So the rehab program includes usual care, such as access to our smoking cessation program, nutrition, mental health services, and exercise programs, and these are tailored as needed to accommodate our patient population. So I added here a sample of the auditing tool to review which programs from the cardiac rehab the patients were utilizing and whether they are being referred appropriately. So again, key to the feasibility project and include components such as referral to allied healthcare providers as needed, number of patient contacts, and program completion. We did a lunch and learn for the staff, as well as developed a booklet to leave with them after the lunch and learn was done. And then to meet the objective regarding education for the patients, the rehab staff are currently offering this infographic, which is available on our CWHHC webpage, both in English and French, along with other standard of care patient education materials, such as nutrition and exercise booklets, which are being provided to this patient population. And then lastly, to ensure our project is being developed alongside our patient partners, we modified the satisfaction survey that's offered to the patients at the end of their program to review any further modifications that they believe should be done. So I've added here some very preliminary results. So we've had 8 patients referred to date with an age range of 28 to 68 and a median age of 51. The HbA1c of these patients ranges from 4.8 to 6.5, so no referrals indicated to endocrinology at this time. No referrals have been indicated for smoking cessation. We've had 4 out of 6 referrals indicated for social work, 1 out of 6 indicated for psychology, and then another 17% for our nutritionist. So when we look at the exercise component, 2 had case-managed home-based programs, 3 had on-site exercise, and 1 refused the referral. Of the virtual group education available, 4 enrolled in our group coronary artery disease class, and 1 opted to receive the available videos at home. 100% had PT exercise prescription, which is actually supported in the latest cardio-oncology guidelines from the ESC, which was only released in August of 2022. And we started this pilot project in April of 2022. So good to know we're in line with those guidelines. Of the 2 who completed the program to date, 1 had 5 number of contacts with their mentor, and another had 19 contacts, but when we dove in a little bit more, 9 of those contacts were with the CAD class, and then 5 were with the stress management class. So as I mentioned earlier, research in this field is constantly growing, and in 2020, Dr. Moore and her colleagues found that patients with early stage breast cancer who experienced cardiovascular events after a cancer diagnosis had increased risk of recurrence and cancer-specific death. There is therefore now emerging evidence that having these cardiovascular risk factors, including diabetes, obesity, and high blood pressure under control even before starting your cancer treatment, not only helps reduce the risk of future heart disease, it actually also helps with cancer-specific mortality and recurrence. One option that's been previously mentioned in the literature to help standardize this is a prehab program. So I'll try, this was my attempt at smarter, but I'll try and explain it here. So what we're doing now, we have that red line, and that's sort of the exercise tolerance of someone. They go through their cancer therapy, and then we have our cardiac rehab program here. So their functionality does increase, but not to the level that it was before. Whereas if we include a prehab program, as is being done elsewhere in the world, we help increase their exercise tolerance just that little bit before their cancer therapy. It still decreases just with their chemotherapy, radiation, and surgery. But then with the rehab afterwards, we're able to get them back to that pre-exercise tolerance. So as I mentioned, in August of 2022, the European Society of Cardiology released their cardio-oncology guidelines with over 270 new recommendations. So this was really instrumental to this field of work. On page 82, it describes the role of cardiac rehab. It notes that high-intensity interval training, or HIIT, reduces cardiovascular risk factors and cardiovascular risk in patients with cancer in the pre, active, and post-treatment settings. HIIT-related benefits on cardiovascular risk factors, physical activity behavior, fatigue, and quality of life, and this persists months post-intervention. So although, of course, most of the responsibility does rest with the oncologist, the cardiologist, and primary care providers, patients do need to be aware of their risks and continue to advocate for themselves as well. So I just wanted to bring up this infographic once again, but this time really highlighting the what can I do section. So first we offer patients to really know their risks, suggest that they work with their healthcare team to ensure that their heart disease, diabetes, blood pressure, and cholesterol are really under control, especially before starting any cancer treatment. Some ways to do this are eating a heart-healthy diet, aiming to move 30 minutes a day, finding support to quit smoking, knowing their numbers, including their HbA1c, their blood pressure, and their cholesterol values. So I just wanted to thank you guys again for your time, and I'm more than happy to take any questions.
Thank you so much, Freya. Really appreciate your presentation. I'll again start our Q&A with a few questions. The first question with is regard to your pilot program. How do you anticipate increasing recruitment of participants into this pilot program?
Yeah, thank you. So actually the manager of rehab and I were discussing this the other day, and we've been having ongoing meetings with the cardiologist at TOH. So we've already done a few things to help with the recruitment, but another one that we're looking at is opening it up to some of the oncologists to refer to our program. But that still needs to be discussed with both teams from rehab and CORC.
Thank you so much, Freya. And then just as a follow-up, what do you see as sort of the next steps for your pilot program?
So obviously trying to hit that 40 number mark. We're waiting to get about 5 people who have completed the program to be able to hold a focus group and see sort of what they liked and didn't like about the whole referral process and be able to tweak it a little bit more to make it hopefully more standard of care for these patients.
Great, thank you.
All right, great overview, Freya. Thank you very much. And a very important project. I'm glad to be involved as the physiotherapist. One small caveat, I noticed that in the data analysis of the 2 patients, we see that the number of contacts is very different, all depending what people choose to get referred to or accept. So our virtual offerings, if someone takes the virtual education sessions, that tacks on 8 contacts, but they're not specific to that patient. So I think we need to be careful in the data analysis because there will be this wide variance. If someone is in the brief program, they may have only 3 contacts during the entire program, and they may decline participating in the virtual education, but just receive the videos. So they're still watching those 8 videos, but we can't put that down as a contact. So I think, you know, in the discussion of whatever paper we publish, we just have to bear that in mind.
No, absolutely. I totally agree. And as I said, in speaking with the manager, we did sort of look at that 5 to 19 difference. And I think when it came down to it, it added up that removing the videos aside, there was still just 5 contacts with the mentor. Thank you, though.
Any questions for Freya, folks? Freya, thank you so much. This was absolutely amazing. Thank you.
Thank you.
Okay. Well, I smell something really good for those of you in person. So we're going to take a lunch break. We'll be back at 12:30. Just a reminder to complete your quiz. We should have the post-event knowledge quiz and survey actually open now, I believe, Sandra was saying. So to complete that, your name will go in for a draw. More prizes again this afternoon. So thank you so much, and we'll see you soon. 12:30, please. Thank you.
Hi, everyone. Welcome back to our Women's Heart Health Education Day. We'll get started. Hopefully you had a good lunch and a nice little stretch. Just a couple of friendly reminders. We've opened up the meeting chat in our Teams webinar, so please feel free to use the chat along with the Q&A if you have that feature. I'm going to introduce our next speaker. Our next speaker is Dr. Heather Tulloch. She is a senior psychologist here at the Heart Institute, and Dr. Tulloch is going to share with us about mental health issues like depression, anxiety, and stress, and cardiovascular outcomes among women. So welcome, Dr. Tulloch.
Thanks so much. I'm excited to be here because I'm always happy to have an opportunity to talk about mental health. I've been at the Heart Institute for close to 20 years, and I've really seen over time how the mind and heart are connected. What I'm going to talk a little bit about today is something that probably will not be surprising to you, right? You're not going to go, oh my gosh, I can't believe that. I'm sure many people already imagine, you know, these connections between the mind and the heart. But I'm going to highlight, well, some of the highlights, but also talk about where we can go. I have no conflicts. It's not going. So as I was looking for pictures and part of the cardiac rehab program, I found this one, which was representing cardiac rehab. And I looked through it and I went, okay, great. There's, you know, patient appointments with the doctor. There's exercise. There's eating healthy. But what are we missing? Right? And I kind of get a little annoyed if I'm truthful. And then I looked at the next thing and I saw 11 bizarre factors that might increase your risk of heart disease. And of course, many of them there, things like loneliness, breakup, abuse as a child, and depression are now considered bizarre. And so then my, you know, back got up a little bit more. But then I was sort of feeling better when I saw that this paper came out. Now, it's about 8 years ago now that it actually came out, and it's from the American Heart Association. It's a scientific statement that says, hey, people, depression should be elevated to the level of risk factor for acute coronary syndrome, for a poor prognosis for those patients. So the evidence is there to make this recommendation now. And I found it interesting this morning, Dr. Coutinho had talked about the risk factors, and I was waiting because she said 7 of them. And I thought, come on, where's the mental health one? Because it is now considered a risk factor. Now, patients, obviously, and I'm sure many of you have heard this before, you know, there's a different or potential different response from different people, but it can be quite varied. And sometimes it's being fearful of having another cardiac event. Sometimes it's worries about doing strenuous activity. I know we have a lot of patients coming to cardiac rehab sort of wondering, what can I do? And being very thankful that they're being sort of surveyed, you know, watched while they're doing it. Sometimes there's a loss of identity. You know, we talk about some patients, even Tammy, who was here, said, you know, I was this fit person and this doesn't fit for me. And now it's like, who am I? I'm maybe not Miss Fitness anymore in my mind. There's frustrations, of course, in making some lifestyle changes. Some people, like my sister, really enjoy smoking. And so she tells me, Hev, it's a celebration. And I say, no, let's change the thinking on that. But there is frustration in making those changes. Strain as well regarding, you know, changes in work, and sometimes that puts strain on the pocketbook and that causes some stress. And then of course there's many others. So what I want to say first is it's very normal. All of these different emotions, very normal. So if you're working with any of these patients, you can say that it's normal. I would expect you to go through these changes. Now, if it sticks around though for a longer time, or if it's really impacting your functioning day to day, then that may be where it's leading to some depression and anxiety or other symptoms that are problematic. So some of the factors that have been studied are these here. So depression, anxiety, post-traumatic stress, some things about social support. Everyone's heard a little bit about type A. Type D personality is when you have more of a negative feelings, negative affect, but then you don't have that social outlet or feeling more socially isolated. And then, of course, there's anger and hostility. Today, I'm going to focus the ones mainly on the left-hand side of the screen, because that's where most of the research is. And in fact, most of the research is really on depression. So quick quiz for you before I dive into some of the numbers. What do you think? Psychosocial factors have been shown to increase the risk of an acute MI, so having a heart attack, for women by what percent? Who says A? Who says 5%? Who says B? C? Not fair. Jeez Louise. I'm glad you told me though. That's a little embarrassing. All right. Why is it so? My slides. Goodness. Moving right along. So it's 22%. Now, moving on to depression. So as you can see, there's a real range. So 20 to 40% of women that have coronary artery disease, but also other diseases. So for example, heart failure, it can be up to about 50%. SCAD, it sort of goes up to about the 40%. So depending on the type of cardiac diagnosis, it does vary, but yet we're certainly seeing depression. There was one study just to compare between men and women. You can see about 30%, 31% of women versus about 20% of men had a diagnosis of depression. And we have to really keep our antenna up for those younger patients. So those that are under 50 are more likely to have symptoms of depression. So, you know, we're seeing it, and again, almost a doubling here, 30% of men versus 50% of women. And interestingly, in this large study, they found that only 2% were prescribed antidepressants. Now, I don't know what to think about that, to be completely honest, because there is some literature that says maybe antidepressants aren't the best thing actually for women, but that's a little outside of my scope. I don't prescribe, so I'm not going to go into that literature, but I think we need to learn a little bit more about that side of things. So who's at risk? Well, certainly I've already said the younger patients, but some data also says older, and this is especially in the heart failure population. So elderly women with heart failure especially are about 1.5 times more likely to develop depression. Certainly marital status and social isolation is important, as well as lower economic status. And as well, previous depression episodes. So if there's been a previous episode and then there's a cardiac condition, they're more likely to have another depressive episode. Again, just as an example with heart failure, and this is, I think, the case for most cardiac diseases, if the symptoms are more severe, then you're more likely to develop depressive symptoms. And I just want to know, you know, we're talking about sort of the presentation and how symptoms may be a little bit different for men and women. Well, with depression, women are more likely to develop anhedonia, so where they're just not enjoying things as much as they typically would. They also have more loss of appetite and GI symptoms, so gastrointestinal symptoms, and more sleep disturbance. So as I already alluded to, depression is a robust risk factor for CVD outcomes or poor outcomes. And there is a dose-response relationship. So not surprisingly, there's the strongest association when depression is chronic and severe. And we know for women in general, women tend to have a depressive episode, like the first one in their life, earlier than men. They also are more likely to have more than one episode. And when they do have depression, it tends to be more severe. So you can see where the risk lies. And when we're looking just at sort of the incidence rates, so the incidence of having a cardiac event, excuse me, individuals with depression, so women in particular for this data, do have about a 3-fold increased risk of having a cardiac event if they do have depression as compared to those who do not. And then if they already have established disease, again, it's about a 3-fold increased risk of having a recurrent event. So now just switching to anxiety. This, as I mentioned, the literature is a lot less in this area, but when we're looking at prevalence rates, again, we're seeing about a doubling of the prevalence rates for women, versus men. And women do report also higher levels of anxiety, and this is independent of other risk factors. So they've looked at, you know, BMI and blood pressure and some of the other socioeconomic sort of variables and control for those, and it's still showing that. Typically for women, there's some research that shows that the anxiety is the highest at the time of admission and then sort of slows down or reduces over a year to 2 years. So it can be around for a while. And what we've learned in some of the research is that those that start out really high on, you know, some of the questionnaires that we typically give, they're the ones that are likely to remain high and actually get a little bit worse than those who are sort of in the moderate or mild range. Those are ones that are coming down, whereas the other ones might be going up, so their anxiety worsens. There have been a number of reviews that have looked at, or I shouldn't say a number of reviews, there's been probably one in each of these areas. So one for anxiety, generalized anxiety, one for phobias, and one for panic, where they've looked at the small number of studies. And they do see a small increased risk, certainly for developing heart disease with anxiety. And it's even stronger for people that already have established disease. So if you have established disease plus there's symptoms of anxiety, then you're more likely to have another recurrent event. Again, you know, I'm just touching on a few of these areas. So for early experiences, just to put some context, we know that girls are more likely to be victims of sexual abuse, and trauma before the age of 16 has been linked to poor cardiovascular health. And there was a meta-analysis of 24 studies. Now this is with not established heart disease, so individuals that were sort of in the healthy population that then they followed them over time in many studies to see whether they then developed heart disease. And they did see a fairly large effect size for adults that developed heart disease, which could be attributed to their physical or sexual abuse. And just to drill that down a little bit more, we can see a 46% increase for physical abuse, 56% for sexual abuse. And I want to point out that this is partially explained by lifestyle factors. So often when there's been an abuse history, people may be more likely to try to cope through smoking, through drinking, and maybe less physically active. And we know all those things are obviously really important for our heart health. Just really briefly, again, there's really not too much on trauma. However, in the general population, it's about 10% of women, but in the cardiac population, it's up to about 30%. And again, this varies, and it really depends on how the questions are asked, if it's in a questionnaire or whether it's a clinical interview. But certainly women that have at least 4 symptoms or more of PTSD, they do have a 60% increased risk of developing or having cardiovascular events. I don't do a lot. I'm not the occupational therapist, but I found some of this research interesting on work stress. And I'm just going to highlight the 2 bottom parts here. So the first one, or I guess I should say the second one, which is if you have a high demand job, but low control, so you feel you don't have much control. And if you have low demand, as well as control, there's actually not as much risk when it comes to cardiovascular disease. But when you have an active job, I'm thinking this is kind of mine, high demand, high control, which is great. I feel I have great control, but at the same time, maybe I have a little bit higher risk. And I think the point that I, especially from my work that I do with couples, is having that work stress plus marital stress actually increases to a 6-fold increase in recurrent events for those that have established disease. So it's that double whammy that really gets us there. So that takes me into a little bit on social relationships, because this is an important piece, especially for women. This meta-analysis is pooled data, both men and women, but it shows that poor relationships do lead to an increased risk for the development of coronary artery disease. And this is especially for women. So these poor relationships, if you're feeling lonely, if women feel lonely many days out of the week, then there is an associated risk with heart disease. And these women were followed in this study for 19 years. Interestingly, this association was not found for men. And that takes me to this quote that I really liked, which is, for the mere presence, the mere presence of a spouse or partner may be protective for men, but the presence of a positive reciprocal social relationship may be more important for women. And we do find that in a lot of the data when looking at marital status is often just being married is protective for men, which is great. But for women, they really want the quality. I'm not saying that men don't, but geez, there's only one man in here at the moment, I think. Hey, Mark, poor you. Yeah. So, but here's a great thing. If as a husband, you're providing emotional support, then we do see that there's some protection there. And so there are some studies that show that that support can actually protect against things like metabolic syndrome. The flip side, though, unfortunately, is also true when there is that distress that does elevate a number of the cardiovascular markers. Most of this research is done in healthy people, though, not with those that already have established disease. But my last point here that you can see is that there was a study that followed women for 5 years after having had a heart attack. And they found that those that were in more high conflict relationships, so less satisfying relationships, they're 3 times more likely to have a recurrent cardiac event. So I have to just quickly mention, as Dr. Coutinho said, we have to, I want to highlight SCAD. because we know that it's predominantly in women. We don't know exactly the cause, but certainly emotional triggers are involved with many cases. And as you see here with one of the studies that came out of Vancouver with Jackie Saw's team, is about half of individuals that have had a SCAD did have an emotional trigger. And there are, fairly high prevalence rates with this group as well. Now, my question is, and this is what I'm doing a study on, is does it matter, whether it's a SCAD and that sort of unique profile, or is that most of these are young women? And so we're trying to tease that out a little bit, but certainly depression, anxiety, and trauma have been noted in this population. So now I've talked about each one sort of individually, done this whirlwind tour. Now I want to highlight this meta-analysis that took a number of studies looking at the psychological distress and predicting MACE, so major adverse cardiovascular events. And what they found was that over these 42 studies with 200,000 women, 300,000 men, that there was, of course, an increase of 22% for women, but 37% for men. Now, I don't know what to think about this, right? Because as a woman, I'm like, oh, haha, we're less. But the other side of me says, well, wait a minute, the risk is still there. And the other part of me says, well, hold on, the research on women is still, not that great, as others have already pointed out. We have less samples of women. Karen Bouchard, who is a postdoctoral fellow working with me, she just did sort of a summary of the many analyses looking at mental health and cardiac disease, and showed that only 25% of the samples included women. So I think we have more work to do here. The other piece I was going to say is just even looking at sex and gender analyses is often not done. And in this meta-analysis that I just spoke about, only 24% of the studies included sex and gender analyses. So again, more work to be done. I'm gonna skip that one. So we've talked a little bit about, what's the cause, what are the links here? And I think the answer right now is we don't entirely know, but certainly there's a number of factors. And I'm highlighting a few. They say for women, the top 3 are the ones that I've circled. So the behavioral mechanisms. So, whether there is depression, anxiety, trauma, often that is affecting the behaviors of women. And so these are some of the areas that we definitely want to target and help them. And so, I'm a real proponent for cardiac rehab, which addresses many of these factors. Then there's also the autonomic nervous system dysfunction. So this is often, and the one that of course is controlling our cardiac activity. And so certainly if that's being overactivated with depression or anxiety, then that's going to do damage to the heart. And then, as others have already spoken about, there's inflammation often with these psychological issues, and we're still learning how this is connected, but it seems to be one of the factors. So what do we do then? We know that there's an issue, so we want to make sure that we're screening. And I apologize, this is really small. I'll flip to the next one, which is really highlighting the one that I suggest, and actually the American Heart Association has suggested for screening, and that we use here at the Heart Institute, which is the PHQ-2 and then the PHQ-9 if needed. So the 2 is those first 2 questions, and if those are elevated, then you want to follow up with the following 7 questions. I will note that number 9 does ask about suicidal ideation. So if you are using this with your patients, just to make sure that you're able to look at that fairly soon after the questionnaire has been completed, just to make sure that the person isn't at risk and you can intervene if you need to. Scoring is really easy for these. You just add it up and it gives a nice guideline here, everything, from mild to severe, and you sort of know where you're working. For anxiety, similarly, the GED-7, same sort of questionnaire and the same reporting. Now, I will say none of these questionnaires are perfect, and really it is good to follow up with the patients, but at least it gives you a starting point, and it saves you little time if you're working in clinic with patients. But when should we screen? So I think I might just tell you the answer, even though the red lines are not here this time. It's all the above. We really want to make sure that we're screening it multiple times throughout the person's admission, and even before and afterwards. Pre-surgery, though, is an area that's been highlighted in the literature where we really do want to screen, because if there are issues of depression or anxiety and you can work with those before, then you're less likely to have complications later. So less infections, for example. So just a few strategies that I like to talk about. So it's really good to have a standardized screening protocol. We have that here at the Heart Institute. So when patients come into hospital, as part of the nursing intake questionnaire, they are doing the 2 screening questionnaires from the PHQ and the GAD-7. It's also great if it's really embedded right into your electronic medical record, which we also have, which is great. And then you can't only screen, right? You want to make sure that you have an algorithm of what to do when you've screened. And so you want to have referral for follow-up. If, you know, I do feel very fortunate here that we do have psychology services. If you don't at your institution, for those that are from outside, then certainly just create a list of referral resources that you can provide to your patients to make sure that they are getting that follow-up help that they need. So now just to talk a little about some of the interventions. First up, as you're not going to be surprised because I've already said it a few times, cardiac rehab. We've already heard a little bit about some of the problems is that patients are not always referred, so we need to get them there. We need to address some of the barriers that we've already talked about. And one of the potential solutions to this, and that we're already seeing, is gender-tailored programs. So woman-focused programs. And some of these are actually showing more reductions in depression symptoms than are some of the traditional cardiac rehab programs. Women do benefit from the traditional ones as well, I have to say, but there seems to be some evidence that helps to have the women-focused programming. And I just want to highlight these guidelines for women-focused cardiac rehab that just came out, like they're literally still in press. The other thing I want to say about cardiac rehab is do not delay. Do not delay the referral, and if we can, we get them in as quickly as we can, because there is some research that shows that delaying cardiac rehab entry actually increases the risk for women to have greater depressive symptoms. So if we can catch it earlier on and not have it get worse, like I was mentioning earlier, then that's better for the patient. There's been a number of reviews that have looked at the psychological interventions, and all of these have shown that there's improvements in depression and anxiety when they do have these interventions, whether it be stress management or cognitive behavior therapy. There's some inconsistent results, though, when it comes to does that actually change something with their cardiovascular risk or those major adverse cardiovascular events. We can see that there's small to moderate changes after having done these interventions for revascularization and for recurrent events. And there's also some small changes that we see in cardiac mortality. So it's doing something, but I think we need to do more. One of the problems, though, in these analyses is, first of all, many of them don't look at sex and gender analyses. There's only one that came out in 2007 that actually did sex and gender analyses. The most recent one that came out, which was about 4 years ago now, did not do sex and gender analyses. I'm not sure why. But in that one, it did show that women were not benefiting as much for these interventions as were men. So there are just a few, or I should mention one other thing. There have been, since that one study, that one meta-analysis, there have been a few that have looked at new studies that have done sex and gender analyses that have actually shown that men and women, there are no differences in their benefit. So I guess the jury is still out, but I have hope. Looking at some specific women, specific interventions, there's been a handful, I think it's 6 to be in total, but there's stress management, sort of self-monitoring, cognitive restructuring, and there's some telephone-based peer support as well, some interventions that have come out. And the results have been mixed. So for the telephone-based peer support, it actually has not shown to be effective. Again, only one women-specific study, we don't know. Maybe there's more, maybe there's things that we can tweak to make those better. For stress management, there have been some good results, but also ones that are sort of just haven't seen much differences. Although the one that had no differences, it was a fairly light intervention, I'll call it, that lasted over 1 year. So I just question the sort of the potency of the intervention. In the one that did show really good results, that was fairly rigorous study, showed that the stress management group who were followed for 7 years did show they were 3 times less likely to die than the usual care group when they were followed for 7 years. So again, more work to be done. So I just want to take the last couple of minutes to talk about some resources. So here at the Heart Institute, we have our stress management program. So it's a 6-week sort of skills-based stress management program. And then we have our second one is our managing emotions. So this class uses some of those principles from stress management, some of those skills based, but then we take it a step further and use some cognitive behavioral therapy to look at how are you thinking and what are you doing and how does that then affect how you're feeling, and really address this within a cardiac population. So they have an opportunity to share with other cardiac patients. This program is really focused on the cardiac piece. So if patients have more long-standing mental health that's unrelated to cardiac, then we're better to help them to find some of the resources in the community. And then I'll just quickly mention, as I talked a little bit about social relationships, is our Healing Hearts Together program. This is a clinical research study right now. We've shown that when people get involved in this program, which is a couples-based intervention to really improve their relationship and their communication to better cope with managing of heart disease, we've seen that it improves their relationship distress, it improves anxiety and depression, and their quality of life. And now we're doing a study to see how does it impact their cardiovascular outcomes. There's also some patient support groups here. So there's a number of classes really that the nurses lead and support groups. So those are on the Heart Institute webpage. There's a calendar, so if anyone's interested in those. And then there's also our patient alumni that has a support group that meets once monthly. I'm sure many people have heard, and I won't talk about this too much because I know the group will be talking about it later, but certainly we have a little bit of promising data so far on the Women at Heart program, and we're just waiting for the results. I'm looking at Carrie Ann because I'm excited and hoping they're coming soon for the randomized controlled trial looking at the results of this program. I also want to highlight on the Heart Institute webpage, there are a number of top 10 tips. And so there's some on emotional health, there's one on stress management, there's one on healthy sleeping, there's also some on healthy diet and exercise, etc. But certainly you can refer patients to look at those resources. And then finally, some other sort of self-management, self-help materials. There's an antidepressant skills workbook that came out of the UBC. That's free, you can download. There's another one on living with health conditions that again is free that you can download, and both these are in multiple languages. And then there's other ones that you can buy at Chapters or wherever else. Mind Over Mood that looks at how you're thinking about things and how you can challenge yourself to do certain things to improve your mood. And with COVID especially, I think one of the silver linings to COVID is that there's now more resources online, and there's been, for mental health in particular. In Ontario, we have the Access MHA, which is sort of like a non-stop shop or one-stop shop where it helps patients sort of navigate to get the, mental health and other resources that they need. And then there's a number of others which I have listed here that are sometimes volunteer, other times volunteer or paid support to help with mental health symptoms. Most of these, I will note, are more for the mild to moderate symptoms. Those that are more severe, don't benefit quite as much. And I'm going to stop there. So I always like to end by saying we need to treat the heart, but we also need to nurture the mind. Thank you. I'm happy to answer any questions. I'll repeat the question in just a moment. I'm so happy for this question. So Bonnie just asked if there are any positive psychological factors that might be linked to cardiovascular disease. And I always feel like I'm, into the darkness all the time. And so I'm, thank you. So there are, and there's things like optimism, resilience, a sense of purpose. All of these things are just in the last, I would say, 10 years starting to be studied more and more. And there actually is potentially a protective effect. So something like optimism, for example, there is, and I'm trying to remember the numbers off the top of my head, but it's about a 28% risk reduction And the overall is, I remember looking at the pooled data of all of these psychological sort of positive factors, it's about a 28% reduction. Now, I don't know if if the positive now negates the negative. So if you're feeling depressed, but then you also feel, you know, you've got some happy times too. I don't know exactly. There hasn't been research on that, but certainly both are important. So if we can help patients really focus on, you know, happiness and how to find that sense of purpose, hopefully it's helpful. Thanks. Okay.
Thanks, Dr. Tulloch. We have one question on our online chat here from Kristen. The question is, can clients self-refer for stress management and emotions program, or is doctor referral required? Many rural clients remain without PCPs and are not regularly followed by cardiology despite cardiac risk factors such as smoking, hypertension, obesity, depression, and anxiety.
Sure. So patients can request to be referred to, well, actually stress management they can do without a referral. However, I'm going to look at Bonnie. Do we have to have a referral put in now? Because we did let them do that in the past. So we should have a referral ideally, is the answer. For managing emotions, we do require a referral because we do meet with the individual to make sure that it is the right fit for them and if there isn't a better resource elsewhere for them. So we do make sure that, you know, it is a cardiac focus and that they do have some symptoms of depression and anxiety. So certainly we do ask for a referral as well for that. Yeah, exactly. They can refer to cardiac rehab, right? And a physician in the community can refer to cardiac rehab and have a request for these services within cardiac rehab, certainly. Yeah, Mark, go ahead.
Multivitamins in women mostly, and using multivitamins in chocolate, and to see if it would help with the link to cardiovascular is that multivitamins by the likes of the first year, you know, to help prevent cardiovascular disease, and the evidence is pretty working. Probably know what it may do to women based on the hospital study which is published. It may prevent dementia. And it's not the chocolate to kids, because they put a chocolate mark, which we thought everyone would like and probably help with dementia. But I think that's really, really interesting and it kind of makes us see. Shifting gears a little bit, I have a question for you. That there's a lot of depression, but obviously many of you see that, say, after heart surgery. I think we see it even after PCI, after staying, people realize their own mortality, whether it's male or female. And how often do you think we need pharmacological treatment? Are we underusing that pharmacology?
So first I'll say I don't prescribe, right? But certainly I've looked at a number of the studies. For men, it seems to be especially that the pharmacological treatments can be effective depending on the population. So for heart failure, for example, men or women, there aren't a lot of studies actually on pharmacotherapy, and they're showing that it's not effective and actually psychotherapy is better. Now for CABG, I'm not actually 100% sure for that population. I mean, certainly we see it a lot post, you know, bypass surgery. But I know for men, there are the SSRIs that seem to have a bit of a protective effect. For women, you know, the jury is a little bit out. And so I can't comment because I haven't really dove into that literature enough to say for sure one way or the other, but I think we need to look at it a little bit more. Yeah, thanks.
Hey, I'd like to introduce our next speaker. is Amy Johnston, and Amy is a PhD candidate in the School of Epidemiology and Public Health at the University of Ottawa and a doctoral trainee at the Heart Institute. Amy will share with us about the gaps and opportunity with diversity and inclusion in cardiovascular research. Welcome, Amy.
Glasses. So I think this is a perfect segue. So thank you, Dr. Tulloch, for that. To talk about diversity, inclusion, and sociodemographic considerations in women's heart health research and related outcomes. So I don't really have three objectives, but really three main things that I want to talk about. So the first thing I want to talk about is social determinants of health. And their role in influencing women's heart health, but cardiovascular health and risk factors and outcomes in general. The second thing I'm going to discuss a little bit is the current state of diversity and inclusion in cardiovascular research. And I'm guessing you all know the answer to that already, so I won't necessarily spend too much time, but nonetheless, we'll talk about that a little bit. And the final thing I want to discuss is, suggestions for increasing diversity in future cardiovascular research, and also provide a conceptual framework for considerations for future studies, study design, and conduct. So to help orient the discussion, I'd like to take some time to talk about some key definitions and concepts. So the first thing I want to talk about is diversity, inclusion, and equity, and what this means specifically with regard to in the context rather of research. So again, probably not surprising to anyone, diversity is all about including or involving people from a range of different backgrounds. So I think we need to think further beyond just male and female and age. We need to think about including people with a range of different education levels, income, gender, as well as sexual orientations, and so on and so forth. What is inclusion? Well, specifically with regard to research, it's about providing access and opportunities to participate, especially for those who might otherwise be excluded or marginalized. And the third thing, just a quick note, is really mainly the difference between equality and equity. I think that this figure is a really good one. I've seen it time and time again, and I know why it's used a lot, is because it really gives a good visual representation of what the difference is between these two things. So for those of you who may not be able to see this, on the left-hand side, we have side of this figure, we have really a representation of what equality is. So it's the assumption that everyone benefits from the same supports. And as you can see here, the shortest person there cannot see over the fence and they can't see the baseball game because everyone was given the same size box to stand on. What we really should be striving for is to give people the support that they need. So on the right-hand side, we have a representation of equity. So the tallest person does not need a box to stand on. They can see just fine over that fence and they can watch the baseball game. But the shortest person needs 2 boxes to stand on, and the middle height person needs 1 box to stand on. So just remember, I hope you'll remember kind of the difference between these two concepts as they're often used interchangeably, and in fact, they do actually refer to different things. So the next thing, again, talking about using things interchangeably, gender and sex. So gender is a different concept from biologic sex. Gender refers to really norms and behaviors, and it's socially constructed. And the concept of gender can change and differs depending on what society we're in, and of course over time. And it can change over time for a person, how they identify. And just a few quick notes, gender is not binary. There exists more than just men and women. It, in fact, is a spectrum. And sex is not binary either. Sex is not biologically female, biologically male. Intersex individuals exist. And so we should also consider biologic sex as a spectrum as well. Race and ethnicity, again, 2 terms that are commonly used interchangeably. They are related, definitely interrelated, but they do actually refer to different things. So broadly speaking, race and ethnicity are sociopolitical constructs. And in fact, they have very little biologic or genetic basis. So I said that they're interconnected, but we shouldn't use them interchangeably because they actually do refer to distinct things. So race is typically used to describe outward physical characteristics. So things like skin tone, hair color, physical features. Whereas ethnicity, especially in the research, and I think we're seeing this more and more, thank goodness, is, especially in the research that I'm reading, really refers to cultural expression and identification. So things like your nationality, your ancestry, your language, regional culture, and so on and so forth. Now, I bring up this slide. It's not a comfortable topic to talk about, but I think it's really important because I think we should move beyond just thinking about race and ethnicity and consider how systemic racism and discrimination can impact our outcomes, especially when it comes to cardiovascular health in women. So here's a definition for racism. I'm not going to read it, but what I would actually, as you read it, what I would suggest that you do is, instead of reading, inequitable opportunities and outcomes for people based on race, I would switch that and change it to sociopolitical construct. And why is this important? Well, as early as 2001, probably before that, but I think that this is a good quote that I found in a study that was published in the International Journal of Epidemiology by Cooper and colleagues. And I think it really sums it up quite well. We were starting to think about this and how racism can impact cardiovascular disease and risk and outcomes. So racism and social inequality, and I think right now we would probably change that word to inequity, can be conceptualized as social causes of excess mortality that may not be measurable at the individual level. And so, in research right now, we often think about taking individual level characteristics and considering those, especially, the hard outcomes, the hard things that we can measure, cholesterol levels and central obesity, those types of things, cardiovascular disease risk factors. But I think this starts to show us that we need to think a little bit more broadly about, what really is affecting cardiovascular disease in our health. So this brings us to the concept of social determinants of health. And so I want to talk a little bit about what this means, and specifically within the context of women's heart health and related outcomes. So you've probably seen this if you're interested in, or you've read a little bit about social determinants of health. The World Health Organization definition is often the one that's cited. And so, just to read, circumstances in which people are born, grow, live, work, and age, and the systems put in place to deal with illness. That's a lot of words, may not mean much. So I like to visually represent it. I mean, there are so many frameworks and so many models that can be used to look at social determinants of health. This is just one that I found on the Comox Community Health Network website, actually. And there are 11 factors here that they point out are social determinants of health, and they range from everything from education to, again, diversity and inclusion. You see that bubble, food security, housing, and so on. So why is this important, especially within the context of women's cardiovascular health and I guess cardiovascular disease and health in general? Well, in 2015, so think back, this is even a while ago, the American Heart Association put out a scientific statement saying that the most significant opportunities for reducing death and disability from cardiovascular disease in the United States lie with addressing the social determinants of health. So this is a very direct and pointed statement. So bear that in mind. You can go and have a look at this scientific statement as well. So we'll talk a little bit about how well we're doing, to this end. So within the context of women's heart health, we talked about social determinants, but how well are we doing, and what do we know about women's heart health and the social determinants, and what's driving disparities? Well, I really like this paper. This is a 2021 paper. Of course, there's a lot of stuff coming out now by Lindley and colleagues. And they highlight several social determinants of health as it relates to cardiovascular disparities in women. And again, it's a little different, described a little differently than the first model that I showed you, or framework. And they summed it up with 8 different kind of categories. So ranging from, education, culture and language, systemic racism, again, that keeps coming up time and time again, sexual orientation, and so on. So what kind of research do we have? What evidence do we have for this? Well, there is a lot of evidence. These are just some results from some studies. I did some PubMed searches, and it turns out a lot of people have looked at this. Now, in the interest of time, I'm not going to go over all these results individually, but people have looked at this, and we keep seeing the same thing over and over again. So something to reflect on. So we have all this evidence. I did a quick PubMed search and looked for disparities within each of these social determinants, and looked for women in particular. And so that must mean that we're doing a great job in including diverse populations and including women in cardiovascular disease research, right? Maybe not so much. So despite the fact that heart disease is the #1 killer of women worldwide, women remain underrepresented in cardiovascular research, but not only as participants, in research leadership as well. And there's an especially pronounced underrepresentation of women who are racialized, who belong to racialized populations, women of reproductive age, and pregnant women as well. And I think what this means is, if there's poor representation, then it's very difficult to make evidence-based decisions. And I really like this quote, that I think it was by Cho and colleagues, that sex-specific data is essential to optimal care. We talk about personalized medicine, but if we don't really have a good handle even on the differences between male and female, and the circumstances, for even intersex individuals, then how are we going to provide optimal care? So really, there's a lack of diversity in cardiovascular research. And I just want to give a couple of examples here. So this letter to the editor was published in 2020. And, still showing that women are underrepresented in cardiovascular randomized clinical trials. Okay, so this was published in 2020. This is a rapid review that we published in 2021 that looked at the use of race, ethnicity, and national origin in observational studies that assessed cardiovascular disease risk in women with HDP, so hypertensive disorders of pregnancy. And white women, again, were overrepresented in the literature. And why is this important? I'll just show you here. So yeah, overrepresented in the literature. So by far the majority of women were white. So this is important because women in racialized populations are overrepresented. They're the ones that are most burdened by HDP. But yet in the research, they're not represented as much as white women. So in their paper, Cho and colleagues outlined several issues related to the enrollment and retention of women with cardiovascular research. And this is specifically focused on clinical trials. And they outlined 8 different reasons. So they investigated, we know there isn't a lot of diversity. We know that women are still underrepresented. So they summarized, 8 specific points. The issues range from everything from ageism to difficulty in retaining women, to special consideration, I think I mentioned it previously, of pregnant women and women of childbearing age, and so on. And in the interest of time, I'm not going to go through each of these individually, but I do want to focus on a few of the barriers, specifically with related to enrollment and retention. So in women who belong to racialized populations, as well as low-income women, what do we see? So the barriers to participation are broad. So everything from language barriers, transportation difficulties. I think we've heard of these things, time and time again, especially, in some of the presentations earlier. But I want to point out the last 2, negative patient experiences and distrust of the medical and research community. Well, we have to think about why that's happening, what's driving that. And I think a lot of these barriers actually map very well onto social determinants of health as well. And of course, once we, if we do a good job and we're fortunate enough to be able to include a more diverse study population, unfortunately, individuals who fall into racialized, racialized individuals and, especially women who are low income, we see them dropping out of studies at higher rates. So what can we do? I think it's important to talk about what we can do because, it's a lot of negativity. So luckily, Cho and colleagues in their 2021 paper came up with a variety of different solutions in 5 different specific areas. So the first one, the area that they identified, and they identified a variety of solutions to address, involves clinical trial infrastructure. So have, again, diverse, teams, study teams, as well as sex, obviously, reporting sex-specific and sex-stratified, data. The second thing involves, the local research team. What can the local research team do? So things like expanding study visit hours, especially important for women. From the patient perspective, they point out that it's really important to provide patient education tools that are tailored to gender and culture and race and so on. And from a clinical care team perspective, really making sure that you're doing a good job with regard to making sure that there's trust among the participants, and also patient advocacy as well. So that's 4. What's the 5th one? Well, society. So I think we're doing a really good job today at demonstrating a commitment to women's health. That's the first point in Cho and colleagues' paper. From a society level, what can we do? We can start to change things if we show that this is actually an important thing. So many of you might be thinking, oh my goodness, this costs a lot of money. Well, it's probably going to cost more money. Absolutely. Women cost more. That's a fact. But think about the cost of not doing things different. So just reflect on that a little bit. So one of the next kind of points I'd like to make is that there's been a lot of research about how do we recruit and retain diverse populations and women into studies. Seems like most of the research is pointed at that, but I think we need to think beyond just recruitment and retention. We need to think about women at all phases of research. We need to think about women at the study conceptualization and design phase, data collection and analysis, as well as the reporting phase. So what does this mean in terms of research conceptualization and design? Well, the first thing that I would say is that, and I think this is a good thing, I think we've seen a shift, a paradigm shift in women's heart health, especially over the past decade, towards a more holistic view where we think beyond, just the biomedical model and start to consider both biomedical and social determinants of health. And I think this is, really good. Combining these concepts, what is happening? So this means not only looking at, these 2 factors, but looking at the interplay between these. So not only, as I mentioned previously, looking at factors at the individual level, but also looking at community level factors that may be playing a role, and also societal level factors. And one thing that you may have heard of is this kind of life course approach to epidemiologic research, but cardiovascular research in general. And I think that this is especially important for women. Because if you think about the different biological transitions over time for women, it could be things like, menopause, of course, puberty, pregnancy. These relate to particularly, rapid changes in cardiometabolic trajectories. And so I think it's important not to just, look at a snapshot in time and try and, predict, down the road. I think the life course approach, especially for women, is really important. So what can we do? Well, I think the first thing is to involve women with lived experience, not just at the analysis phase or the, dissemination phase, but at all phases of research. It can add, just such robust, expertise and just information that we might not have thought of. The second thing, obviously, is to recruit enough women in diverse populations. And not only will this, allow us to do meaningful, and by meaningful I mean powered. We have enough data to show a difference if a difference exists. Sex stratified analysis in primary studies, but if we actually report those data, then we'll be able to do and use those data in subsequent studies, and systematic reviews, for example, meta-analyses for future studies as well. But we need to do a better job at reinforcing this, because it's not enough. It's not good enough to say in a grant proposal that, oh, I'm going to do all of the things, and then really not make a good enough effort to actually do this. So this needs to be reinforced by funders, journal editors, and conference organizers. So during the data collection and analysis, as well as reporting phases, what can we do? Well, design better ways to collect and report on these data. We need to collect, make an effort to collect a comprehensive set of sociodemographic information. And also, we talk about sex differences a lot, but we also should think about differences between women. Again, we're not a homogeneous group. So think about that when you're designing your study. What differences could there be between women? Because that could make an important difference when it comes to risk stratification. And in that figure I showed by Cho and colleagues that showed the 8 different social determinants of health as they relate to cardiovascular disease in women, I showed a variety of different results and prevalence differences from studies that, again, it was a quick search in PubMed, but I think we need to move beyond that. Okay, so move beyond that and look for and use more sophisticated mathematical approaches, because if we need to move beyond explaining disparities and actually identifying targets for improvement. And of course, we need to publish our results, preferably open access, so that it's widely accessible to individuals, and it's not behind a paywall, and really do a better job of disseminating, not just in scholarly journals, but in these types of settings, as well as social media and other avenues that might be possible as well. So I'm almost through here, but the last thing that I want to talk about really is a way that we can what framework, I guess I would say, that we can use in women's heart health research that kind of brings all of these concepts together. A better way to look at social determinants and the biomedical determinants, and really look at the interplay between these things. So I like to refer to intersectionality as the plus and SGBA plus, so section gender-based analysis plus. It used to be GBA, and then it was SGB, and then it was SGBA plus. So that has evolved over time. So let's talk about this for the next couple of minutes. So intersectionality, I don't know if you've heard of it before, but just to orient everyone, coming back to social determinants of health, we know that they're associated with cardiovascular disease risk and outcome severity. And social determinants obviously can impact access to healthcare, as well as the response to specific interventions. But we have to be aware that people have intersecting social identities. When you collect information on income and social resources and all of these specific variables that when we're collecting data for our studies, it's important to understand that these things don't exist in individual silos. So they do. There is an interaction. There is an interplay between these factors. And so this is just an intersectionality kind of wheel that kind of shows the interplay between these different factors. And there are several of these, just like there are several frameworks available for social determinants of health. But this is the one that I took from CIHR, the CIHR website. So I'll just give you a few quick examples here. So intersectionality, again, it assumes that an individual's experience are not simply equal to the sum of their parts. So, for example, this is just a quick example that I had. So being a woman and being a minority, it's not additive necessarily. You know, there are things and there's an interplay between different factors that can affect our cardiovascular disease risk. So I'll give you two examples of actual intersectionality work that's been done in the context of women's heart health. So in the first study, the authors found that compared to white sexual minority women, so these are women who are lesbian, bisexual, transgender women, Black sexual minority women have a higher prevalence or had a higher prevalence of cardiometabolic risk factors. And again, they controlled for other variables. And another study that was just published, I think it was in 2021, found that compared to Black newcomer women, Black immigrant women who lived in the United States for more than a decade were at higher risk for preeclampsia. And so they posited, you know, what could be causing those things, and it, you know, they really brought in a lot of discussion about social determinants of health and racism and discrimination as being potential, you know, factors. So how can we integrate intersectionality into women's heart health research? Well, luckily, some very smart people have already thought about that. So this is a figure from a paper that was published in 2021 by Helena and colleagues, and they highlighted 5 distinct overlapping steps that we can take right now. And this is all about, again, you know, steps for how to integrate intersectionality into cardiovascular health research. And in the interest of time, I won't go over, you know, this in detail, but one thing that I want to point out, you know, as studying epidemiology, is sometimes I think it's important to also recognize, if you look in the data analysis bubble, they do mention qualitative research as well. And I think that's really important to kind of get at the why. Because, you know, it's sometimes, you know, easy to look at data and put it in a statistical model and you get what's happening. But I think, you know, integrating qualitative research can really help us get at the why. So, you know, something to consider as well when we're designing and carrying out our studies. So this was a lot. But I think this is the way forward, and you know, we've been doing the same thing for a long time, and I think you know, we're certainly not going to change things overnight. But if we take one step at a time and start working away at these things, I think that we'll be able to make a positive difference. So 3 summary points. Again, I'm not going to you know, spend too much time. I think we all know that you know, cardiovascular disease is an issue, and that you know, we need to do a better job with recruiting, retaining not only women but diverse study populations. We need to think about women during all phases of the research design and conduct. And I think, you know, as I mentioned previously, we need to you know, move towards that kind of intersectionality lens in women's heart health research. And I think that that's, you know, really the way forward in the future. So that's all I have. Thank you very much.
Thank you so much, Amy. I don't see any online questions, but I'll get us started again. Can you tell us, maybe you can share with us maybe some of the barriers to using the intersectionality framework that you just referred to earlier? You know, it seems like, as you just said, it's sort of the way forward to think about inclusivity and diversity in cardiovascular research. So yeah, what are some of those barriers to using that framework?
Yeah, thank you for the question. I think that's a really great question. And in fact, the quantitative side, which is what I'm on, it's far more difficult, I think, to do, because you have to use very sophisticated statistical modeling. And you run into issues, I don't know if anyone's quantitative here, but you run into a lot of issues with regard to collinearity. So, you know, what variables should you use? And you have to use, again, as I mentioned, maybe hierarchical modeling to look at individual, community, and societal factors. So it can get very complicated. I don't know if that's the reason why it hasn't really been taken off, but I think that certainly is a barrier. Also, getting access to the information that we think is important. so I use administrative data. And so, I have no control over the data that are collected. So I have to use what's available. And a lot of times what that means is using proxy variables. And again, I think, through this presentation, I think we've seen kind of some of the issues with using proxy variables, treating race, for example, as though it's some sort of, a biological variable. That's not really the right approach, but sometimes that's the variable we have to use. So yeah, I think specifically on the quantitative side, lots of statistical issues that are still being worked out. And on the qualitative side, I think we're doing a much better job because, it's really asking a lot of questions. And I think that's what qualitative researchers do really, really well.
Thank you so much, Amy. Any questions from our online group? Just make sure you enter it in the chat if you do have any.
Sandra, Dr. Ruel has a question here. Would you like to?
Sure.
Yeah.
I'm still really confused with sex and gender. Maybe I'm the only one, but it's really, I'm looking for practical ways. We just sent a big grant submission and I didn't write this section because how do you practically measure gender? Like sex is fairly simple and EPIC does it. I mean, today you told us that it's not binary, but it has to be at some point, right? And EPIC certainly considers it to be binary. When you look at a patient, it's male or female. I realize there are nuances, but for most people, it is binary. But gender is so complicated. And how do you measure it as you're doing a clinical trial if you don't want to spend hours like grabbing that data? I realize some of the nuances, but I need help from you.
Yeah, thank you for that question. It is very difficult. The answer is yes, you're absolutely right. It's very difficult. I think we're coming up with new frameworks. I think Genesis Praxis, I don't know if you've heard of Genesis Praxis. It was one of the first studies that actually looked at, how do we measure gender? And I think it's kind of one of the most referenced studies right now. And they actually developed a gender index where you could ask specific pointed questions. But I think that the information that's used has been criticized by certain people and for legitimate reasons, because what I think we should be doing is really kind of focusing on social determinants as opposed to trying to put, trying to figure out this gender index for a person and rating people on a scale. I know that there are questionnaires that you can give if you're actually doing studies where you're recruiting individuals and you're collecting data from those individuals. Where it really gets complicated is the use of administrative data. So I saw one study that actually attempted to come up with a gender index for individuals for data that were collected in administrative databases. And their conclusion was, we don't know how to do this. It's just really difficult. The complicating matter is first of all, is it appropriate to assign a gender index to somebody? How male or female are you? It seems, silly when you think about it that way, but maybe that's the best way, to do it. Or is it, And so, unfortunately, there is no best way to do it. I think the advice that I would give is that if you're going to measure it in a study, measure it consistently. Use one questionnaire and, administer it the same way for everyone and use that data. But yeah, it's a very, very complicated question and more research needs to be done. Absolutely. Yeah. 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 And this, yeah, and this is why I think we should be moving towards more social determinants as opposed to specific gender, because I think that may be more telling.
Is that like better than?
Ooh, not according to the big funders, certainly. No, so I would say if it is possible, I think it's just another data point to help kind of risk stratify. And again, you mentioned sex, being binary in medical records, and indeed it is. And yes, about 2% of the population are intersex, and they're a very heterogeneous population. And that can mean a lot of different things. There's no one definition for intersex individuals. But I think it's very telling that we don't actually have a box for intersex individuals in a medical record, and I think that's problematic.
Okay, we're going to take a short coffee break. We're running a few minutes behind, so maybe we'll be back in 10 minutes. Sandra, my co-moderator, does that sound good? Back at 5:02?
That sounds perfect.
Okay, and for the Canadian Women's Heart Health Alliance presentation, so we're all looking forward to that. Okay, I think we're ready to get started.
Thanks so much, Bonnie. So I just wanted to make a quick announcement before we introduce our next speakers. For those who have asked, our post-event survey as well as quiz is found in our digital event guide all the way at the bottom of the page above the sponsor section. It should be open and allow for you to participate. So we'd really appreciate your feedback about this event and how we can do it better next time. So please complete the survey and quiz for us. Thank you so much. And then our next speakers are from the Canadian Women's Heart Health Alliance team. I'm very pleased to introduce Lisa Comer, Knowledge Translation Lead, Anice Wong, Project Coordinator, and Nadine Elias, Women at Heart Program Lead and Health Coach. Lisa, Anice, and Nadine will talk to us about the Canadian Heart Health Alliance and the Women at Heart Program. So welcome.
Thank you, Sandra. Good afternoon, everyone. Thank you for joining our presentation. My name is Anice Wong. I'm the project coordinator at the Canadian Women's Heart Health Alliance, and I'll be presenting with my colleagues, Nadine Elias and Lisa Comber. And we'll be presenting about the Canadian Women's Heart Health Centre, and we'll be happy to answer any questions at the end. So after our presentation, you should be able to describe the programs and services available within the Canadian Women's Heart Health Centre, explain the Women at Heart program, describe the mission, vision, and structure of the Canadian Women's Heart Health Alliance, or the CWHHA, and identify the educational resources available for providers and patients developed by the CWHHA. So the Canadian Women's Heart Health Centre at the University of Ottawa Heart Institute is working to change women's heart health landscape in Canada. We're dedicated exclusively to conducting women-specific heart and vascular health research, enhancing care and improving outcomes in the prevention and treatment of cardiovascular disease in women, raising awareness of heart disease in women through advocacy and education. The CWHC delivers local and national initiatives to improve outcomes for women at risk or living with heart disease. And our vision is to provide leadership in development, implementation, and evaluation of cardiovascular prevention and management strategies to improve women's cardiovascular health. So the center has a number of programs and initiatives, as you can see on the slide in front of you. But today we'll be talking about the Women at Heart program, the Canadian Women's Heart Health Alliance, and the Canadian Women's Heart Health Summit. So now I'll just pass it over to Nadine, who will speak about the Women at Heart program.
Thank you, Anice. Good afternoon, everybody. Happy to be here with you to talk to you about a program that is near and dear to my heart, the Women at Heart program. So I'm Nadine Elias, and I'm the program lead for the Women at Heart program. So in the next few minutes, I'll just give you a quick overview of some of the rehabilitative needs for women and how peer support could actually help women on the road to recovery, as well as give you a description of what the program is all about and discuss program implementation or adoption if any of your institutions are interested in being involved with that program. So what are some of the needs for women after they have had a heart event? So we know that cardiac rehab is the golden standard, but yet women do not participate in it. So what are they looking for? One of the things that is very important for women is to be able to talk to other women that went through similar experiences, to be able to reach that care in an easy way, because we know that often women will go back, they're the caregivers, they want to go back to their routine. So the more accessible the program is to them, the easier that they will be involved and do it. Be able to inform them, give them more information about the different their diagnosis, the different recovery that they might need, and as well as like what it means to them now to live with that chronic condition, as well as help them to improve their communication with their doctor, to become advocates for themselves. Offer them the opportunity to express what they're going through, and the stress that they might be living with now that they have that new condition that they have to deal with. So based on those needs that we found in the literature back in 2014, as well as a national survey that we have conducted where 80% of women that participated in the survey have said, yes, if there's a peer support program, I would be involved. We put it together, the Women at Heart program. And the Women at Heart program is based on peer support. So what is peer support? Peer support within the healthcare is the provision of emotional appraisal and information assistance by a social network that has gone through similar experience or that have lived with similar behaviors. So emotional support is allowing the women through the program to be able to discuss what they're going through. Informational is to gain more knowledge, and appraisal is to help them affirm a little bit what they're going through and be able to validate the different emotions that they're going through. So what is that Women at Heart program? So the Women at Heart program is a peer support program for women with heart disease that is led by women with heart disease within local community that allows to access information, education, and support services for better recovery. So the three key things of the program is to be able to offer emotional support to promote better coping strategies for women, reduce the risk of isolation that are associated often with, being diagnosed with heart disease, like Dr. Tulloch talked about a little bit earlier, offering educational support to empower women to better take care of their health, to have a more active role to play and get a better understanding of their condition, and creating a caring environment where they could receive and give support to others. So the way the program runs it's delivered in person, and in the last few years, we were able to transition it to also now offer it virtual. So when it's offered in person, it's within local community that is accessible for women to participate. So whether in community centers available near them, to try and break down the barriers of parking or traveling, or time that might stop women from actually being involved. And when we transitioned via Zoom, via virtual, it has been offered via Zoom healthcare. So it's private and secured for women to be able to also be involved. The groups are usually between 6 to 10 people. We try to have a minimum of 5 people per group. So there is good discussions that happen and people could support each other, and not too many either. So there's enough room and enough time for women to be able to share. The program runs over a 4-month period, which is weekly and bi-weekly sessions of 2 hours length every time. And the groups are closed group. So once the group starts together, they pretty much stay together for the duration of the group. So people cannot be dropping in and out to really allow a bonding to happen between the people and feel that they are well supported. So the registration could be done online. You don't require a doctor referral in order to participate into the Women at Heart program. And any women who have had a heart event and stable, so has not been hospitalized within 6 weeks, is eligible to participate into the program. With time, we were able to also develop specific groups for different conditions. So for our SCAD group, we have a SCAD group specific Women at Heart. We also have a heart failure group, as well as an electric group right now. So depending on the need, we're able to also make the groups more specific, so the support is even better for the woman who participates. So what is covered during those sessions? So we obviously try and cover the 3 attributes of the peer support, the 3 pillars. So we talk about the emotion, we offer information, and we allow for appraisal support as well. So within the first 4 weeks, the sessions are weekly. So to really allow to create a good bond between the group and for people to feel comfortable and be able to share and support each other. And we address a lot the emotional component within those 4 sessions. We talk about women and heart disease and how heart disease is different in women than it is in men. We explain the road to recovery. We talk about the different emotions that might come, with having a new heart disease diagnosis and how to better manage those emotions. After that, we transition into the informational piece of the program, and those sessions are bi-weekly. And we start talking about managing risk factors, learning about the risk factors related to heart disease, how can we better manage them, as well as learning about the different self-management tools that could help the women on the road to recovery, to change their lifestyle. And then we wrap it up with how to become more empowered and have a more active role by better communicating with your healthcare provider, as well as finding the resources within your community. All of that is done by peer leaders. So they're role models, leaders that we train here at the Heart Institute. They have about 20 to 30 hours of training that they receive in order to be able to offer support to other women. So their role is really to help reduce the isolation that women might be struggling with in their recovery, as well as offering educational support to women to help them better navigate the healthcare system and create to them a caring environment where they feel heard and they could express themselves. And eventually our peer leaders also become advocates within the community to increase awareness about women and heart disease. How can people become peer support leaders? So basically they have to have gone through the program, have done and complete the 4 months program. After that, get the training done, and it's by application. So if ever you have patients that you think they're good or they could be interested in becoming a peer leader and supporting other, they could just apply, and then we vet them. They go through the process and we accept them if they have done the program as well. Some results to date in terms of the program achievements. So we have trained 62 peer leaders since we started back in 2014. We've launched over 146 peer support group. 55 of those have been online in the last couple of years with the pandemic. Over 1,000 women have enrolled into the program. 684 graduated from the program, and the satisfaction is 4.5/5. So usually women really do appreciate the support that they receive within the program, as well as the information that helps them to be more empowered. We've seen an increase in terms of how women cope in a more adaptive way that they're more activated in terms of, taking care of their health and making changes to their lifestyle, better communication with their provider, and increasing their fruits and vegetables intake. We also have seen a decrease in terms of the anxiety, the stress, and the depression that they have in living with that, chronic condition or heart disease diagnosed, and an improvement in their overall waist measurement. So over the last 2 years, we have reached out to other organizations that might be interested in offering Women at Heart as a service for their patient. And we have been having good success in terms of nationally expanding the program. The fact that it's virtual has also helped a lot in terms of reaching women that in normal time would have not had access to the program if it was only in person. So you have a little overview here in terms of the increase, but we have increased the reach of Women at Heart outside of Ottawa about 312% in the last 2 years with the pandemic. We have a little project, pilot project happening right now with Vancouver, and over there we've launched 2 groups so far, and the numbers are just increasing in terms of how women are reaching to us and learning about that program as well. Finally, if you are interested or you know of somebody in your organization that could offer that program or help offer that program as a service to your patient, we do have an implementation process that helps us in terms of taking you from pretty much A to Z, implementing the program and having it up and running. So we help you through the needs assessment to see what's the needs and want of your organization in terms of offering that program. We also talk about planning, how we could make it happen, how can you fit it within your protocol, so in terms of recruitment of your patients and recruitment of your own leaders. We have a training to help you learn about the different processes, how to run the program, your leaders to be comfortable offering the material, and also to implement the program after you've promoted it and evaluated it. And I believe this is it for me. I'm not sure if we're taking questions right now or at the end. Perfect. So I'll pass it over to Lisa.
Hi, everybody. Lisa Comber. I'm the lead for the Canadian Women's Heart Health Alliance. I'm very excited to be speaking to you all today. Today, I'm going to be talking about the Alliance and all of the programs and services that are available and resources. So to start with, we all know, I think from today's session, that cardiovascular disease continues to be the leading cause of death for Canadian women. Sex and gender differences and disparities with respect to CVD awareness, development, and identification and treatment is persistent. So since 2016 at our inaugural Canadian Women's Heart Health Summit, one of the priority action items was to develop a network of stakeholders. So that's clinicians, researchers, clinical scientists, trainees, women with lived experience members, as well as decision makers and program leads to work together collaboratively to implement evidence that we already know, transform clinical practices, and impacting the public policy with regards to women's cardiovascular disease across the lifespan. So in 2018, we were able to launch the Canadian Women's Heart Health Alliance. And of course, the vision is to improve women's cardiovascular health across the lifespan. And we have to date actually over 130 members. So it's very exciting. Here is the executive steering committee. This is the organizational chart of the Alliance. You'll see there, this is the leadership that we have currently. And then you'll see that we have 4 pillars of or themes: knowledge translation, mobilization, training and education, advocacy, and health systems and policy working groups. And then you'll see the secretariat that is comprised of myself, Anice, as well as our colleague Melissa Corgun, and then of course led by Dr. Coutinho and Dr. Carrie-Ann Mullen. What's really amazing about this organizational chart here is that you'll see that we have a trainee representative, Naja Adric, as well as leaders of our working group co-chairs, and that is one person who is a healthcare professional, or healthcare provider, sorry, and as well as a woman with lived experience at the decision-making table. So it's something that we're very excited about, and the team is a 2-year turnaround cycle for project cycle, and so this is our leadership for the next little while to next year. We are very excited and fortunate to be awarded the Dr. Harold Siegel Award of Merit at this year's Canadian Cardiovascular Congress. And this particular award is all about the participation in the betterment of cardiovascular health in Canadians by advocating for prevention and cardiovascular disease and the promotion of cardiovascular health in Canadians. So we're very excited that the Alliance has received this recognition. As I mentioned, that there are 4 pillars, so advocacy, training and education, health systems and policy, and knowledge translation and mobilization. Within each of these working groups that are led, as I mentioned, by our co-chairs, there's about between 30 to 50 people per working group. And with more people, more volunteers, we can do more. And so I'm going to highlight some of the amazing outputs and projects that are currently underway within the Alliance and to let you know a little bit more what's happening behind the scenes. So for the advocacy working group, this of course is trying to reach as many people as we possibly can about women's cardiovascular health, signs and symptoms, prevention strategies, and all that wonderful stuff. So this is something that the advocacy working group is a very busy working group. We have about 4 projects underway under this team, and I'll highlight a few of them today. So you may have already known about Wear Red Canada, but we love to promote with all of our branded merchandise here. But Wear Red Canada is in its 5th year, and the goal is celebrated annually across Canada on February 13th to raise awareness about women's cardiovascular health. And in our 2022 campaign highlights, just wanted to mention a few of them. This is honestly grassroots. So this is just our groups of people from across Canada looking to amplify the message that we're trying to get across around women's cardiovascular health. And with that, we've been able to have over 10 million impressions on social media. We've had some amazing influencers participate. We have Olympic athletes, we've had chefs, we've had political parties, we've had a lot of opportunities for us to be able to amplify. Proclamations, so we have 45 proclamations across Canada from cities, provinces and territories and municipalities proclaiming Wear Red Canada Day on February 13th. You might have noticed last February that we had a lot of the downtown core in red. So a lot of our landmarks buildings, the CN Tower, I know at Whistler Mountain, here within the Ottawa area, we've had a number of different locations and landmarks lit in red, and it's growing. So that's obviously in support all these businesses and communities, hospitals and institutions, academic institutions participating in support of the cause. We've also been able to conduct media interviews. We have which I'll talk about, a movement challenge coming up. We also incorporate educational materials. So we do webinars, we've done social media videos, posts, infographics. And then you'll see there on the bottom with regards to key messages, Anice is going to talk about that, but we've been able to utilize just our networks and through some of our contacts, translations of our key messages into 13 different languages. Also, high schools, we're connecting with high schools. Last year, we launched a program, which I'll talk about, but we've been able to get amazing uptake just with people working within the community and talking about Wear Red Canada. So new this year, originally was the 5K virtual event. Now it's changed to our Wear Red Canada Movement Challenge. And this is a virtual event, but you now, depending on where you are in Canada and with regards to the pandemic recommendations, people are meeting in person to do meetups. But it is virtual, and so anywhere between February 1st to the 28th, please, it's all about getting up and moving. And so you can sign up for a 5K or 10K distance or 30 to 60 minutes of movement. And all it is anything that you want to do in terms of getting up and moving. And so that could be a run, a walk, a bike, if possible. Or you could dance in your living room, you could do a yoga, anything that you want just to keep moving. So more information to come. Registration is going to be opening in November. Teams, individuals can go in there and you can create a team, but more information will come on our website. We have targeted outreach this year for this year's campaign, and that's where, as I mentioned, we're growing our I guess you could say product outputs or offerings for high schools, as well as post-secondary, workplace, and then we are targeting primary care clinics. That could be community health centers, nurse practitioner-led clinics, family health teams, as well as cardiac rehab programs from across Canada to participate in Wear Red Canada. And that could be involving wearing red, of course, also going on social media, posting of that information of you wearing red, highlighting perhaps some of our 5 key messages, and hashtagging Her Heart Matters. members. Signing up a team for our movement challenge, lighting up your academic institution, hospital, or office building, as I mentioned, joining or organizing an awareness event. So this is an amazing awareness event that's happening today, an educational event. There's opportunities for people to be able to run 1-hour lunch and learn lessons, lunch and learns. There could be info booths, offering of just handouts, whatever. We have tons of opportunities and ideas that are up on our website, as well as requesting an educational presentation. Either somebody within your institution would like to do that or request a presentation from one of our community advocates. The heart of the matter, this is the lesson, this is what I was referring to with regards to our high schools. And I just wanted to highlight it because it's such an important and exciting initiative that we started. And this is a lesson plan and toolkit for high schools targeting grade 8s to 11. And that's just because of obviously across Canada and depending on the subjects. So what it is, it's a 60-minute lesson plan where we have the educator is welcome to present the content. There's an icebreaker activity, pre and post assessments. There's an amazing video with one of our youth advocates who interviews a woman with lived experience and her son who is in high school and his experience with his mom going through a SCAD incident with the birth of their third child. And how it impacted the family, as well as 5 practice activities. So we have physical activity there. We could writing exercises. There's opportunities to speak to anybody in leadership. If you want to write a letter, perhaps to your municipal representative and so forth. So there's about 5 different practice activities that they're welcome to take on, as well as trivia. So we have created trivia slide decks for beginner, intermediate, available on Kahoot, which is very popular. We're finding out. And then, of course, ongoing learning. And so there's within that 20-minute presentation video, there's also a talk about the anatomy of the heart. It talks about why women's hearts are different, and this is from our healthcare professional, Dr. Judy Liu, and she also refers to the 5 key messages and how, as a youth, how can you participate in this? So that is one aspect. We have other opportunities for high schools this year, and that is we are offering a national innovation contest where classes are able to work together as smaller groups to look at a problem, which is obviously women's cardiovascular health, and looking at proposing solutions. And so there is going to be a contest. It's going to be judged on a national scale by educators, women with lived experience, and professionals, healthcare professionals. And so that's more information is available on our website. There's also an opportunity for scholarships. So we have up to $5,000 towards a Canadian Women's Heart Health Alliance Youth Advocate Scholarship. Also, if you want presentations, and as well if anyone wants to run an assembly or any type of educational event at their school. And actually, I'm going to pass the baton over to Anice to talk about these amazing multilingual resources.
Thanks, Lisa. So one of the projects within our advocacy working group is the multilingual resources. So to reach more women across Canada, and particularly those who are at higher risk of heart disease, the Alliance has created some multilingual resources. The resources address symptoms of heart attack, causes of heart disease for women, risk factors, and ways to reduce your risk of heart disease. So using Chapter 2 in our atlas, which we'll talk about in a few slides, we use that as our target audience is the Indigenous population, Black, Hispanic, South Asian, East Asian, and the Chinese North American women for this project. And this is a multi-phase project. So the first phase, what we did was we took our 5 key messages from Where in Canada and we translated them into 12 different languages. So altogether 13, including English. And they include English, French, Arabic, Creole, Hindi, Inuktitut, Chinese, traditional and simplified, Portuguese, Punjabi, Spanish, Tagalog, and Vietnamese. So our goal is to build also community relationships with cultural associations, community health centers, women heart health centers, and doctors' offices to assist with our dissemination of these translations and PDFs. So the resources are available in PDF, but what we also did was we were able to use some of our Alliance members and use our expertise and language abilities, and we made videos in all the languages that I just mentioned. So the translations, they were professionally translated, and they were also reviewed by healthcare providers and patient partners and also members of the community before we put them up on our website. So the content is housed on our wherericanada.ca website if you do want to look them up. Currently, we are expanding our video, so our catalog of videos. So we are currently working on sign language, so that's ASL and LSQ. Future phases of the project include translating the key messages, translating our posters and brochures into the different languages. So these are just a few screenshots of the key messages that were translated, and also some screenshots of the videos on our YouTube channel. So I'll talk about the peer support network project, which is within the advocacy working group. We have two projects within the peer support group. We have the Women's Heart Hub and also a evidence map project. So as many of you know, and Nadine mentioned this before in her presentation, women living with diseases of the heart and blood vessel need more than medical care. So peer support empowers women and provides a safe place to meet, bond, and share experiences. Peer support comes in many forms: in person, virtual, formal, informal, and to help connect women with peer supports that are right for them, the members of this subgroup within the advocacy working group created a national directory listing programs and services and different initiatives for peer support. The directory is the Canadian Women's Peer Support Heart Hub, and its intent is to increase awareness and connections for women living with heart and vascular disease with peer supports that meet their needs. So right now, if you go on womenshearthub.ca, you can find approximately 20 different programs listed so far. The criteria that we used is they must be based in Canada, inclusive of women, so it could be only women, a women's only group, or a mixed group. It has to be heart and vascular focused, online or virtual. And the sorry, the other peer support project that we have within the network, peer support network project, is the peer support interventions for women with cardiovascular disease, so an evidence map. It's a broad search, a one-year broad search of the literature that's currently being conducted, describing peer support interventions used by women with CVD to inform future programming and offerings. And you'll see the goals of our evidence map here. The first one is to provide an overview of the context in which peer support interventions have been used in women with CVD, identify gaps in primary studies where new or better studies are needed, and describe specific knowledge gaps where more complete systematic reviews might be required. So the project is partially funded by a CIHR grant and is led by Dr. Monica Perry. Our team consists of about 12 to 13 other researchers, trainees, and what makes this project really unique is that we have a couple of patient advocates on the team that are helping with the screening, the reviewing, the writing of the protocol, and also the data extraction that we'll do later this fall. And some exciting and recent news is that our protocol paper was just recently published in BMJ Open. So the link is on the screen here. And we hope to publish, we hope to submit to publication sometime, I believe, in spring 2023. So I'll pass it over back to Lisa to continue.
Thanks, Anice. So we talked about the advocacy working group. So you can see they're pretty busy. And now I'm going to talk about the knowledge translation mobilization group as well as the health systems and policy team. So just regarding the scope for knowledge translation mobilization is they are looking at the translating of evidence and existing and new knowledge and looking at a variety of different knowledge translation type outputs. So you'll see there just in the definition there, guidelines, tools, programs, and it's all about improving the outcomes for Canadian women. Health systems also, they're working at exploring cost-effective strategies in the improving and monitoring of women's cardiovascular health and promoting these strategies based on the findings. So back in 2018, when the teams were meeting to discuss what their project planning would be for the next 2 years, they realized that, well, KTM knowledge translation team wanted to do a consensus document to look at the lay of the land, and the health systems team wanted to work on a policy document. They realized, though, we need to do a real baseline approach here and see where are we currently within this landscape. And so they decided to work together in a joint venture, which we coin now the JAHA paper, but it's the State of the Science of Women's Cardiovascular Health Disease and the Canadian Perspective, the Influence in Sex and Gender. So this particular publication has already had over 14,000 downloads. It's been cited over 66 times. That was last time we checked, which was a few months ago, but I'm just saying is that it has been, the visibility has been phenomenal, and we're very excited about it. 35 authors from across Canada from a variety of different disciplines, and so stakeholders, even including our Women in Lived Experience, participated in authorship of this journal article. And so what happened is that we had so much information. There was a lot of teams working together. We had over 80,000 words, which had to be condensed for this particular publication. And so they thought, what are we, and this is a beautiful summary. It's an outline of the issues with regards to, or the current landscape right now, women's cardiovascular health. And so we thought, well, why not take advantage of all of this amazing literature that we've been able to put together and create a more of a live document. And this is what we talk about when we refer to the atlas. So this is the epidemiology, diagnosis, and management of cardiovascular diseases in women. And so this atlas is as I mentioned, a live document. It has multiple chapters, really going into in-depth areas on all of those high-level topics that were mentioned in the JAHA paper. And what's amazing about this is that we have different chapter leads. So within the Alliance, we have chapter leads. They take on for the chapter, but then there are women in lived experience who are included in all of these chapter publications. We have an amazing partnership with the Canadian Journal of Cardiology Open, Dr. Michelle Graham, and she has allowed for us to, we've been working together. They have a whole collection on the homepage of the Canadian Journal of Cardiology Open specific towards the Atlas and the Canadian Women's Heart Health Alliance. And so just to give you an overview here regarding publications, we have published chapters 1 through 6. And we are in the midst of chapter 7 and 8 are currently in production internally here in the writing groups, and chapter 9 is soon to come as well. We hope by the end of, mid-2023, we'll have all chapters done, and then we will continue with annual or biannual updates to provide the latest and greatest information. So this is the goal, is that we have this document or the set of chapters specific to these areas where you're able to go to get the latest information and research available to you. And because of part of knowledge translation is looking at different ways for us to package the information, this of course publications, but then we've also decided that as part of the outputs, we offer a webinar that targets the general population. So anybody can access, of course, it's free, of course, and it's open to everybody. And we also provide infographics highlighting the key takeaway messages within each of these subject areas. So this right here is just a snapshot. You're more than welcome to have a look on our website and to gain access to all of these infographics as well. If you want to go on the Canadian Journal of Cardiology Open website, it's all on the homepage. Health Systems and Policy Working Group, they are currently working, so that's an ongoing project. This project started about last year or so, and it is specific on identifying the barriers for access for women's specific cardiac care across Canada, looking at the differences across regions and levels of service provision to inform care and policy changes. So we are looking at where are the gaps in care, where, depending on somebody who's living in a rural area versus urban, how are they gaining access to care? What what are the barriers for access? And so this is something that we really wanted to look into a bit further, and not just looking at when they get to the hospital, but looking at the pre-hospital stage, looking at the acute care stage, as well as the follow-up once they're discharged within the primary care setting. And so this is something that we're looking and doing. We are in the midst of sending out, or actually following up with our national survey. And this is targeting healthcare providers as well as women with lived experience to identify their experiences and to be able to acknowledge where those barriers and gaps are. For expected outputs, position paper describing the existing systems and policies available to with women's cardiac care across Canada, as well as a policy recommendations paper. So talking more thoroughly about the facilitators and barriers, and to hopefully look at considerations for moving forward and hopefully reducing these barriers. The Knowledge Translation Working Group is also working on, they've joined efforts with this national survey, but this one in particular is looking at the current state of cardiovascular care provided to women in Canada. And so this national survey is really trying to identify the current landscape of programs and services that are available to women across Canada. And so this is information that's going to be foundational for us to be able to move forward in future planning with regards to projects, programs, and initiatives that are allowing for availability and access to care. Expected outputs are a publication, report summarizing the findings, providing and developing a provider toolkit, as well as increasing or expanding the Women's Heart Hub.ca directory to provide our women lived experience, our patient advocates and caregivers, as well as our providers, a listing of available programs and services with descriptions, locations, availability if it's virtual, in person, and more information with contact information for more, to get more info. Another project that's happening within Knowledge Translation is the cardiovascular disease in women in the emergency department. And so this is something that came out actually about through the ER department in BC. One of our amazing advocates, Dr. Shaheen Jaffer, presented about the Alliance and so forth, and they requested, the BC Emergency Medicine physicians, they requested a document or a protocol specific to chest pain and ACS for women who enter the emergency department. So the team has worked together to develop a 3-page document outlining all the areas that need to be known for regards to symptoms, recognition screening, potential treatment options, or sorry, treatment and protocols. So there's more information to come on this. This is something that we're looking for as a springboard. Right now we're talking about ACS, but we're looking at other areas as well to develop. And so this 3-page document will be available very shortly on our website and accessible to all. And we are targeting emergency medicine departments across Canada for adoption. We have a clinical practice update. We have been accepted for the CCS to develop a writing team for a clinical practice update on MINOCA. And this is something that we hope to have ready to go and launched in October 23. And the co-chairs are Christine Pacheco and Dr. Tice Coutinho. And we're also looking, this is relatively novel, is to incorporate, along with the clinic practice update, a plain language summary document, which is available to everybody for consumption. Because we know that there's no currently a consensus statements or guidelines regarding MINOCA in Canada. And furthermore, there's persistent gap in clinical care. So we're really hoping with this document, as well as the plain language summary document, that we're going to be able to put that and provide that available as much as we can to whoever's interested, and then as well as for the plain language allow for our women to be empowered for when they do go to the emerge. So that's the knowledge translation mobilization. And lastly, the training and education working group. We have just launched, and I think the link will be available to everybody here. This is available for free and available in English and French, and it is accredited to the Canadian Cardiovascular Society. And it is an educational course and teaching toolkit. It is comprised of 9 modules, specifically around sex and gender and cardiovascular disease for women. And it's available on our website. You can access them. They are about 30 minutes in length, each of the modules. And there's also Women in Lived Experience story attached to each one of these modules. And there's pre and post test questions. What also is an important thing to note is that is a teaching toolkit. So within the learning management system, we offer all of the PowerPoint slide decks, references, linked to the actual articles online, and allowing for faculty or others who are interested in running and presenting their own content at their own institutions, grand rounds, or any other type of presentation opportunities to be able to do so. We also offer for speakers too. Our members are extremely open to being a part of invited talks, so that's always an opportunity too. There was a publication with regards to the methodology of creating our educational course. And we are now using the course content to allow for us to work directly with institutions, academic institutions. We have targeted medical schools, nursing programs, allied health programs, kinesiology. We're looking at midwife, respirology, and paramedics, and a few other groups to connect with a survey, identifying where those gaps are in knowledge and in their current curriculum, and offering of different types of outputs to allow for this content to be put into their existing curriculum. And so that could either be using our modules as is, using the content in the PowerPoint slide decks for presentations, invited speaking. We're looking at developing case studies, and then also placement opportunities if possible. So this is a really great opportunity. There's already been 6 or so universities that are interested in working with us, and we hope to continue those relationships moving forward. So that's all about the Alliance. And so if you ever any questions with regards to that, all of the projects that I mentioned, as well as a few others that are happening, one of them being I just wanted to highlight is that we do have a member success program for our members where trainees, we're having a mentorship opportunity where for trainees, as well as women lived experience, a development opportunity for advocacy. So that's going to be launched in early of this next year. And so we're very excited about this initiative, and we're excited to be promoting it at the Canadian Cardiovascular Congress this year. So more to come with regards to that, but if you're ever interested, reach out to me. Also go onto our website. We're always looking for new members, as I mentioned, to volunteer. More volunteers we have, the more we can do. And so we're very fortunate to have over 130, which is growing every month. But if anyone is interested in working within the Alliance, please feel free to connect with us and have a look on our website. Moving gears here, then, I just wanted to highlight our Canadian Women's Heart Health Summit. This is actually so exciting to say because we're having it in Vancouver this year. That's going to be taking place April 28th and 29th in Vancouver. You're welcome to have a look on womensheartsummit.ca. And so this is a great opportunity where we've been able to partner with the University of British Columbia, with the Leslie Diamond Women's Heart Health Center, as well as the CCI. And so in partnership with us and of course Heart and Stroke, we're really excited to have an amazing lineup of internationally recognized speakers. It's a 2-day event, and more information in regards to registration, call for abstracts and all that is on our website, but please keep note, November 1st is when everything's opening up. And that's it. Any questions?
Okay, yeah, great. I thought I'd come over here because I want to start off with a comment. First of all, congratulations on all the amazing work that you do. Really, I thought I knew a lot about what you guys all do, but I've learned so much in the last hour. So I really want to commend you for everything you've done. And Carrie, it's incredible the work that you've done for women across Canada. So
Thank you,
maybe
Bonnie.
a little round of applause for that.
Thank you, Bonnie.
And I was really impressed to see the work that you're doing to reach women who are hard to reach and marginalized populations. And so I'm just wondering about what some of the successful strategies that you use, for example, within the Women at Heart program to recruit women from these populations to that valuable program, which I'm sure, particularly during the pandemic and everything, has really been a lifeline for our patients.
Great question. I didn't know, Nadine, did you want to talk about Women at Heart? And I could talk about the Alliance too.
Well, one of the things that we have been trying to do is actually using our patient advocate to promote more the program within the different cultural group. So a lot of them in the last year or so have been doing virtual presentations to talk about the different things that we do for women's heart health, but also for women at heart. So that we're still, there's a lot of work to be done in this area, but that's what we started by doing, is truly trying and creating partnership, with the different cultural organizations within our community to try and promote the program and get the word out.
Sandra, do you have questions online?
I just have a few comments. A comment from Freya about just the phenomenal work, and Robin as well, just encouraging everyone to join the Alliance, that it had really increased skills and knowledge just in her work as cardiac rehab exercise therapist. So yeah, just all around really positive comments about the work that the Alliance does. I think it was an earlier question from Brittany about asking about for women who are currently going through the process of diagnosis, like we heard earlier from our patient Tammy. Is our Women at Heart program a good place for these women who are still kind of figuring out diagnosis and kind of gaining help and advocacy skills, because it is kind of scary not knowing the diagnosis and that process and journey. Not sure if you can comment on that, Nadine.
Yeah, I sure can. So we don't refuse any women who would like to participate and gain knowledge and becoming more advocate for themselves. The only thing that we always warn women about is that within that same group, there might be some women that might have gone through open heart surgery or just had a stent. So possibly that the emotional aspect that they're coming out with within the group might scare some women who have not gone through any diagnosis yet and just in the process of, figuring it out. So as long as they're comfortable with that and they're aware of it, then they're more than welcome to participate. We had few women that did get involved into the program that had not had a diagnosis, but they were there to get the knowledge. But so that would be the only thing. For some, it might not be, the perfect situation if it's going to cause more anxiety. But in general, if they're aware and they're comfortable, they're more than welcome to attend.
Thank you, Nadine.
Thank you. And just to add to that as well is through our Wear Red Canada campaign, we are launching a new website the next little week and a half, hopefully 2 weeks. So if you do go to wearredcanada.ca, you might see the look and feel a bit different. But we are highlighting stories from our patient advocates. And a lot of times, and then also, so that's so important, is that identifying what those symptoms and what the experiences of some of these women who've already gone through this, that's been very helpful, I think, for those who might not know what's going on or have not received any definitive diagnosis. So understanding that, and also a lot of our media links that we do have on the wearredcanada.ca website, I found that was very helpful with a lot of our patient advocates sharing of those stories far and wide, where then they were able to identify a potential provider that they could connect with. And knowing, okay, maybe it could be this, that sounds similar to mine, and then voicing that and being empowered enough to speak to your physician, your family doctor, or even your cardiologist, or within your care system to talk to them about those concerns. And sometimes having the right wording to be able to describe what you're experiencing by hearing it from somebody else who has gone through something similar has been very helpful, I think, for those still trying to find out what they currently are dealing with. So those are just some ideas, and of course, through a lot of our advocacy work through Wear Red Canada and through the Alliance, we're really trying to offer support to those individuals, because it is a very scary time. And sometimes it takes a number of years to identify what the potential issues are. So please know that we understand that this is a very stressful and scary time. And we're really trying to, through our directories, through the Women's Heart Hub.ca, offering of supports and resources and programs that could be available to you virtually if you're not able to go in person, so that everyone can get that type of care that they need.
Hi, I had a SCAD last year, and I just want to tell you that I participated with Ellen Roberts with the SCAD group, and there were ladies from Vancouver to Ottawa. So it was very interesting and very uplifting for me. So thank you so much for all the work you do.
Thank you.
Thanks very much for mentioning that. And I think that is one of the opportunities or one of the bright sides of COVID, if there are any, that moving our program virtual has really been able to reach people across Canada. Women, especially women who live in rural areas who really do not have any services, no cardiac rehab programs in their areas. I think in particular, we're hearing a lot of great feedback. Some are finding us spontaneously, but we're now trying to more systematically roll the program out across the country. So thanks for mentioning that, and happy to hear you enjoyed the program. I'd like to echo Bonnie's comments. I don't know how my team does it. Lisa, Nadine, Anice, great presentations. Thanks for all the work that you do. I don't know how you juggle all the balls that you do. It's super organized group, obviously, but really incredible work. One of the things we talked about during the break, Amy and I, was sort of tying Amy's presentation into, I think, one of the other questions we had. We often, so in our program, Women at Heart, for example, we know who's coming to our program, and we might know who's not coming to our program, but I think we need to know a little bit more. I know we need to know more about why they're not coming to our program, because Amy presented barriers to research for women. I think that list that you provided of those barriers is very similar to the barriers that women face for joining our support programs as well, not just research. Certainly in primary prevention, we see this. In secondary prevention, our psychosocial interventions as well. So just to keep in mind, we've talked about this on our team, but we need to learn more about really what are the main barriers for people joining our programs, and we need to start working on filling those gaps for sure. Congratulations on all the work that you do.
Caring. And just to add to that too, because I would like to talk, is that with regards to the relationships that we've been able to foster and develop and build through our multilingual resources, the dissemination piece, that's something that we're really trying to target. Like, how do we reach these individuals with the resources and the supports and the services that we provide? And also just offering of the key messages that we really want to bring forward, especially to the various more at-risk target audiences, so our target groups. And so I think it's happening. We're developing the channels right now. And so in further opportunities for us for dissemination is going to be a lot more easier or accessible for us to be able to reach those groups through these networks that we are creating through this national alliance. So as I mentioned, volunteering is more than welcome to cwhha.ca. Thank you.
Thank you. Just one more question for Lisa or Nadine. There was just a question from Sonia on online there about asking about whether we have information or support for husbands or partners that can help understand what their wife is going through. So just wondering if you can comment on that, Lisa or Nadine. Thank you.
Sure. Well, I can talk, and I don't know if you have something to ask too. Is that we are looking at educational social videos that we've created where we have a woman lived experience as well as like talking about her story for about a minute or so, and then we have an interview with a healthcare professional regarding various topics, and that is one of the topics that we are actually going to be filming in the next month or so regarding the caregiver's experience and supports that are available. And I don't know if Heather Tulloch is in the room, but she'll be interviewed. And so because there's some programming and services and resources available for caregivers that we really want to bring forward, because we understand as a family dynamic, everyone is impacted by especially their loved one's diagnosis. So offering of those supports is something that we are very much aware of, and we want to have it up at the front and available on our website. So that's something that we're looking at in the interim. And I don't know if Nadine, if you wanted to mention too about your program.
The only thing that I could add to that is that part of the resource section, when we talk about Women at Heart, like in session 10, 9 and 10, we have resources that if it's a struggle within the family, that the patient could bring the resources to their family members and encourage them to participate in certain of those programs and services that we have. So we do have a list of what's available, for caregivers if that's a struggle within your own family. So we do provide them with that.
Any other questions, Sandra?
No, that's it. Just lots of great comments, just about all the positive work.
Thank you so much, everybody. Okay, so Sandra has asked me to remind everyone to please complete your post education and post knowledge and the presenter evaluations. We have a really good number for the pre one, so we're working on getting a number for the post one so we can draw the rest of our prizes at the end. So please, the link is actually in the chat to complete it. I would like to introduce our last speaker of the day. Her name is Helena Van Ryan, or more commonly known to those of us who work with her as Lainey. So Lainey is a remarkable physiotherapist at the Heart Institute, and she's also professor at Algonquin College in their cardiovascular technology program. Lainey has done a tremendous amount of work in the Alliance, and she also participated actually in the development of the learning modules that were just brought up in the last session. So Lainey will share with us cardiac rehab for patients with SCAD and MINOCA. So welcome, Lainey.
Thank you, Bonnie. I'm very pleased to be here today, and I want to thank Dr. Paquin and my colleague Guian Prue, who reviewed this presentation in advance. And I also want to thank you, Manu, for manuifying my presentation. I'm going to make sure I can advance my slides. There we go. I have nothing to disclose, and the information provided in this presentation is not meant to substitute for professional medical advice. Should I just press enter to advance, or no longer advancing? Here. Enter doesn't seem to be advancing it. Yeah.
Oh, there.
I have to go there. Okay.
Yeah.
Thank you. Sorry. All right. So the content of today's presentation will highlight the multinational SCAD registry. We'll talk about the components of SCAD and the known triggers, which we've heard a little bit about already today. We're going to talk about the literature reviewing physical activity in SCAD. I'm going to mention a case study, and finally we'll talk about 2 MINOCA studies and conclude. So the Mayo Clinic published a registry which was led by Dr. Audrey Chaussin Suarez et al. And they surveyed SCAD patients from March 2011 to November 2019. They had 950 participants. The mean age was about 47. There were 96% women, 77% attended cardiac rehab. 70% of the SCAD patients had at least one risk factor, with high cholesterol, hypertension, and obesity being the most common risk factors, which is slightly different from what we had previously thought. We used to think that they had no cardiovascular risk factors. Prior to the SCAD, 48.5% performed aerobic exercise greater than or equal to 3 times a week, and 32% performed strength building exercise. 93% received some exercise counseling, including an exercise prescription. This is a very well-known diagram that describes or shows you what a SCAD looks like. Sharon Hayes was the lead author of this publication that was in 2018. It really improved our understanding of this condition. The characteristics that they found in their study are listed on the left-hand side of the page there. 90% women, 45 to 53 years of age, and about a quarter of the women had pregnancy-related SCAD. And generally, these ladies had no risk factors. The pictures that you see show you in figure A normal artery. So you see a normal adventitia, media, and intima. In figure B, you see an intramural hematoma. And in figure C, it shows an intimal tear with a false lumen. So theories around what SCAD's all about. As we've heard already today, there are emotional triggers that are most common in women, physical triggers that are more common in men. Severe illness can sometimes be a trigger, but it's less common. And about a quarter of the women with SCAD have recently been pregnant. What do we know about cardiac rehabilitation? Well, Dr. Saw's group from Vancouver published a paper in 2021, and in it they stated that cardiac rehabilitation is a multidisciplinary intervention for secondary prevention, improving functional capacity, enhancing quality of life, and improving psychosocial well-being in a broad range of cardiovascular diseases. It is well studied over a number of years and is a Class 1 recommendation in multiple guidelines. There was a Cochrane review as well on the benefits of cardiac rehabilitation. They examined 63 studies and approximately 14,500 participants. And they found that cardiac rehab showed a statistically significant reduction in cardiovascular mortality and risk of repeat hospital admission. Health-related quality of life metrics were significantly improved in a majority of the studies, and overall the benefits appear to persist over time with a 21 to 34% reduction in mortality over time. So we know that cardiac rehab generally works, but what do we know about SCAD? Vancouver General Hospital has led the way in this assessment. Dr. Jacqueline Saw's group were the first to study and demonstrate safety in the SCAD population. They were assessed at baseline with cardiopulmonary stress tests, body composition, depression scores, and emotional stress. Participants were prescribed 60 to 70% of heart rate reserve and an RPE, a rating of perceived exertion of 12 to 14, so somewhat hard, which gradually increased as their aerobic capacity improved. Patients received psychosocial, nutritional, and stress management support, and fitness levels expressed in max VO2 were increased by about 18%. This research is now widely quoted, and VGH now has a SCAD-specific cardiac rehab program, which uses most of the above guidelines. They adjusted the exercise prescription to use 50 to 75% of heart rate reserve based on the entrance stress test, and less than 130 millimeters of mercury of systolic blood pressure to reduce the arterial shear stress. Of note, at the Heart Institute, we now use a calculation with age-predicted heart rates. At a mean follow-up of 3.8 years, there was a significant reduction in major adverse cardiac events, or MACE, which was reduced from 4% versus 26% in the control group. So that's a 22% reduction in MACE, which is very significant. Physical activity and exercise in patients with with a SCAD and fibromuscular dysplasia was studied at the Mayo Clinic by Marcia Tweet et al. And this was the first very clear and helpful guideline that was published in 2021 in the European Society of Cardiology journal. So you can see it was very, very recent that this publication came out. What is fibromuscular dysplasia? It affects the arterial walls, making them either too weak or too stiff. And it is associated with conditions, it's an associated condition with SCAD, but it affects 90% of women and is unknown in its cause. It may be related to other connective tissue disorders such as Ehlers-Danlos syndrome. In this paper, they identified recommended with caution and things to avoid as far as exercise is concerned. The overall goal was to aim to achieve 30 to 40 minutes of moderate physical activity 5 to 7 times a week, or approximately 150 minutes per week. The recommended category, which kind of looks a bit green and is on the far left side of your screen, is cardiac rehabilitation, moderate aerobic exercise, interval training, which is not to be confused with high intensity interval training. Those are two separate things. Weight training with low resistance and high reps. With caution, they suggest endurance aerobic training, muscle building exercise, and yoga poses without extreme head or neck positions. And to avoid abrupt, high intensity exercise, peak weights with prolonged Valsalva, so holding your breath, contact sports, and extreme head positions. This is now applied to our SCAD population with or without fibromuscular dysplasia. I want to go back to an earlier study that the Mayo Clinic group published, which showed that 269 patients attended their cardiac rehabilitation program, and they attended about 76% of the sessions that were offered. Their average age was about 46. 96% were women. 82% perceived physical health benefits, and 75% perceived emotional health benefits. We've been talking a fair bit today about the barriers, and this same publication by the Mayo Group brought to light some barriers to participation. In their initial registry, 85 patients did not participate. One of the main reasons women cited for not participating in cardiac rehab is a lack of physician referral. Other barriers to participation included inadequate transport, no insurance coverage, or the cost of cardiac rehab. In Ontario, it is covered by our provincial health insurance, but I've since discovered working with the Alliance that it's not standard across the country. Caregiving and work responsibilities were also cited as a reason to not participate. No energy or lack of motivation, and just feeling generally too ill. Dr. Sharon Hayes, who is a leader in this field, has summarized these guidelines in her 2018 publication. She says, providers are encouraged to prescribe a prudent approach to physical activity, balancing the known benefits of exercise with the potential risks associated with high levels of exertion and strain. Referral to cardiac rehab is paramount for addressing exercise-induced symptoms, providing feedback and individualized fitness needs. And arbitrary heart rate and weightlifting limits can sometimes lead to frustration or fear with unclear benefits, both during and after cardiac rehab participation. To that end, I'd like to discuss this case study. Grace is a 37-year-old woman who had her third child. She was previously healthy and a runner who has a family history of hypertension. She has no known connective tissue disorders or fibromuscular dysplasia. Since her baby was born, she's been getting very poor sleep, and it is very difficult to not lift over 20 pounds since she has a newborn who is in a car seat and a toddler who is still in diapers and needs to be lifted in and out of their car seat. I think everyone in this room who has had a child can relate to this scenario. She is under significant financial pressure as well, since her husband's business was drastically affected by COVID. They were a dual income family, but now they're down to living on EI and have little savings. Unfortunately, their extended family lives far away. So in terms of the cardiac rehab involvement for Grace, Grace attended virtual cardiac rehab because it was a challenge for her to come on site due to the travel costs and specifically the gas prices. She was able to do the virtual care program, but she still had to juggle the care of her children while she was on the call. She likes having access to the health library because she can access that on her own time in the evenings. And exercise is mainly walking in her neighborhood with her baby and her toddler and their dog. Two days per week of lightweight training with 5-pound weights. So for this lady, we prescribed 30 minutes of exercise 5 days a week and 2 non-consecutive days per week of strength training using 5 pounds and doing free weights, 10 to 15 reps, 2 to 3 sets at a RPE of 11 to 13, so it feels somewhat hard. There's little space in her life for running at the moment, and usually she would have a gym membership, but the costs are too high for her right now. She is interested in speaking to people with a similar condition, so Women at Heart for the SCAD specific population was something she was able to do. And I want to say kudos to Helen and Riza for their work there. But she couldn't make time for seeing a psychologist. So Grace's situation just shows us one of the challenges of meeting the weight recommendations because she really can't avoid lifting someone over 20 pounds. So I'm going to switch gears for a moment and talk a little bit about MINOCA. So thank you to Tammy for her earlier presentation. It was very enlightening on this subject. According to Dr. Monica Perry, who's the lead author of Chapter 6 of the Atlas that we just heard about on women's heart health, which was published in April of 2022, approximately 15% of those presenting with acute myocardial infarction have an MI with non-obstructive coronary artery disease, or MINOCA, which disproportionately affects women. The etiology of MINOCA includes stress-induced cardiomyopathy, myocarditis, underappreciated plaque rupture, as we heard from Dr. Coutinho this morning, coronary thrombosis or emboli, coronary spasm, microvascular disease, as Tammy so clearly outlined, and also spontaneous coronary artery disease. This Dutch study, we see another issue with referral and probably the barriers mentioned with the SCAD population as well. So 32% of patients participated in the cardiac rehab program, 33% were not referred, and 35% did not participate after being referred. In a study, a Chinese study of 524 participants with MINOCA, they were randomly assigned into an exercise-based cardiac rehab program versus a control group. The cardiac rehab group followed a home-based exercise program 3 times a week during the 3 years of moderate continuous training. They were working at 65 to 75% of peak heart rate on a bicycle or treadmill. After 1 year of follow-up, the quality of life survey that was used, the SF36 survey, showed the apparent improvements in mean physical health score in the cardiac rehab group compared to the control. A multivariate Cox regression analysis indicated that exercise-based cardiac rehab was associated with a significant reduction in all-cause mortality. The conclusion of this study was that a long-term exercise-based cardiac rehab program was associated with superior physical health and significant reduction in all-cause mortality and MACE in patients with MINOCA. For treatment of MI or MINOCA or ACS, I should say, we take a similar approach. We follow the American College of Sports Medicine guidelines for exercise post-MI. We currently assess the cardiac and other medical history. We review the social determinants of health, as were mentioned by Amy Johnston so well. We talk about the risk factors. We discuss current, past, and future exercise. We talk about orthopedic concerns, available equipment, and barriers. We generally recommend walking within the first 1 to 2 weeks of the event. And then we follow the FIT formula as identified here, but the guidelines have changed in 2022. So our previous guidelines would say 5 to 7 times a week, and the new guidelines say 3 to 5 times per week. The intensity is 40 to 80% of heart rate reserve if a stress test is used or ordered, and rest plus 20 to 40 beats per minute if the patient is on a beta blocker and we didn't use a stress test. We also use the talk test and the rating of perceived exertion to guide the intensity of the exercise. The time that we recommend has now changed as well in the 2022 guidelines. We now say 20 to 60 minutes as opposed to 30 to 60. And at the end of the day, sitting is the new smoking, and any exercise is better than none. The type depends on the interests and available equipment that the patient has. And in Ottawa, of course, it also depends on the time of year. We need to focus on adjusting for extremes in temperature and periodizing the year. My colleague, Mary Elena Keast, who has been at the Heart Institute for 38 years, would say that the science of exercise is easy, but the optimal balanced exercise program that encourages continued motivation, that's the art. What do we recommend for strength training? Strength training post-MI, we usually focus on at least 1 month or 4 weeks of aerobic exercise before adding in strength exercise. We recommend 2 to 3 days a week of non-consecutive strength training, generally at 10 to 15 repetitions, so a high number of repetitions where it feels light to somewhat hard. We recommend 1 to 3 sets, 8 to 10 exercises focusing on the major muscle groups. And as far as what equipment is used, it really depends on what's safe and comfortable for that person. We can use free weights, machine weights, dynabands, core strengthening, whatever really is available. The stretching guidelines are, as recommended by ACSM, are greater than 2 to 3 days a week, with daily being most effective. We recommend a total of about 1 minute of stretch per muscle group, so we can divide that up in different ways. We recommend static and dynamic stretches, focusing on all the major muscle groups, and the optimal time to stretch is after exercise, but any time is really good. So in conclusion, I just want to say that further research is needed, but we have learned a lot about SCAD in the last 5 years, and it appears that cardiac rehab is beneficial in the SCAD population. We now have much clearer guidelines for exercise participation and prescription. The barriers to participate continue to be an issue, and more research is needed in the MINOCA population. And we hope that this presentation will be useful to you as a healthcare provider or a person accessing the healthcare system. And finally, I just want to mention that the path forward involves participation in research, partnerships, national and international cooperation, and education of patients, healthcare providers, and medical practitioners. And we look forward to new innovations and increased treatment options. I'm very excited about the work being done by the Canadian Women's Heart Health Centre and the Canadian Women's Alliance. Thank you for your attention and your time. Sandra, do you have any questions at your end?
Thank you so much, Lenny. None at the moment, so you can go ahead with your in-person questions.
Hi, Lenny. Thanks for the talk. Always very informative. So as you know, we deal with a lot of SCAD patients in cardiac rehab. When we started, we didn't even know what SCAD was a few decades ago. And as you said, the science is evolving. We take a lot of our guidance from the West Coast, from Jacqueline Saw's group. We're still very conservative, very restrictive in our exercise guidelines, and rightfully so. What do we do with patients who want to go beyond that? And you said that this 37-year-old mother of 3 had no time for running. But if she had expressed a desire to return to running or to go beyond, say, 20 pounds for weight training, how do we deal with that?
That's a great question. Thanks, Mark. If she had expressed an interest in running, we could use our current guidelines, which are to use age predicted calculations. So 220 minus her age times 0.7. The Gellish formula is what we're using currently to get a age predicted heart rate maximum. And then we usually deduct about 20 to 30 beats per minute from that to account for the beta blocker if the patient's on the beta blocker. And then we can prescribe exercise from there. So some women with SCAD still have chest discomfort, so that often is limiting, and there's a lot of fear around pushing themselves beyond that early, beyond where they should. So usually in the early period of the SCAD, we tend to be very conservative, but then as time goes on, as the healing potentially would happen in the first 3-4 months, we may be able to kind of reintroduce running and gradually build up the intensity there. In terms of the weight training limit, I find it frustrating myself. I know, having been a mother of twins, as Bonnie is, 2 kids in 2 car seats is a lot of weight. And luckily they get gradually bigger, so you get gradually stronger. So it's overload, which is good, but it is a lot of weight and it is hard to avoid lifting sometimes more than 20 pounds. So that is a frustration, particularly with the postpartum group that we see who are SCAD patients. Carrie.
This is a question about, you talked about motivation. I loved, whose quote? Oh, Mary Elena's quote.
Mary Elena's quote.
So yeah, motivation is the challenge. And so we'll have some patients who are motivated and some where we really struggle to find that motivation. This question's around the MINOCA patients, but maybe more so INOCA. So our patients who have less than 30% obstruction, they sort of feel like get a different message about the secondary prevention or the prevention, I guess, that they could be doing. What strategies do you use for patients who feel like I don't have severe disease? I haven't really been given the same message as someone who's had an MI, for example, to sort of help motivate them to make some of the changes or follow the recommendations that we do for patients who maybe have been through the full, procedure and so on.
Yeah, thank you. So yeah, motivation is a subject I really love talking about it. I could go on for a long time about motivation, but I think what we now understand about exercise motivation is that people kind of fall into different categories, right? There's the individual exercise who's going to do it no matter what on their own. There is the person who needs to disguise their exercise as a game. There is the person who's a really social exerciser who needs to have a partner or a buddy. You need to kind of explore with that person what they've had success with in the past, what they've enjoyed doing in the past, and then try to build from there on those things that have worked well for them in the past. So that's one thing I think is very important to kind of explore with your patient, what their interests are and where they want to go with their exercise. In cardiac rehab, you have the pleasure of working with people who are just wanting to be able to play with their grandkids, and also people who are looking to do the Rideau Lakes tour, or who want to, climb Kilimanjaro, or they have very lofty goals. So I think it's really important to individualize your assessment and make sure you understand exactly what this person is trying to get back to in order to really tailor your intervention to best meet their needs.
Thanks, Lenny. I do have a question from online here. There was just a comment about patients post-SCAD and having chest pain. And the question is about, it says here, the post-SCAD chest pain, it is often passed as coronary artery spasm with inadequate testing to confirm diagnosis. It asks, do you test for vasospastic angina or microvascular angina? Not sure if that's something you can comment on.
I think it would be wonderful if we had those kinds of tests, but I'm a physio. I only can prescribe a stress test, which is a very gross assessment. So Dr. Coutinho would be better perhaps to answer that question in terms of how to best address assessing angina.
Thanks, Lenny.
Thanks.
Hey, so I hope everyone has enjoyed the day today. I think it's been fantastic. I had one of the in-person participants actually comment to me and say, Bonnie, you could really keep people here for days talking about this. I promise I won't, but it's tempting. So thank you very much, everyone, for taking the time out to attend and listen to the sessions. We have recorded them because we're going to be using them for ongoing learning with our staff, and we hope that you can do the same with yours, along with all the other resources that were discussed today. A very special thank you to the presenters, and especially Rachel and Tammy for taking time out of their day to come and share their very special patient lived experiences with us that really hits home as to why we are doing this very, very important work. So thank you very much from the bottom of our hearts. I also want to mention a very special thank yous as well to some folks who really made this day possible. They put a tremendous amount of work into it. So Nazli Parast, who you've seen running about most of the day and presented, she's the special nurse in the Women's Heart Health Clinic and really does a tremendous amount of work in her work time and also on her home time to advocate for women's heart health. So thank you. To Stephanie LeBlanc and Sandra Wong, our clinical regional nurse educators. They're really putting all the details together and thinking of everything. So thank you very much. You're both lots of fun to work with too. To Andrew Brown and Michael Nugent from IT, who sit at the back and just make everything look easy, especially for people who, like me, who aren't particularly IT knowledgeable. So thank you very much. And also to Melissa Harrington, our administrative assistant extraordinaire from our division. So thank you for everything. And now, Sandra, I think you do have some winners to draw, I hope.
Yep, that's correct. I'm just going to quickly share my screen here. So thanks everyone for participating in our survey and quiz. I'm going to share my screen.
Sandra, just one more thought I wanted to just add in. Just because Bonnie thanked everybody, but she was the one who initiated this whole event. So I just wanted to say thank you. We wouldn't be able to have done that without you. Thank you.
My pleasure. Thank you.